I would like to tell everybody that we in time and we don't want to cross over and loss of the time. So please request 1 minute we are going to talk about, but that will also we'll have to do after the session is over for discussion. Thank you.
As the life is moving fast, we also need to move fast and upgrade ourselves. This presentation is one of them. We are doing all your fast and functional eyelid. That is near normal to what God has given to us. This is the anatomy of the eye, the 7 layers of the eye, the skin, the submucous muscles, alveolar fibrous muscles, conjunctiva. These are the cases in which we do all new fully functional eyelid. Usually, people used to prefer cutler beer eye reconstruction, that is, using the lower eyelid and the upper eyelid after removing the growth. And now we are doing total removal and fast functioning. This is how we remove the whole growth. Because we are fixing the growth with the sutures and removing with the RF cautery. RF cautery is which cuts and coagulates at the same time. We have to remove 2 millimeters away from the inward margin to get the normal margin. Then we take the buccal mucosa. Because we need a bigger growth, we are taking buccal mucosa. This is how we remove the buccal mucosa from the mouth. This is how we do the suturing for the same after removal of the buccal mucosa from the mouth. This is how we place the remove buccal mucosa over the proposed eyelid. We'll take the proper measurement for proper suturing and fixation. If the graft for buccal mucosa is small, then we take it from the lip like this. Then we go for the ear cartilage, which represents the tarsal plate. This is the incision over the ear we put it. And this is how it is removed from the ear. This is the animated. This is a post-operative 10 days picture of the patient. And this is fast and fully functional eyelid.
Let it.
Videos. आँख खोलो मत
Protruding or unusually like protruding or
This
unusually
is the animated film taken for ear cartilage removal.
surgeon carefully adjusts the ear's cartilage to create a more balanced, natural appearance. The surgery is typically done under local anesthesia.
The ear cartilage is required for tarsal plate representation and contour of the eyelid.
Otoplasty can be performed.
This is the 10th post-operative day of the patient. Wait, video. This is after 10 days, you see the left eye moves and closes the eyes. See, there is no exposure keratitis and no visual function is compromised. You can see how the eye closes properly.
बंद करो आँख खोलो बंद करो बंद करो
Our respected sir and Ruchi madam had told me, "Okay, why don't you take the frontal flap?" So this is how the frontal flap is taken. And this is the if you take a bigger flap, so this is how the trimming if you take a bigger flaps like this. This is 2/3 of the lid is constructed. Cheek flap is always good so that the proper healing and proper angulation at the medial canthus is achieved. You can see the 2/3 closure.
बंद करो
You see proper closure and all is important.
Can you show
These are the references for that. Thank you.
It was a very good presentation with animation. I think the presentation was very good. And we now go on to Dr. Sapan Shah, who is going to speak on the coloboma leads. Presentation will be presented to Dr. Ashish, please. Yeah.
So, my topic today is So, there is a whole patient of 2.5 months age between the patient mom, there is a small image which goes up like this, and then will be a coloboma. So, my background is good. They are associated with the coloboma, and it's difficult to decide whether to go operate first or to solve coloboma. And just down here, wait for some time, and we So, check for the cornea, and the cornea is a normal. So, we decided to first settle down with the thank you, for giving while sharing the coloboma. We should claim that clear and possibly on the other side. We finally decided to go to the first, followed by coloboma. So actually we started with women. We were intra-regional, we were in the organization. So there was a 40 million intra-regional, one allowed students given to the inside of Colombo. Even a close follow-up, every 21 days we took a follow-up. And after the first injection, we see the difference. The eye is totally formed. It's totally formed. There is nothing you can see. The Colombo is totally formed. The eye is totally formed without any operation or anything. The local measurement is utilized and the eye is totally formed. In this picture, you can see there was a Colombo, but here the Colombo is totally formed. In the second picture, after the second dose, you can see. So why did it happen? And why Colombo was there and the image of one Colombo also on? So the mechanism is did I generate tissue? No, not. So tissue was typically present at the time of patient call, but once the mechanism happened, that forms the pressure over the arteries on the very thin artery tissue. That leads to a tissue necrosis and tissue necrosis and ulceration. That leads to tissue rupture, that leads to a Colombo. But what is the this measure reduce? It leads to decrease in the angiogenesis, decrease the lesion volume. Tissue strength is reduced and leads to iron margin deapproximate and then all of the blue. So, what is the correct management algorithm? If the cornea, you will check on the cornea. If the cornea is safe, wait for the time. Treat the measurement first, give the steroids, give the proper amount, and wait for the measurement to resolve. GSS the delete margin. Only if defect.
Oh, thank you. This is a very complicated stage. It is very, very difficult to have the things. How do you take the sutures? What is the material you take with the sutures? Just an injection. Okay. Okay. There are so many other coloboma also, so we have to take care of all the other things and these things. Right. Okay. Right. Okay, thank you very much, Sharukhkhan.
When do you refer the second dose?
After 21 days.
Why don't you prefer bleomycin?
When you are well taken care of anything else, and how many days you will try to give bleomycin. It will be different with the results.
Yeah, very
I
nice.
think
Kids.
we have got enough time and we can have the discussion. Dr. Shreya is not here in the hall, and I would like to present the memento to Dr. Sapan Shah. Nice. And we now go on to Dr. Maya Harda. She is a very nice presentation, and she is coming from Jaipur for her presentation, and we have seen her. She is very, I think she is working in the associate professor in Jaipur, and we are having her lecture.
Thank you, sir.
On the things, we are definitely welcome her to Ahmedabad city from Jaipur.
Thank you so much, Dr. Nitin, sir. It's a pleasure to be here at Ahmedabad. I'm thankful to Dr. Jagdish Rana, AGOS, Dr. Sandeep for having me here. So I was supposed to be speaking for general ophthalmologist and was given a topic of watering. That is a very common topic which we all encounter. So whenever you come across a patient of watering, we have to make sure whether it is epiphora or whether it is hyperlacrimation. So the difference is epiphora means there is inadequate drainage of tears, whereas hyperlacrimation is over secretion of tears. So you have to first rule out any sort of ocular surface condition that is leading to reflex lacrimation, do a thorough examination to rule out any lid margin abnormalities, or then check for epiphora. So it's very important to take a thorough history, whether the watering is continuous or intermittent, and also look for any involutional changes in the eyelid, because the functional epiphora in old age is very common because of the laxity of the eyelid, which leads to non-functioning of the orbicularis pump, which causes pumping of the tears into the sac. So that is also a very common cause when there is no obstruction, but there is an epiphora. What are the common causes of obstruction? We can have an obstruction at the level of punctum, at the level of canaliculus, or at the level of nasolacrimal duct. So in adults, we have the obstruction at the level of sac and NLD junction, whereas in children, it's at the level of Hasner's wall. When you are looking at a child of epiphora, you can see that there is an increased height of tear meniscus, the lashes are matted, there is often a discharge which is present, and sometimes there is a swelling over the sac area, and this is usually seen in the cases of acute acrocystitis. Sometimes there can be associated fistula. You have to rule out whether it's a congenital fistula or an acquired fistula post-rupture of the lacrimal abscess. Sometimes the term is amniocystocele because it's an amniotic fluid which gets collected into any lid margin abnormalities first. You have to look for the position of canthus, if there is any traumatic telecanthus. Do a slit lamp examination to rule out any trichiatic, metaplastic lashes, punctal stenosis, or pouting punctum. So pouting punctum is one condition in which there is no NLDO, but it is canaliculitis, which is causing this watering and discharge. And what you have to do is just dilate the punctum and express out all the surface granules which are causing obstruction in that canaliculus, and the symptoms will be relieved. So this is often misdiagnosed as nasolacrimal duct obstruction, and DCR is advised in such cases, but it's usually a canaliculitis which is causing trouble to the patient. Then punctal stenosis is one condition where punctal snip surgery was advocated earlier, and where you need to cut the punctum and then put the mini monoca stent. But now what we do in our practice routinely is just dilate the punctum, because most often these kind of blocks are membranous block. You follow the orifices of meibomian gland, locate the lacrimal papilla, and then dilate the punctum with a sharp needle ship punctum dilator, and you will be able to open up the punctum. And once you are sure that the punctum is open, just check the patency of the system with the probe and the syringing. And after that, you can put the mini monoca or the monocanalicular stent. So this is a self-retaining monocanalicular stent. This we are putting because we don't want the punctum to get stenosed or fibrosed again. So this will be inserted into the punctum, and we can take usually 0 to 00 size. So yes, I'll just conclude. Conjunctival DCR is the condition
about the retinoblastoma. About the retinoblastoma.
Excuse me, Dr. Maya, you will be felicitated in the evening because you are a national faculty. Thank you.
Next, Dr. Shalin Shah, be ready for the presentation.
Thank you, all of the Ophthalmic Society for the opportunity. So today I will be discussing on the retinoblastoma, recently management.
Jignesh, so many years, but it has been presented to Dr. Shalin Shah. Dr. Shalin Shah, please come.
Presentation, or do we save these eyes? So let's see them one by one. So when it is possible to salvage, when the nodes are not involved, when there is no metastasis, that's a negative.
The frontalis muscle action. Recently, as I myself have observed, that the material of the silicone sling has been degrading since some years, and also the quality which was previously being used has been not up to the mark. So many a times we see recurrence or slippages. There are many cases where there is extrusion of the sling, infection post-surgery, brow scars in cases where the skin is not that adequately thick, the lag of ophthalmos and the contour of the eyelid that is not very good, and exposure which can be there in this case also, the frontalis flap also, but it is more in cases of the sling surgery. So what is the frontalis flap? As you all know that the frontalis muscle generally attaches onto the supraorbital margin. So what we do here is we advance this flap from the supraorbital margin, we separate it from the periosteum, and we try to attach it to the tarsal plate, either using the levator muscle or levator aponeurosis in between, or just directly attaching it to the tarsal plate. So it produces more of a physiological blink rather than a mechanical secondary blink, which is in case of a silicone surgery. So indications, again, severe ptosis where poor LPS function is there. Adequate Bell's phenomena should be there, and especially used in cases where revision and the sling surgery has failed or recurrence has happened secondary to any other causes. Contraindication in such cases would be absent or poor frontalis action, forehead scarring due to previous surgery, progressive myopathies such as myasthenia or CPOE, and poor ocular surface and poor Bell's phenomena. Difference between frontalis flap and sling surgery: one is dynamic mechanism and one is a static lift secondary to the sling. A material uses autologous muscle, other one has a silicone or a fascia. Now, blink is more physiological in case of a frontalis, lag of ophthalmos is less, and revision is easier in case of the sling surgery. So basically these are the surgical steps. We mark the eyelid crease, we open up, we go superior. I'll show you the video how we do it. And after the skin incision, the dissection is done superiorly between the orbicularis and the orbital septum, rectangular, or a direct frontalis muscle flap is made, which is then anchored to the tarsal plate using a bite from the LPS or without it, depending on how much the correction is required. So this is how we do it. I'll show you a short video. I'll complete as soon as possible. So this is where we are exposing the levator aponeurosis. And then we go superiorly and we do a dissection, a blunt dissection or a sharp dissection between the orbicularis and the orbital septum. Then we separate the frontalis muscle from the inferior periosteum, and superiorly we do a dissection. We do a partial dissection, keeping in mind that there will be small capillaries and vessels which are there. So again, I use a modified technique. I don't make a rectangular flap because it gives a proper elevation post-surgery. So after the frontalis flap is properly fashioned, then we pass a non-absorbable Prolene 60 suture. We pass it through the levator muscle. In this case, the elevation was more required, so I took the levator in the suture. Again, we do horizontal mattress suture and pass it through the frontalis muscle, and you can see how the eyelid elevation is achieved. So such kind of the suture can be taken on the lateral aspect, one on the lateral and one on the medial aspect. And the elevation would be more physiological, almost similar to the levator muscle, levator dissection. So this is how a post-op, we can see how much elevation is achieved. Lag of ophthalmos initially will be there, but again after 15 or 20 days it will be much better. So this was the case. Immediately after the post-op, you can see how the result was seen. So flap design, basically width is 15 to 20 mm, and the length is around 6 to 10 mm depending, and I already told you how much dissection we do in 2 planes. Complications may be under correction, asymmetry, forehead contour irregularity, and brow descent. Brow descent is where sometimes beneficial in cases where frontalis overaction is there. So these are 2 studies where I compared, in one of the studies 92% of successful correction was there by Quing et al. And in another one, the 2 flap comparisons were there. One was the conventional and one was the modified. Modified is the one which we did. And this is the rectangular flap which generally was fashioned since few years. But a proper elevation is achieved in cases where the modified flap was placed. 90% of surgeries were successful in those cases. So thank you all for patient listening. I'll open the stage for questions.
Dr. Khetwani. Now we have been, whenever there is a conference, this topic is discussed, and a lot of people have started doing this type of surgery, and the results are much better. Our chair, Madam Rekhaben, is here, and I would request her to come the presentation to Dr. Khetwani, please. After a very session at the end, she is coming. Sandeep is, I think, giving some time for this session, and we would like to have a photograph of all the speakers. Sorry. Yeah, please.
Aí, vamos sair aqui.
It goes on to next topic of the ocular trauma. Please, the chairperson should be here. Sandeep, I think, will take care of it.
Good morning, everyone. So here we are going to start Ocular Trauma Symposium. And I would like to invite Dr. Mehul Shah, sir, for his keynote address. Dr. Mehul Shah is a prominent retina surgeon as well as cataract surgeon. He is my mentor, and he is the one due to whom, what I am right now. So, Dr. Mehul Shah, sir.
बस आणि परत मुकीत होतं डायरेक्ट टाइप से सर टाइप सी अच्छा ओके रवा सर चार्जिंग लगाओ जरूर outset by the time it is being arranged. Thank you, Parth, and thank you, Jagdish Bhai, for allowing me to be here, and thank you for Parth, thank you for your kind words. Yeah. Thank you very much. Please, may I start? Sure. This is dedicated to our mentor and chief, Dr. S.S. Badrinath. His birthday happened to be here in this month. So he is no more there with us. Just I would like to highlight that we are working in the Temple of Eye at this geographical location, covering 17 districts of 3 states. Our hospital is being inaugurated by our Honorable Chief Minister at that time, Mr. Narendra Modi. These are the areas of working, and we are working for all periphery, and this is the journey of our Drashti Netralaya Hospital. So today I will be talking about current trends in ocular trauma. We work for the ocular trauma since 1992, and we have developed and designed many more systems and contributed to the scientific contents all across the globe. So these are the number, approximately 50,000 cases we have seen, and number of surgeries of ocular trauma we performed approximately 8,000. And this is the contribution. We published 70 peer-reviewed articles in field of ocular trauma, written 10 chapters, 2 books, and all scientific research is being done with various groups across the globe, like APOTS, iGates, we are part of all this. It is important cause of monocular blindness. We know all this because of comorbidities, and there is the social and economical burden. This was the old BTTS classification. We published and validated the newer and updated classification, which has been published. We worked for the epidemiology. We worked as an independent center, and we worked as a group with the iGates, and published many articles for the epidemiology in Asia Pacific region. But there are many data available all across the country, north, south, west, central. But we tried to study. We collected all data and studied the 30,000 articles, and we did the meta-analysis and prevalence of eye injury in India. This is the average data we calculated. These are some of the manifestations of closed globe injuries. I am not going into details. And this data has been published in IGO. This data was worth 12,000 patients. And these are the manifestations of open globe injuries. I think everybody amongst us is seeing some or other form of trauma every day in day-to-day working places. Some people are treating, some people may refer the cases. So these are zone 1, 2 and 3 injury, and these are the innovative methods of wound repair which has been published in IJO videos. At the instances, we see many cases, infected, non-infected. There are different type of foreign body. This is the case where we have multiple foreign bodies. At least 4 foreign bodies we found. With the endophthalmitis, patient is managed. We salvage the eyeball and salvage the vision at least up to finger counting. One more. We performed the vitrectomy, did the keratoplasty of the patient, and patient had different type of traumatic cataracts. Everybody is coming across. We are the first in the globe who classified the traumatic cataracts and published in BJO. This has been published in 2011, and so according to that, the different surgical techniques were recommended. This IOFB with the cytosis bulbi. Again, we published this same thing in Controversies of Traumatic Cataract Classifications, and effect of time interval for intervention has been discussed with EJO. And traumatic vitreous hemorrhage, as we know, traumatic vitreous hemorrhage with open globe and closed globe injury is very common, and the outcomes are better, very good. Traumatic retinal detachment has got different configuration, and different type of retinal lesions can be seen with the closed globe and open globe injuries. And PVR is very bad with current scenario forward. Bimanual dissection done. Using PFCL. We push the retina back, and just followed by the laser and oil, patient had a finger counting vision. This is the traumatic endophthalmitis which was presented with no perception of light. Following vitrectomy, we completed the vitrectomy, and after 1 month, we did the scleral tuck IOL. So there is a study we published in the Journal of Retina and Vitreous with visual outcome of severely traumatized eye with no perception of light. 29% of patient has recovered at least some vision following management. The retained wooden foreign bodies that we all are coming across, these are the foreign body. This is the big foreign body. We can see this foreign body is seen. This patient, at least we could salvage the globe. We could not gain any vision. We devised the specific innovative anesthesia technique to work in all areas, combining the regional and general anesthesia using the sevoflurane without any complication and smooth recovery following anesthesia. Traumatic ectopia lentis, I think we all are aware about that. And there are many methods to manage that. Rehabilitation is done with the lenses, contact lenses, and AC lenses, iris claw anterior and iris claw posterior lenses. But important is, like Parth and I has designed this lens as a scleral tuck lens, and which has been published in many journals now. And we have good experience. This is one study is published in IJ also. And that same has been done with the ectopia lentis cases. The comparative study of open and closed globe injury in adult as well as pediatric population has been published in Graphe Archives and IJO. And wooden stick is one of the most common object of the it makes for 57% of the cases. But by traditional teaching, if you have a wooden stick injury, there will be vegetative injury and there will be infection. Contrast to this, we studied this. Out of our 57%, we did not find even single infection with the vegetative injuries. Because of Alosia nilotica is one of the reasons. The bubble tree, which is more common for the injuries in rural India, having the antifungal and antibacterial properties, which protects the eye from the infection, rather than metal and stone injuries caused more sight loss. So these are the factors affecting, not improving the vision. Corneal opacities are leading, then recurrent inflammation and posterior segment pathology in 1.9% cases. Major factors affecting the non-improvement is amblyopia, astigmatism, and after cataract. So amblyopia management, there are newer hand-eye coordination with perceptual learning is a newer technique. Now it is very important to predict the ocular trauma score. We have ocular trauma score, pediatric ocular trauma score, and toddler ocular trauma score. These are comparative study, and these are the method. How do we calculate? We validated the ocular trauma score, which has been published in Journal Cataract Refractive Surgery and Journal of Ophthalmology. And we modified that with the pediatric ophthalmology trauma score as well as toddler ocular trauma score between 0 to 6. This has been published in Graphes and this has been published in IJO. I'll sum up. Yeah, interesting cases. This is the trauma and extra strabismus. This is the algorithm developed by our own institution. Dr. Rea developed this. So these are the 10 reasons how the strabismus is present in the ocular trauma, and we can treat all. We published that article also, post-trauma kinetic horn. Chemical burns being treated with AMG, MMG. And kind of reference treated post-traumatosis. Also, there are different algorithms and management system for the post-trauma cases, outcome of LPS surgeries, Fasanella servat tarsorrhaphy, and outcome of cicatricial ptosis with the skin graft. Legophthalmus is lacrimal injuries. There are different type of lacrimal injuries which has been treated, and there are different consequences. A canalicular injury also has been discussed with the innovative product which is there in the market now. The Teflon sleeve, and this is the modified pigtail which we developed and which is available in the market now. This also has been published. Post-trauma DCR has been done, large number of cases, and traumatic telecanthus has been treated. Conjunctival DCR, endoscopic guided, orbital trauma with the orbital fractures to tackle the post-repair orbital fracture, and orbital foreign bodies has been. This is the interesting case of the carotid cavernous fistula. We can see this pulsation. This ligation, vessel ligation has been done, and patient has been treated with the. Then animal-inflicted injury, dog bites have been very common. These dog bites have been treated. Canalicular tear with LPS rupture. You can see this is the end result, and there are no legophthalmus. Most important thing, we have published that there are the ocular trauma centers are less accessible for the people, and enough awareness is not there. So for that we tried to collect the data from our own country as an ocular trauma registry from Ocular Trauma Society of India, and from airports. I get study with the AI program is there, which is collecting the data, I think, across the 40 centers of the world. These are the awareness has been generated. Public education is done, but advocacy is an important part that we have been doing this since 2 years. We had a meeting with the National Human Rights Commission, taking the cause up with. We are talking about the 17 ministries, and we had a meeting in the center. And there is a legal step. There is a PIL right now in Delhi High Court for prevention of the ocular trauma for certain type of firecrackers. But it's long battle to go. We all will have to participate, and it's the call for an action. For everybody will have to get together and work to prevent the blindness for ocular trauma. Save life, save vision, then cosmetic correction. Thank you. Thank you very much.
Thank you so much, sir, for being an ocular trauma surgeon. You have to be an oculoplasty surgeon, cornea surgeon, a cataract surgeon, and a retina surgeon. And thank you so much, sir, for teaching us all. So I would like to invite Dr. Gunjan for the next presentation. Dr. Ruchi Kabra. Yeah.
Good morning, everyone. Thank you so much, EKA team, for this wonderful opportunity. I'm Dr. Gunjan, and I will be presenting two interesting cases for chemical injury and how to be applied their connection. So, we all know that chemical burns are potentially negative ocular injuries, and this is a true ocular necessity. 80% of ocular chemical burns are due to industrial or occupational exposure, and tuna is very much common in India. Emergency management, if appropriately done, is one of the important factors in determining initial prognosis of the long run. On the practical severity basis, these are three events which may influence the final visual outcome. First of all, is ocular surface injury, then corneal spondylometallus injury, and then inflammation. And we have to address all three components in the management. The clinical cause of ocular chemical injury can be divided into following four phases. First is immediate, then acute, ameliorative, and late reparative. The immediate phase begins the moment the chemical agent comes in contact with the ocular surface. The key elements for determining the extent of chemical ocular injury and prognosis are the total area of forehead epithelial defect, which we have to assess at the time of presentation with fluorescence staining. The area of conjunctival epithelial defects, surface inflammation, the number of clock hours or degrees of pimple branching, and the area of density of corneal opacification, evidence of increase in intraocular pressure on presentation, loss of lens clarity and clarity. These last four points, they will indicate the level of intraocular penetration of the chemical agent. The first and foremost aim is to get the surface epithelialized. If the surface is epithelialized, it means the eye is safe. Then for the visual rehabilitation, next steps can be taken. And it is very much important to classify chemical injury, understand the disease process, to assess the prognosis, and documentation is very much important as well as the medical aspect and to planning of secondary stage surgery. There are two classifications. First is overall, which is prognosticated the chemical injury depending upon the corneal and conjunctival environment. Second is dual classification, which is graded the chemical injuries in 4 to 6 levels, depending upon the limbus environment and conjunctival environment. So we will see one by one in the following cases. This diagram shows how to estimate the conjunctival injury. In the management part, initial evaluation and immediate treatment involves thorough history, examination, thorough wash is to be done, and removal of anxiety agent. This is very much important and the foremost important point in management. And then always do the fluorescence staining, and while doing the wash, double immersion is very much important. And as I have already said, documentation is very much important on each and every follow-up. In the acute phase, treatment aims at re-establishment of the corneal epithelium, maintain the balance between collagen synthesis and collagenolisis, and minimizing the number of adverse effects. So this is a grade 1 injury in which 0 block hours of members is involved and only corneal epithelium is degraded. This patient has accidentally put nasal eye drops in the eyes. This is the right eye, and this is the left eye. And this has been very much conservative management. This is another patient of aggravated test. As we can see that the nimbus is there, and conservative management has worked very well. This is another patient follow-up color, and on the tertiary examination, we can look that staining is negative. But when we stain it, it is very much important to always stain it because we may miss the finding. So this was staining was positive, and with medical condition, it was also very good. Then in the grade 2, there is 3 kilograms of inverse involvement and 30% conjunctival. This patient has accidental fall of liquid metal. And as we can see, the epithelial defect margins are very dark, and that the epithelium is denied that it won't heal on its own. So surgical management is required in these types of patients. It was like 3 to 4 weeks old injury. So I was degraded and then tinoplasty along with the amniotic membrane and acidotic was done. And in the final we can see in inferior conjunctivalization and the surface is very well epithelialized. With this type of presentation, he has a 6-12 vision and visualization was clear. So no further surgical intervention was required. But if patient was cosmetic requirement or if it is bothering so much, then surgical correction can be considered in this patient. This is another patient of fall of molten metal. In the cases where hot molten metal, as patient has suffered the trauma with hot molten metal, it may look like grade 2 or grade 3 injury, but most of the patient, the surgical intervention is required. It presents here. This is another case of 5-grade injury. This is now grade 3 injury where 3 to 6 kilograms of involvement and 30% involvement. This patient is boy for liquid tumor in his eyes from the back. And as we can see, epithelial margins are low, so the gradient energy and that's what this is wonderful outcome. With the history of all chemical and the inferior quadrant was involved. With medical condition, involvement. This patient was 32-year-old female with history of accidental fall of cleaner in right side. Presented as 7 days. Second image shows 2 days of treatment in the form of topical steroids. In this particular case, we can see the pattern of how the normally epithelium heals, and in the end, teardrop pattern. In the inferior picture, we can see the teardrop pattern, which shows how the epithelium normally heals naturally. This is another patient, history of fall of toilet cleaner, 25-year-old pregnant female, but she is for the treatment. She responded. This is a grade 5 injury, 20% involvement and 75 to 100% conjunctival involvement. Fall of 2-year-old. Tuna injuries, most tuna is almost always embedded in the superior cornea. So, if we just is not sufficient, we have to double layer and check for tuna particles and do the surgical management as they can required. So this is our tuna requirement, tuna gradient and ENG and liver transplantation was done later. This is another patient of grade 5 injury, fall of toilet cleaner. This is another case of accidental fall of ammonia. Another tuna injury. In this particular case, after tuna removal, gradient and ENG. This 23-year-old female section behind by Darcy clinic, right side 5 chemical injury and left side grade 1 chemical injury was there. And the surgical intervention was there, and after 3 months, stable success was made. Up to 6 months, this was the final. Ministry injury along the patient may be admitted along with body burns. So it is very much important to take your skin and everything, your face and everything pertains to the general wall, and then assess the injury. This was a grade 6 injury. This particular patient has grade 6, both sides grade 6 injury. Total inverse and total conjunctival involvement. And that's why the ENG was done for both sides. And after 3 months, success was taken. This is another case of grade 6 injury. Accidental fall of hot chemical, 40% body burn on the torso, crystallized. That's why the ENG was done on the 4th day. And this was the final outcome. As we can slit surgery can be considered later. This is another case follow complete limbal surgery after 1 month. Total lobe epithelial defect, limbal and organ system defects common. Representation. So, timing is very much crucial in the management of chemical injuries. Even if it is grade 6, but timely level, timely management can save the eye and lifelong economy for the patient. This patient, he had this chemical injury while doing science experiment. This is another case injury during capillary glass presented after 25 days. This in the right you can see that chemical it was embedded for the whole 25 days in the eye. In chemical injuries, white eye is worse than red eye. And few more of such cases, in the initial presentation within 1 to 2 hours patient present, staining may not be very prominent, but this epithelial edema can be there. And after on the second day, we can see this patient was taking the stain, and the superior stage was negative. It means that epithelium was started slightly from the superior limbus, and after 15 days, the surface was epithelialized very late. Another case, and this had scleroderma. My examination became tuna chunk was there, and the pregnant lady also was there, and the 3-month postop was there. This is another tuna is 1 month old, and we had retained tuna particles with BCL, 5-year-old boy. The total epithelium loss was there. Tuna removal ANG was there, and after 3 months total epithelium was there. Slit surgery was done, and it is the 3-month postop.
Dr. Kunjan, please summarize.
This is a grading system, and the main question is how we manage patient in the acute state will decide how the patient will be seen for his life. And irrigate, thorough removal of cication is very necessary. Topical steroid we should not miss. Prevent exposure to BCL or bad arso. Fluorescent staining, do not forget about it. And documentation is very much. Thank you so much.
It was great presentation, Dr. Kunjan. Any questions from audience?
Gunjan, excellent presentation and nice documentation of all the cases. There are a few things I would like to emphasize. You should clarify which fluid should be used, because a lot of times general practitioners, they know it has to be irrigated, but don't know what fluid should be used. Second, you presented a case of 1 month delayed presentation. Such patients, I think you can combine with slit also, because by 4 weeks, almost have all the limbal cells, they have got significant damage. So that can help you. And third, what is the cutoff? When would you like to do AMG? As soon as you see the patient, or you wait, and what is your protocol for that? And when you showed one case where it was the bedside AMG, and you can elaborate that also, how we do bedside, because that is a very critical technique and everybody should know, because for SJS patient also, you have to do bedside AMG. So that is eye saving procedure. You can just emphasize on that. Thank you.
So, when the patient he comes within a few hours of initial days of the injury, I will irrigate and I will start the treatment, topical treatment, of fevers, cycloplegic, vitamin C, doxycycline. And if it is not showing any signs of healing, then I will consider the AMG. And I will also consider the points that whether the patient is coming from very far distance, if he can come to follow frequently or not, because follow is also very much necessary. And for the bedside AMG, these patients, they get grade 6 injury. I started topical steroid, waited for around 3 to 7 days. There was no healing in the epithelial defect, so I did AMG. For AMG, I used private reserved AMG, and Encertain I used Encertain, and it is very much convenient to use Encertain, and I've done 4 or 5 cases with the same way. And I can show you the pictures probably someday. If anyone wants to see, then I can share the presentation with them. But it is very much convenient, even for Stephen Johnson syndrome, acute SS, Encertain is very much.
Very Very nice. Thank you.
Yes. Dr. Ruchi? So Dr. Ruchi is going to present on canalicular tear repair.
Hello, a very good morning. I'm Dr. Ruchi. Thank you, AGS, for giving me an opportunity to speak on canalicular lacerations. So the aim of this presentation would basically be to talk about the risk factors and pathogenesis in canalicular injury, to see how to examine and diagnose the patients, to manage these cases, and to talk about the postoperative care and the expected complications. So canalicular lacerations is basically an ocular emergency we all need to look into. It is reported in all age groups. Most of the times, in 70% of the cases, it will be involving the lower lid. Majority of the lacerations we see are monocanalicular. The main pathogenesis which lies is that there is a direct or indirect trauma which goes and hits the medial canthal complex. The medial canthal complex splays around the lacrimal drainage system, and when this is injured, there is a stretching and avulsion of the lid, and it separates the lid along with the canaliculus, along with the medial canthus, many times. The risk factors which are involved are, it is more prone in elderly patients, children and young adults. Males are more prone to such injuries because they are the ones who travel more. Animal bites, especially dog bites, can lead to canalicular injuries. Glass or metal injuries can also lead to, industrial injuries can lead to such kind of tears. Fist trauma. And in very small children, infants, you will see, in fact, that feeding mothers and these children will come with the blouse hook injuries. Road accidents. Many road accident patients will also have canalicular tears. So it is very, very important to examine thoroughly, ocular and periocularly. Routine examination of the eye has to be done and completed along with complete vision assessment. And then what you can do, coming back to the canalicular part, you have to see the extent of the canalicular laceration with dilatation and probing. Clean the part, and also you can do that in case of trauma. You have to see if there is a possibility, you have to keep in mind the possibility of a retained organic or other foreign bodies. In case you suspect, on palpitation, if you suspect that there is a fracture, then don't forget the CT or the MRI part. If there is a trauma by an animal bite, don't forget the immunization part. In such case, immunization is very important. Immunization has to be done by the protocol, and also local infiltration of the immunoglobulins have to be done. One more point I would like to stress here, in case of dog bite, see, many of us the patient will come with a dog bite. In case of a dog bite, there is always a question, do we suture or don't we suture? If there is a laceration, the traditional teaching goes, don't suture any dog bite or animal bite. But if the organ involved is a very essential or critical or vital organ, then you can take minimal sutures after injecting the immunoglobulin at the local site and also giving systemically. A punctum dilator should be passed to enlarge the punctum, and then a stent may be passed into the punctum and through the canaliculus. In monocanalicular lacerations, you can go for, there are oro stents and mini-monoca stents, which can be pulled in the punctum, and the distal portion is pushed into the second part of the canaliculus. So the main challenge in canaliculus repair is what I want to talk about, because that is what we undergo. Is to find, when you look under the microscope, what happens is, sometimes you see an epithelialized lining, and that shows that it is the other end of the canaliculi. If you inject air from the non-injured puncta, then you can watch for air bump of the canaliculi. Topical phenylephrine in the area, if it is put drop by drop, it causes a vasculature constriction here and there, and that also helps you find out the cut ends to find the other end of the canaliculus. So these are some patients where you see a monocanalicular tear. So as we always do, and you can see the blouse hook injury, small child, lesser. In case you don't have a stent, and then you can put this IV cannula which we use, or Venflone can be used and sutured to the skin. In case there is a bicanalicular injury, in that it is better to use a bicanalicular stent. You can pass it through the cut ends of the canaliculus, pass it into the nose, through the nasolacrimal tract into the nose. Endoscopically, you can see it in the nose, and then you can pull it out and attach it on the nose. A bicanalicular intubation set, which is introduced through the punctum, then you can see it here in the endoscopic picture, pull it out, retrieve in the nasal cavity, and it is done. The same procedure is reported for the other canaliculi also. Most of the steps are common for both monocanalicular and bicanalicular lacerations. The eyelid margin and the skin should always be closed slowly with a 6-0 ethylone. And the muscle layer has to be closed with an absorbable vicryl suture. Monocanalicular stents are left as it is for 6 weeks, whereas bicanalicular stents, we would like to leave them a little longer, maybe up to 3 months. And after that time, we can easily remove these 2 stents as an OPD procedure. You just need to pull them out, they'll come out. The complications of these stentings are that there can be plain bleeding, infection, there can be scarring. Sometimes there can be extrusion of the stent material, like all the stents. There can be cheese wiring of the silicone tubes. Pyogenic granulomas may form, punctal ectropions may form. And the next thing is there can be absence of functional patency. The overall success rate of a good canalicular repair is 90% or higher. This is my take-home message, that it is a simple surgery to do, can be done by all the practitioners. Everybody can do it.
Ruchi, that's very good take-home.
Canaliculars for the time.
Yeah, initially we...
Yes, ma'am. And previously we used to do sutures, but now I think we have better materials.
Yes, silicone. Move on to our third presentation by Dr. Parth Rana. He will be presenting intraocular foreign body surgical management.
बैक कर जो Good morning, everyone. So today I'm going to present about IOFV. Due to shortage of time, I'll just fast forward my videos. So as I told before, like for being an ocular trauma surgeon, we have to be an oculoplasty surgeon, a cornea surgeon, a cataract surgeon, and a retina surgeon. If we are doing everything, then only we can operate something like this, or we'll need at least 3 to 4 surgeons together to finalize a case something like this. So in this case, a young chap, he was working in a workshop from like he had an injury directly from upwards from the lid, and directly this foreign body went inside his vitreous cavity. So for starting with this, I had to suture the small wound, but once we open the conjunctiva, once we start exploring, we can see the total extent of the wound. Once the total extent of the wound is seen, I start suturing the wound. First of all, we have to take the first suture, which is proximal to the limbus, and then we have to keep the suture ends quite bigger, so we can hold that suture point and then go posterior. So here I am taking all the sutures one by one. And once after completing the suture, we have to do cryo there, because once it is around 3 to 4 millimeters behind the limbus, there are high chances of retina involving there. And if we are not doing cryo, there are high chances patient will come with the RD with PVR, and in this kind of cases, it is quite difficult to save the eye. So once we have done the cryo, it is quite easy to go inside and start the vitrectomy. So here I have started the vitrectomy here. once we are completing the total vitreous hemorrhage from there, we have to open the wound. Here, the main mistake, usually what we do is, like when we see the foreign body inside the eye, that foreign body looks small. But actually, when we are seeing through all this inverters and all, it looks small, but usually it is bigger. So first, for saving the macula, I have put PFCL there. And then I'm trying to remove this foreign body with help of magnets. But as you can see here, the wound was quite bigger, like what I have made this scleral wound, it was bigger. But the foreign body was not able to come through that. And it usually happens. So opening the wound bigger is the only solution not to injure the macula, not to injure macula or not to injure retina inside. So here I am trying to remove the foreign body. In 2 or 3 attempts, I was able to remove the foreign body because it's like quite smooth from all the sides and it's very sharp from all the sides. So whichever foreign body forceps we use, this happens. So if foreign body is bigger, always open the big port there. And once it is done, I'm just completing the laser on the impact side, and finally, I'm suturing and I'm completing the vitrectomy here. So this was done with sparing the lens. Here I'm showing one more foreign body video. Here the foreign body has entered through the cornea and through the lens. So in this kind of cases, it's best to do the lensectomy first and then start, and not to make scleral openings. So as a retina surgeon, most of our retina surgeons will agree to this. We love our cutters and we like to do our lensectomy or cataract surgeries with cutter only. We don't like to go with phaco. So here I am doing lensectomy with use of cutter only. So the anterior capsule also I am cutting with cutter. Even the posterior capsule also I am going to cut with cutter only. And it is kind of, when we are doing this anterior capsulotomy with cutter, it is as strong as the normal capsular axis. It is already proven in multiple articles. So once after doing the lensectomy, this is the impacted site as we can see there. These videos are in 3D, that's why we are seeing this 2 videos together. It was recorded in 3D. So after completing the total vitrectomy, I am removing the foreign body. I am pushing the foreign body directly into the anterior chamber. Once it is above the capsule, it is kind of main responsibility of ours not to drop the foreign body, and not this foreign body shouldn't touch on the cornea. So both the sides we have to be careful. So here I have made a opening at limbus and I have removed the foreign body from here. So once it is done, the laser at the impact site is necessary because there can be small holes inside this impact site and there can be RD in that, and once RD happens in this traumatic eyes, usually it's quite bad. It happens with PVR only. So we have to be careful in this kind of cases. Not only removing the foreign body is important, but after the surgery there shouldn't be any complication. That is also our responsibility. Thank you.
Thank you, Dr. Rana. Wonderful presentation. If we don't remove this foreign body, what will happen? And how early we should remove this foreign body?
I'm removing, normally when trauma cases comes to me, I prefer to do primary and secondary both surgeries separately. Primary, I'll just close the wounds and maybe I'll just reform the AC, and then vitreous hemorrhage or RD, I'll do it after 15 to 20 days. But once the foreign body is inside the eye, then it is kind of a bad sign. We have to operate as early as possible, because once the siderosis starts, then it's quite difficult to save the eye, even after removing the foreign body. So many times due to toxicity, we are losing the eye.
But if it is the glass foreign body or an inert foreign body, then if there is no risk of sidrosis.
Then maybe we can leave, but once the foreign body is there inside the eye, for me, it's kind of emergency to remove it. I'll do it in primary surgery only.
Correct. Any question from the... Yeah.
Yes, that's what I'm telling. Why I have showed both the different cases here, both the different kind of mechanisms here, because once where I am able to save the lens, both of the patients are young patients. So if I am able to save the lens, I'll try to save that, because their patient is going to have good vision after the surgery. But once I'm removing through the lens, patient is going to have IOLs, and in one eye patient is phakic and one eye IOL is there. So patient is usually not satisfied, and all these patients are usually of kind of worker category. So they need good vision to survive in their environment. Yes, in second case, it went through iris, it went through lens, and then it went inside. That's why the lensectomy was needed.
Most of these patients, they have a traumatic cataract eventually down the line, so it is better to get rid of that lens. But then what is your take on putting the IOL in the first sitting?
That I don't do it, because it's kind of, as a pure retina surgeon, it's not my forte also. And the second thing, if I'm doing IOL workup in the primary case where a vitreous hemorrhage is there, where foreign body is there, usually there are kind of high chances of refraction after the surgery. So we'll wait for a while. If posterior capsule is good, then I'll ask the cataract surgeon to put the 3-piece IOL. And if it's not, then I'll do the secondary IOL in second sitting after a month or two, once everything is settled.
Thank you.
Yes. Thank you so much. So we'll conclude the session here.
We invite the panelists and speakers of next session.
I would like to invite Kankaria sir and Dr. Amar Agrawal sir on the stage to give the trophies to all the presenters.
itu enak langsung yang berbeda untuk bagi approve.
Let's go to kind of
आपने जवाब
aku
सर एक बार काम कर रहे हो ये रहा
ada apa lagi itu bila mutiara lagi itu એવું છે
ये लगी
हर्षो
नहीं ये अच्छा ये
ठीक है
So, good morning, ladies and gentlemen. It's such a pleasure to be here. So, we begin with our next session here, overcoming cataract surgery challenges. And I would like to invite Dr. Lahani, Dr. Divyang on the stage. He's there, Dr. Rana, Dr. Arvind Moria, and Dr. Shell. What's up? Is Shell there? I don't see him. Yeah, Shell, please join us. And our panelists, Dr. Arun Tyagi, Dr. Gaurav Mehta, and Dr. Narendra Verma. Are they there? So we begin with our session and to begin with, we have our keynote at this time. It's an honor to have with us Dr. Amar Agarwal, Chairman, Dr. Agarwal Group of Eye Hospitals with us today, and a very innovative personality as far as scientific contributions are concerned. So we would like to invite the keynote lecture from Dr. Amar Agarwal, and he'll be talking upon aberopia and pinhole pupiloplasty.
On karo. Yeah. Thank you very much. First of all, it's such a pleasure to be here at this AGOS Summit. I'd like to thank Jagdish, Parth, and the entire team of AGOS for inviting me here. Ahmedabad is very dear to me. To be honest to you, Nitin Bhai, Talati, all of you people have taught me so much in life. I see Rekha Ben also there. So many people are here who have taught me and made us what we are. I want to thank each one of you personally from the bottom of my heart. So let's look at this pinhole pupiloplasty. Well, ladies and gentlemen, in the world, globally today, 2 to 6 crore blind are waiting for donor corneas. That's a huge number. This is a rough number. And this number will be increasing every year because there's no way in the world you'll get 6 crore blind becoming all right, because you cannot get that many donor corneas. So we have this technique called the pinhole pupiloplasty. The principle is very simple. You can see we are making the pupil 1.5 millimeters. What is the principle here? I am blocking all the peripheral rays of light. The central rays go in, hit the fovea. The person sees distance and near without glasses. When we were started for astigmatism, and you can see here a patient with RK and AK. Now, important issues, as I said, we started with astigmatism. Look at the astigmatism there is about 6.8. But another picture which you see here is a red blocked area, 10.9. This is an aberopia level. This shows a normal person will be 0.3. We are not in the habit of checking the aberopia of a human being right now. We need to get into that. Imagine if a normal is 0.3, here I'm showing you a 10.9. Imagine how bad this person's vision will be. So when we started this patient, we discovered the terminology aberopia and we published it in the year 2002 in the Ocular Surgery News. So like you have myopia, like you have hyperopia, you have a thing called aberopia, which was also published in 2007 in the JCRS. Now, when I started working on pinhole pupiloplasty, I knew my success rate will be less because my knowledge of optics, to be honest, is underground. So I started conversing at that time with Jack Holliday, who's perhaps the guru in optics. And since then, all the papers which Priya and us have written with Jack Holliday always has Jack Holliday with us. And Epsilon, we designed this device. It's a very simple device you can understand. Keep it in front of your patient's eye. Let's say you have a keratoconus patient who's come to you, let's say for PK or DALK, whatever it is. Keep it in front of the patient's eye. Ask him which pupil does he like. 1 or 1.5, you will make the pupil that size. It's a very simple, beautiful device. One, it tells you what the patient will reach. It also tells the patient what they will achieve. Now look at the next step. We have to do the pupiloplasty technique. This is the reverse fourth-throw, and I have to give credit to Priya and her daughter Ria and Samir for this help on this topic. So you can see in reverse fourth-throw, the knot or the tail goes behind the iris. So if I'm doing a pediatric graft or something, endothelial graft, you can see the needle first goes behind the iris. The rest of the procedure is simple like the fourth-throw pupiloplasty, but the advantage here is the tail, or shall I call it the knot, goes behind the iris. So when you inject an endothelial graft, the graft will not get damaged by the knot. You can also do the fourth-throw pupiloplasty, single pass, go through clear. So those who are not doing it, very simple procedure. Take a Proline needle, okay, 9-0 or 10-0. Go through clear cornea. Catch the iris, pass it inside. From the other side, I've got an paracentesis. So remember, paracentesis you need only on one side. Take a 26 or a 30 gauge needle, pass it through that, railroad the two. Now bring this loop out. So ladies and gentlemen, this is single pass, the first pass, and the only pass you need. Now remember the number 4. You pass it 4 times. 1, 2, 3, 4. Pull on both ends, and that is game, set, and match. You can do it as many times as you want. So you see, once I have done that, the same case, I keep on doing it more, till the pupil becomes small. Now remember, you need a vitrectomy machine. So you don't have to be an expert like Parth Rana, who's a super retina guy. Okay, we are lesser mortals. We can even use a simple phaco machine, which has got a basic anterior vitrectomy. So my point is, you don't need a constellation. Even your phaco machines have got enough vitrectomy probes. So just take that vitrectomy probe in the left hand. You see, I've got a fluid going inside the eye. Make the pupil the size you want. In this case, I have made it 1 millimeter. Look at the patient. Pre-op 2/60, post-op 6/9. This patient had 7 diopters astigmatism, 10.9 aberopia. So this is a very high patient with high aberopia. Now, can I see the fundus? That's the question retina guys was going to ask you, basically. This is 160 fundus you're seeing through that 1 millimeter pupil. So you can see the fundus. But let's give a theoretical example. If the patient develops a retinal detachment, you are referring it to Talati. All Dr. Talati has to do is take a YAG laser, shoot on the iris, make the pupil large, and you're back to square one. Okay? So now let's take the game to the next level. This patient came to us like this. So as I told you, the first thing when we started and pinhole pupillometry, we used for astigmatism, then we began to use it for aberopia, and now we are using for the next final frontier is we are trying to avoid a keratoplasty. In other words, can pinhole pupillometry be an alternative to keratoplasties? So this patient came to us like this, corneal scarring, corneal vascularization, you can see high astigmatism. Somebody had put an Intax in the patient, vision 660. My doctors brought the patient and told me, shall we remove the Intax? I said, don't remove the Intax. Let's do it another way. I leave the Intax as it is. You see what I'm going to do? The patient already has a cataract. I've done the cataract. I'm now at the same time making a pinhole pupil. Once that's done, look at my vitrectomy probe. I've got my fluid in the left hand. Look at my microscope light switched off. I'm using an endolimiter from outside, and you can see the Purkinje image P1. That is bang centered. So what you're doing, 1, the location of the pinhole is important. It should fall on the Purkinje image. 2, size is important. The size will be between 1 and 1.5 millimeter by and large. Higher the aberopia, ladies and gentlemen, smaller the pupil. Simple rule. Okay? If the aberopia is still 5, 1 to 5, you'll go for a 1.5. 5 and above, you'll go for a 1 millimeter pupil. Look at the patient, 6'9", N6, because they see distance and near without glasses. Now look at this, another case here, pellucid marginal degeneration. Look at a patient, look at the Purkinje image, it's off-centered. In such cases, I made my Purkinje of my pinhole also off-centered, if you notice, matching the Purkinje image. So, another problem which can happen sometimes is you can get a patient pre-op 660. I've done a pinhole pupillometry 6'9", but the patient says sometimes my illumination in the room is dull. All you do is take a YAG laser and enlarge the pupil, and you can see the patient is extremely happy. So for YAG laser, you just cut the iris, use the 3 to 4 millijoules, 2 to 3 shots, and you can make it all right. Another patient you see, after penetrating keratoplasty and glued IOL, patient was very happy, but said the illumination is a bit less. I just took the patient back to the YAG laser and enlarged it a bit. Okay, now look at this patient here. Another patient with keratoconus, sometimes you can get a dialysis. As you can see, there's an iodialysis present there. So learn the second thing you need to learn is, one I showed you, fourth iodialysis. Fix a trocar gets repaired. When the dialysis gets repaired, please understand you will off-center the pupil. So now you do a fourth row. So in other words, you're doing a twofold technique, which is combining the trocar-assisted and the fourth row. We also designed this device with Yuri Kalynnikov from Russia with Epsilon. It's a pinhole gauge. So you can see now, with this, you can measure also the size. Look at that. That's about 1 millimeter here, and this is a 1.5 millimeter thing. This is also available with Epsilon. And once again, no financial interest in any of this. The final clipping I thought I'll show you quickly here is this. A child, 14-year-old, came to me with a scar injury like this. You can see bad scarred injury. The surgeon previously had implanted IOL. It has subluxed. Now you see what I'm going to do is, I'm doing a glued IOL here. So first thing is, I'm making my sclerotomies. There is an IOL inside. After doing vitrectomy, I am not going to explant the IOL. First, after vitrectomy, I'll bring the IOL up. Now I'm going to do a glued IOL behind the existing IOL. So in other words, ladies and gentlemen, the glued IOL is working like a scaffold. This is a glued IOL scaffold. The advantage is, now when I cut the single piece foldable IOL, I don't have any fear of the foldable IOL falling down. So you can see here, I've cut the haptics there, cut the optics there, bring them out. Now I start the pinhole pupillasty. Again, single pass, fourth row pupillasty with that. And once you make it small, now my idea is what? Can I miss my central scar? Look at that. I made my pupil like that. Let's see how the patient behaves on post-operative period. Purkinje image is bang centered. Apply the glue, seal everything down. Let's see how the patient behaves at the end of the day, ladies and gentlemen. And you'll see here, pre-op was counting finger 1 meter. Post-op vision improved to 6, 9, and 6. So ladies and gentlemen, various cases which I thought I'll just quickly show you one fast case. For lack of time, I realize it. But this is important for you to see this because this is a case, and since Kudlu has come, who's a great refractive surgeon, perhaps in India and globally, this is a patient who had smile done. The patient came to us from South Korea. After that, they did a PRK on the patient. Now they messed up, and Kudlu must be cursing all the surgeons in the world for why they messed up smile cases when it's so simple. But it happens. Now what happens here is, the patient was screaming, to be honest to you. Now imagine the patient is from South Korea. So they've done twice surgery. Patient has gone to 624. Now what I told the patient was very clearly, there's only one way out for you, is to do the pinhole pupillasty. And you can see the final picture here, which I thought I'll show you here. Post-op day 1, vision 6.6, N6 without glasses. Thank you very much, ladies and gentlemen. Once again, thanks to AGOS Summit.
Thank you so much for this lovely talk. I have a few quick questions. For example, we all know that maybe some of the patients might complain of decreased mesopic or scotopic vision. So like maybe let us take into account that out of 10 cases of pinhole pupiloplasty that you have done, how many cases would actually need a post-YAG to slightly enlarge the size of the pupil?
Every day we do approximately, I think, I don't know rough number, but at least 5 a day. In our hospital, Monday to Saturday, we are doing that many numbers of pupiloplasties. And I can remember, I don't know in how many years we've been doing, so I don't know if you ask me number, but I must have done YAG laser in about 4 or 5 cases till now. That's very less number actually.
Okay, since...
But if you make a mistake, please understand one point which I'd like to tell all of you. If you make a mistake, it's better to make it small because it's easy for me to enlarge with YAG. If you make a mistake by making it bigger, then I have to take the patient back to the operation theater and make it smaller. So if you make a mistake, make it smaller, easy to do. But if you make it slightly, let's say 3 millimeters, okay? You say, listen, I heard Amar speak, he said make it, but it's too small. I made it 3 millimeters. Patient will not be happy. If you want to make that patient happy, make it 1.5 to 1 millimeter. That's when the patient will be extremely happy.
Another quick question. We all know that we have to align it on the Purkinje 1 reflex. Now we are operating all the cases under block. How do you make sure that, the eye can rotate when the patient is being operated under block?
It's a very good question. So what I do is I make the patient, after I finish everything, and I'm assessing the Purkinje image when I'm doing that vitrectomy, because that's the final portion, where the vitrectomy you're doing for the pupil. Keep the chin up like this so that the ray of light will hit directly perpendicular to your eye. Because sometimes the eye is down. So keep it flat. That final portion, adjust it something. I'm not saying it'll be 100% accurate. To be honest with you, you might miss a little bit, but it's pretty good otherwise.
Sir, I had a question that most of our pupils generally in our part of the world, the mesopic pupil usually doesn't go beyond 2, 2.5, 3 in most cases. So particularly nice with keratoconus arche, where their mesopic pupil is already, when you see on the slit lamp, is not very high. How do you decide this is the case where I want to consider pupil?
So that's why we designed this holiday pinhole device. Shell, what you do is take the pinhole device, keep it in front of the patient. Now see, the word you use is around 2.5 to 3 millimeters, correct? You lose the battle. You need that pupil going to that 1 to 1.5. I understand that 1.5 range, from 3 to 1.5, you're saying it's only 1.5 millimeter. Yeah. But it's huge difference. So what you do is, take the holiday pinhole device. I'll give you a simple example. All of you sitting here, go to your clinic on Monday morning, take a 6 diopter cylinder from the trial, keep it in front of your eyes. I'm not joking, you see nothing. You take 4 of them, make it 20 diopters, you see nothing. Now, keep a pinhole in front. You suddenly see the last line. So the answer to your question, Shell, is when you see a patient, get the pinhole device, keep it in front of the patient. 1, it will give you the confidence, yes, I can make this patient all right. 2, it will give the confidence to the patient also, this is exactly what I'm going to see. Because you don't want to promise something and then tomorrow the patient coming back screaming that, listen, you promised something, I'm not very happy. That Korean patient who came, believe it or not, one eye we have done smile. Okay, other eye now we have done pinhole. She's happy with the pinhole to the smile eye. I'm not saying do in all cases, I'm just saying when the complication occurs.
So one last question, sir. If patient is not aphakic or pseudophakic, patient is normal phakic patient, and if pupilloplasty is pinhole pupilloplasty indicated, then what will you advise?
I make them pseudophakic, to be honest with you, because I tell you what, if you try it, you will damage the lens. There are high chances, so I'm not going to take that chance. Second thing is, let us give an example of keratoconus. Your patient is -10, -12 astigmatism, something, whatever it is. When I do phaco and IOL, the -10 becomes 0. The 12, whatever the astigmatism, it doesn't matter to me, it becomes 0. So that becomes, actually he becomes 6'6", N6 without glasses. Remember the beauty of pinhole pupiloplasty, I do not mind what the astigmatism is, because the pre-op astigmatism, the post-op astigmatism is the same. I have not changed it. The pre-op aberopia, post-op aberopia is the same. I have not changed it. So what's the nomogram? Nothing. My nomogram, Jagdish, is only 1 to 1.5. That's the range I'm playing with. Yeah. You know, even if I make a mistake from 1 to 1.5, I'm bang on track.
So again, we do not have any pinhole IOLs in our part of the world. So I think, would you exercise or would you explain the benefits of doing a pinhole pupiloplasty over a pinhole IOL?
I have got pinhole IOLs. I have used pinhole IOLs because Trinidad family is very, very dear to me and very close to me, like they are to the Vasada family also. But the problems, please understand, in a pinhole IOL, 1, the location is fixed. I cannot change it. So if the Purkinje image is at some place, I cannot change it. I do not know where it's going to fall. The second is the size is fixed. The third bigger story is, if a patient has closed angle glaucoma, when I do a pinhole or pupiloplasty, I pull it so that my closed angle becomes open angle. I don't need FDA approval. That's 800. So even today, if I have a pinhole IOL, I do pinhole pupiloplasty. Beginning in the lecture, I showed a photograph. You can get 160 degrees fundus through 1 millimeter pupil. So there are machines like Nidec, which is the Mirante. I use that, but you can use the Optos, you can use the Zeiss and the Heidelberg. So all are available for examination. There's no issue there. The problem will come. Let's say the patient gets a detachment. Let's say 5 years down the road. Take a YAG laser, just shoot, you're bang on track. But please understand, a patient comes to you with, the maximum I've done is a 40 diopter astigmatism patient, okay? He's blind. All you do is go to the clinic, try with a 6 diopter astigmatism, you won't see anything. So right now the patient is blind. Let's say a corneal opacity, just I tell you, this week when I came, I had a patient from Singapore with a huge corneal opacity sent to me for PK. And I've not done PK, I've done a pinhole pupiloplasty. So the advantages are huge. If I do a PK, I tell you whatever it is, you'll get an astigmatism. So even if you're doing a PK, do a pinhole. Second problem is your patient on medication for 4 years, 5 years. Here the patient on medication 1 month, just like phaco surgery.
Thank you so much.
Thank you very much, everyone.
Thank you so much for this beautiful presentation, sir. We move on to our next presenter, Dr. Harshul Tak. Dr. Harshul, okay. He's going to take some time. So, I would then request Dr. Jagdish Rana, and he'll be talking upon redefining the cataract surgery with capsule laser.
So, very good morning, friends. I welcome you all on behalf of all Gujarat Ophthalmological Society on this beautiful morning and a lovely venue located at the Kankaria Lake. I think you must have enjoyed breakfast in the morning and academic session today and tomorrow also. So I will start my topic, redefining cataract surgery with capsule laser.
Next.
Yours is ready?
So Dr. David Mordaunt is the inventor of this capsule laser. It is developed and manufactured and marketed in USA by Excellence, and Dr. Richard Packard is the key collaborator in presenting technology and publishing this clinical data. It's Dr. Richard Packard, who has developed surgical laser capsulotomy protocol in May 2023. This is a capsule laser in action. In a fraction of a second, the capsule action happens. So they are the indication for. So they are the indication for the use. Capsule laser indicated for the use of anterior capsulotomy. The mechanism of action is it's a selective laser capsulotomy device. It operates to the absorption of a orange wavelength, that is 590 nanometer laser energy, onto a trypan blue stained dye. It's converting the type 4 collagen to amorphous collagen, that is non-fibrillar to fibrillar. So dye plus focus on capsule plus laser is equal to capsulotomy. This is the overview of capsule laser. It creates the highest quality anterior capsulotomies, laser precision in size and circularity, high resistant edge, and most accurate capsulotomy centration, and improve visibility, including the centration with capsule blue, and for all stages of cataract with proven surgical value in complex and premium cases. And definitely it's quite cheaper, or we can say cost effective than flex. So this is the laser precision which leads to centration and 360 coverage with capsule laser. It's 100% coverage with a capsule laser, 89% with flex, and 72% of with a CCC. They are the what studies have been done. This highest quality capsulotomy, visible and tear resistant. So we can say it's 1.5 times stronger than the CCC. If we consider CCC, manual CCC 100%, then flex is 70% stable or tear resistant, and capsule laser is 150 times more than the normal CCG tear resistant. Is a safety profile regarding the temporary rise in the antechamber with a capsule laser. This is regarding the centration with capsule laser capsulotomy done. And this is regarding descentation comparison with a flex and capsule laser. Descentation with flex is 0.4 to plus to minus 0.4 millimeter with a flex, and plus 0.15 to plus or minus 0.1 millimeter with capsule laser. This is a surgical protocol. We have to dilate the pupil with 5 lesser concentrated phenolphine. 5%, 10% phenolphine are contraindicated. And we have to use the HPMC to hydrate for the optical clarity. And low and slow injection technique is required. And capsule is stained for 60 seconds. And after washing the dye, we have to backfill with a special OVD, which is recommended for this capsule laser. And we have to apply the BSS on the cornea. We need a fixation ring to minimize the eye tilt and center the rectus. After the 2-side port, injecting a intracameral anesthetic. We need to hydrate the entire cornea, not allowing the entire cornea to dry, because it will lead to the descentation and the scattering of a capsule laser. So low and slow technique. We have to be on the entire capsule and slowly inject this specially recommended dye. After 40 seconds, you are injecting small amount of BSS to evenly spread the dye. So removing the dye from the main incision and then washing dye from the main incision. This is the backfilling the antechamber with a specially recommended OVD. Fixating the eyeball with a special fixator ring. Focusing the laser on the entire capsule. It is a 0.3 second and the exercise is over. Thank you. Thank you very much. Thank you.
Thank you so much for this presentation, Dr. Rana. Just a quick question, if you can just answer this. This device, is it a separate device or an attachment or something?
It is a console which is usually mounted on a microscope stand, and the delivery system is on a microscope that is binocular, just near the binocular, above the beam splitter.
Thank you. Anybody has any questions? Okay, thank you. So now we move on to our next speaker, Dr. Shell, and he will be talking upon posterior polar cataract with pre-existing defect. Meanwhile, I would like to ask Dr. Harshul, could you please fix up your presentation on the other podium?
Thank you very much to the AGUS Summit team. we do receive research grant support from Alcon Laboratories. So this was a 49-year-old male with a bilateral posterior polar cataracts with pre-existing defect. The left eye had a white cataract. So we had seen him many years back, 15 years back, and advised him surgery. He comes now at 49 years of age. And this is what we mean by the pre-existing defect. So as you can see, there is already some amount of lens matter which we feel is probably even leaked into the anterior vitreous phase. And this is the classical pre-existing defect that we are talking about, one which rides from one end of the equator to the other. And this is the typical shape in which it occurs. And the posterior polar component is sitting right in the center of it. So our first aim during the surgery is to try and prevent this from dropping and creating a catastrophe. So therefore, we prefer flax in such situations for two reasons. One is it gives us a controlled capsular axis, and we can do multiple cylindrical lens divisions which act as actually multiple forms of delineation of the nucleus. And it's very important here to do things very slowly. So as you can notice here, I've dropped my IOP to only 20 and I'm using a flow rate of only 18 cc per minute. And because the flax cuts the lens in vertical meridian, you can actually scoop out each epinuclear shell from the support of the other without actually disturbing this final epinuclear plate or needing any form of fluid hydroinjection or any form of rotation. So this is what we described as femtodelineation way back in 2015. It's always very important to maintain a closed chamber technique taught to us by Dr. Bobby Osher, which means that injecting a dispersive viscoelastic before making sure that the probe comes out so that the chamber doesn't collapse. Even if you're not normally doing bimanual irrigation aspiration, I would urge that in these cases of posterior polar cataracts or in any complicated situation, it's a good idea to do bimanual irrigation aspiration so that the chamber stability is maintained at all points of time. And swiping movements, this is also something that was taught to us by the late and great Dr. Alan Crandall and Dr. Liliana Werner. Swiping while removing the cortex reduces stress on the capsular fornices and also make sure that the equatorial cells are removed so there are lesser chances of PCOO occurring. So once again, I'm working at a very low flow rate of only 16 cc per minute so that things will happen slowly, but they'll happen under my control so that even if I catch something inadvertently, I have enough time to reflux it. And fortunately, through the procedure, maintaining low parameters, we've been able to remove the lens without actually disturbing the vitreous or causing any drop of the nucleus that has occurred. And therefore, in such eyes, my preference is to go for a 3-piece IOL. This is a holding-folding technique of injecting. Sometimes with an open capsule, I'm scared of injecting the lens with the cartridge because it tends to open up differently. And making sure that the haptics go in the sulcus. And now what I'm doing here is pushing the optic behind the anterior capsular axis, what is known as an optic capture or a conventional optic capture where the haptics remain in the sulcus. And I'm actually pushing it even behind the pre-existing posterior capsular tear so that the optic stays very much away from the iris. As you can notice here, I'm touching and showing that the optic is behind the anterior as well as the posterior capsule. Always suture a wound anything more than 2.4 millimeters and inject triamcinolone dilute in the end to make sure that there is no vitreous disturbance, which fortunately there wasn't in this case, and the patient did quite well post-operatively. This is the 3-month follow-up, very well centered IOL, and this IOL is now not going to move anywhere and it's going to remain crystal clear. And this is the UBM of the same patient showing how posterior the optic is. The optic is actually even behind the pre-existing posterior capsular tear. So there are no possibilities of uveitis, glaucoma, hyphema occurring even in the long run in this young patient. And follow these patients post-operatively because there are higher chances of developing cystoid macular edema in the post-operative period as well. And this is the second eye of that same patient. We know from the first eye that the patient has a pre-existing defect. So naturally with this white cataract, obviously there is a very high chance that this will be a pre-existing defect. We prefer to do the capsular axis, as you can see here with the flax, so that at least we have a centered, complete capsular axis. And because this had some amount of nucleus as well, we have done a sculpting, and what we are doing is with angle cannulas trying to inject fluid in the nuclear material itself, so that there is less and practically no chance of causing an inadvertent hydrodissection at any point of time. This is what we described as inside-out delineation way back in 1998. And then follow once again the same principles. So irrespective of whether the patient has a defect or not, treat each posterior polar as if it's going to have a defect. So low intraocular pressure or low bottle height. So IOP of 20 is equivalent to bottle height of only about 37 centimeters, which means even whatever you're using normal, making sure that you access the cortex from both sides equally in this case. And here, as you can notice, there are some changes already of some of these lens particle matters in the anterior vitreous phase. That's how the cataract becomes white in a pre-existing cataract, that the fluid tends to seep in. And therefore, we need to address those particles as well as whatever vitreous prolapse is there, and our preference is for pars plana approach. So as you can notice, the irrigation is making sure that the chamber remains well formed, and this is a 23 gauge trocar. You can even use a lance knife, but trocar gives you the ease of going in and out easily at all points of time. While doing vitrectomy, have the highest possible cut rate your machine has, which has 5,000 in mind, but it could be anything. Moderate vacuum and a very low flow rate of only 10 cc per minute. And once we've cleared off the muck as well as the vitreous, once again going ahead with the 3-piece IOL haptics in the sulcus, making sure with the forceps that the haptics go nowhere except the sulcus, and pushing the optic not only behind the anterior capsular axis but also behind the pre-existing posterior capsular tear. And this is just to highlight that this is behind the anterior as well as the posterior capsular axis. In the end, always make sure by injecting diluted triamcinolone that during your maneuvers there has been no vitreous disturbance that has further occurred, which fortunately there wasn't. And there is no count of the sutures. I felt I needed 2 sutures here. You may feel you need 3 sutures. Take as many sutures as may be needed. So to finalize, avoid a rapid buildup of hydraulic pressure, and this goes true for any posterior polar cataract. Create a mechanical cushion effect either by hydrodelineation, inside-out delineation, or with femtosecond. Avoid forward bulge of the capsular zonular capsule diaphragm, which means keep filling the anterior chamber, don't allow it to collapse. Create a communication between the anterior and posterior compartment. So the final epinucleus, don't remove it completely, just detach it from the fornices, what Dr. Bobby Osher just recently described in a paper as the escape route, because that will allow some amount of fluid to start coming out so that there will be no further sudden raise in the intralenticular pressure, and whenever possible femtodelineation, but always counsel the patients for a 2-stage procedure in these eyes. Thank you so much for the patient listening.
Thank you so much, Shell. Beautiful presentation, and you have actually correctly highlighted all the points that we need to follow whenever we are doing a posterior polar cataract. I think the key for this is that you have to be ready with any of the complications that would come up, and especially doing a good amount of vitrectomy. So coming up to this, Shell, I would like to ask you that what is your favorite take on doing vitrectomies whenever needed in these types of cases?
So in any form of vitreous disturbance, the first point is to make sure that you tackle the vitreous before you go to the next step. So don't think that there's one fragment remaining, let me remove that and then I'll remove the vitreous with this in the anterior chamber. So first is tackle the vitreous first. Second, stain with diluted triamcinolone. And my preference is to go through the pars plana because it will drain through the pre-existing tear and cause the least amount of vitreous traction. But even if you are doing limbal vitrectomy, doesn't matter. Do a good vitrectomy.
Do you like to use a trocar, or would you like to use an MVR?
MVR. So I prefer a trocar for 2 reasons. One is, of course, you need not suture it. But the second is, once you make an incision with the lance knife, you need to do a conjunctival peritomy as well. Because if you do through the transconjunctiva, there will be a lot of chemosis. So going in and out again will be very difficult. And
we need
with
to
and now with the newer phaco machines, most of them are compatible with at least 23 gauge. The newer machines are now, cataract machines are even compatible with 25 gauge trocars and vitrectors.
Thank you so much. It was a wonderful presentation. Thank you. And okay, so we have a request coming up now. Dr. Harshul, he does not want to talk on posterior polar again. So he's going to show us about subluxated cataract management.
Thank you so much. Committee for giving this wonderful opportunity. And I have three comments. So, as Shell has briefly covered
So this is the case which had a automatic subluxation and without subluxation was almost here. The problem was that the anti-capsule was very So we always need to be clear that whenever we are going to fibrotic area, we need not to pull the sources. So in these fibrotic area, we should cut through these areas, and whenever we are in the area, we try to access. And many times you need to make extra cycle incisions, which you should not be shy of because it gives you the perfect angle to make acroaxis. And you need to change your hands again and again. And many times you need to do bimanual touching using micro scissors like this. So again I am changing my hands, holding the flap with forceps and cutting through. And remember that this area, which is the subluxation area, you need to keep a margin of 2 mm so that you can easily put capsular hooks and also capsular tension segment can easily go through this area. Once you make capsular access, now before you start anything, you need to put some viscose there to emulate the anti-VEGF phase. And depending on area of subluxation, you need to put capsular hooks 2 or 3 or 4 depending on the area of subluxation. These capsular hooks, once they are put, they act like artificial glues. They give extra posterior support to the capsular bag. So if you don't put these capsular bags, really it will be very difficult. Further neural rates may increase and it will make life very problematic. So once you need to input these capsular hooks, and depending on the balance of the nucleus, you may decide a technique of FACO. But in my opinion, joint chop always is better because it doesn't cause any stress on the volumes and capsular bag. And this was a brittle cataract, so nothing great in multiplying this. Just need to be careful that there is no cortical support there. But remember that maintaining a closed chamber is the key in cases like this, in subluxated, post-polar, any kind of cases. You always want to maintain anterior chamber deep and not, it should not collapse because frequent collapse of anterior chamber can cause disturbance in the anterior VEGF phase. So once you take out the entire nucleus material, I go ahead and do visco exchange before taking out FACO probe. And now these looks are of no use now because they are multiplication. And after that, you need to provide some equatorial expansion of this capsular bag. You need to provide equatorial support there. So there is a CPR ring. So you can either put a only CPR, which is really cumbersome. So nowadays, most of the surgeons they prefer to use CPR ring, which goes in capsular bag. And once the CPR goes in capsular bag, it gives good expansion of the capsular bag. It distributes forces from the intact granules to the weaker granules. So this ring goes in capsular bag, and after that you can do thorough cortical matter irrigation aspiration. Before changing hands again, you go ahead and put OVD, so never let your chamber collapse at any speed. So again, I am maintaining anterior chamber. And this is the capsular tension segment, which is made of EMF. So this was the old days, I was using 90 Crowley. Nowadays, I use 60 Crowley to flange these capsular tension segment. So You put a suture there, 90 in one of the eyelid, and put this segment inside. So these two weights of this capsular segment, they go in the capsular bag, and the eyelid it comes above the entire capsular access margin. Then I think we can create a offset there, or with 1.5 millimeter behind the inverse I go and railroad both the ends of this suture. So once you railroad both the ends out like this, then you can go ahead and patent the tension which is needed to fix the bag. This fixation is very essential if you have a subluxation more than 3 torcas. In 3 torcas, only a CGR can take care. But if it's more than that, you need to anchor the capsular bag to the sphere for long-term stability. And depending on whether it is a traumatic subluxation or this is already, you may decide on the type of the lens. This was a traumatic subluxation, so I went ahead and put a single piece capsular bag. Had it been a unit, choose a 3-piece IOL. This
Thank you so much for this presentation. We are running short of time, so I would request all the speakers to please maintain the time. Dr. Harshul, it was a great presentation. Yeah. Meanwhile, we set up the next presentation. We can ask you one question. So, yeah. I would just like to ask you that, is it that in every case, I think it's a good idea to support the capsule bag with would you use a hook or a capsular hooks would you like to use, or an iris hook like you say? Many surgeons, they even use an iris hook kind of a thing. Would you suggest using one?
So ideal is of course the capsular hooks, because the ends of the capsular hook are bigger, they are broader, so they provide the support till the equator of the capsular bag. Whereas the iris hooks, they are sharp and they are very small in length, so it may cause tear if you tend to pull it. So ideally is capsular hooks, but if you don't have, of course, you can use iris hooks.
Thank you so much. Can we have the next presentation on the screen, please? Yeah. So we have now Dr. Sameer, and he will be talking about IOL scaffolding in tricky situations.
Good morning, everyone. First and foremost, I would like to thank Dr. Jagdish, the viewers, for giving me this opportunity to speak in front of you. So I will be speaking on IOL scaffold. So before I start, I would all let you know that this beautiful technique was started by Dr. Ahmedabad. And it is really a privilege that we have the man himself sitting with us and kudos to him. So what is a scaffold? A scaffold is a temporary platform. So IOL scaffold means that you are using the optic of the IOL as a scaffold. And this can be used in various tricky situations that I will show you. Now this is an animated video of how this IOL scaffold is done. If you get a PCR during the clinical study. Now you put the instrument, do a technical exercise, do your micro procedures, and then you start your scaffold, you back it up, and here you get a large PCR, and there is a large nucleus still lying there. So what I do is I will put a 3-piece IOL in the circle or over the iris image, okay? And now I can easily read the nucleus that is of the IOL. So there is no chance that the nuclear piece will fall into the nucleus. And now we can dial this IOL into the IOL into the circle. We get a very good result. Now this is the 7-year-old patient who came to us with morbid very difficult to handle. The capsular access during this is very difficult. So let's see. So first we have to see prepare the do. So after preparing do, you have to be very careful with the capsular access, and you have to be careful with the capsular access. prevent that circulation left side. So here you can see the fluid is coming out. You have to do it very slowly, and luckily everything is going right till now. You complete your exercises. So after you complete your exercises and you do your hydro procedure, I start with my payload. Now you see what happens. As soon as I start with my payload, you see there are the nucleus are so weak that the whole nucleus comes into the anterior chamber. Now I don't have nucleus support. So there are all the chances that I will get a PCR by eating this nucleus and having lot of problems. So what I'm using, I put a piece I use as a step, and now I am safe because I am sure that the nucleus won't fall into the vitreous. So now with the paper machine, with the you can easily read that nucleus piece, but you have to make sure that you use a lot of viscoelastic so that you don't damage the endothelium. So this is also there is floppy itis. So you have to make sure that there are some many times pieces hidden behind the iris. So you have to take out those pieces. But now you're not afraid that these pieces will fall into the vitreous. So you can search them all and bring them off, knock them off with your paper machine. So after this, you have taken this, so your surgery is over. You get some result like this. Now you can also use IOL schedule for IOL exchange. Now, this was a case that was referred to us with Gujarat syndrome, and in this the doctor had put a one-piece IOL. They also incident, and we had put a one-piece IOL in the sulcus. So we had to remove it and replace it with three-piece IOL. So now you cannot get viscoelastic in this eye because all the viscoelastic will go into the posterior chamber, and on the second day you get a lot of vitritis and secondary glaucoma. So you have to use either AC maintainer or anterior chamber TOCA. TOCA is more like stability of TOCA is more. So as with there is a range, you have to follow that vitrectomy rule. You have to do with the tripod, you have to follow vitrectomy so that I put the lens. So vitreous is not good and there are no chances of retinal detection. So I am doing the vitrectomy, anterior chamber vitrectomy, and now I am doing iris because I am not able to see the textural margin or the what's the status of the how much is the red and what is this. So after making the main incision, slowly what I am doing is I am pulling it up and this peak workpiece IOL and bringing it into the anterior chamber. So now what you do is after as I told you, you have to use viscoelastic a lot because you have to save the endothelium also. Now I am injecting a three-piece IOL and this is acting as a scaffold so that the nucleus doesn't fall down and bringing it out. So after this, now this is acting as a scaffold. I have injected this into the directly into the sulcus. After you direct, now the thing is that I have to remove the so this can be done with the IOL cutting faucet or with the harness faucet. We have to make comparison because we have to hold the
Can you please sum up, please? Yeah.
You have to hold the IOL, and with the IOL cutting faucet, I am just bringing up with the harness faucet. You have to bring up with the harness also. This is a old video. Now we take a triangular cut. just pull it out, it will come out to the rear cornea incision in two parts, like you can see here. This has come out, and now I will remove the. So now you use the iris hook. Make sure that the IOL is in the sulcus. Remove the iris hook, take the sutures, and again do a thorough vitrectomy because we have manipulated so much into the anterior chamber. Just take out this, put air. That is the end of the surgery. This is how it is. Thank you very much.
Thank you very much, Dr. Saminaling. It was a very nice presentation. I would like to invite Dr. Rajan Gupta, EKA in difficult situations. We are running short of time, so please sum up early as soon as possible and within a time given. Thank you.
Good morning, dear friends.
So we begin our next talk.
At the outset, first of all, I would like to thank AGOS, Dr. Jagdish Rana, Dr. Divyang Brahmat, all the fraternities for inviting me, giving talk in the FECO in the difficult situation. As we have already seen the difficult videos, it's just a summarized PPT about whatever the difficult situations we face during our routine cataract surgeries. So what are the various difficult situations during the phaco surgery? A cataract, we can do in a corneal degeneration, small pupil, runaway rhexis, zonal dialysis, subluxated cataracts, hard cataracts, posterior polar, and pseudo-exfoliation syndromes. The small pupil is around 2 to 4 millimeter in size, and the various common mechanism for the small pupil formation is in age-related, it's an iris atrophy. In pseudo-exfoliation, it is dilator and sphincter muscle atrophy. In IFS, it is dilator muscle atrophy, and in diabetic, it is due to the metabolic changes and reverses iridis. In the posterior cyanic, due to uveitis, previous angle closure, and the previous intraocular surgery, and because of medications of the alpha agonist and anticholinergics. So what are the various technical challenges of small pupil during the cataract surgery? There is a reduced red reflex, small rhexis, increased risk of iris damage, iris prolapse from wounds during the surgery, the iris bleeding, incomplete removal of the cortex, risk of catching pupillary margin during the phaco surgery, and the problems in ensuring the bag placement of the, specifically in the toric IOLs. What are the various small pupil management? It can be pharmacological madrasses, ocular OVD usage, and the mechanical devices you can use. So in preoperative, you can use NSAIDs like ibuprofen and naproxen and other NSAIDs. The intracameral injection of epinephrine, that is 1 in 1,000 diluted, and intracameral injection of tropicamide, phenylephrine, the linocaine, which is already available in the market. You can use various OVDs like viscoadaptive, Helon. It's useful in cases of small pupil. The term viscoadaptive relates to the different behaviors that displayed during the surgery. And at low flow rate, the viscoadaptive OVD is highly retentive and maintains the AC depth. At high flow rate, it changes fracture and coat the endothelium, similar to dispersive viscoelastics. What are the various mechanical devices? You can use a Malin ring, BX pupil expander, I-ring pupil expander, and iris hooks. What are the various surgical means? You can do a synovial stitch, pupilloplasty in the iris cutting with the Warner's scissors. The stepwise approach in managing small pupils is first you do the intracameral injection, then do the viscodilatation, and again you can do the posterior synovial, then pupillary stretching technique, and last of all use the pupillary expander devices. In hard cataracts, the problem is the lens fibers are totally adherent, making the chopping very difficult, and there is very little or no cortical cushion between the lens and the capsule. So potential complication in a hard cataract is a corneal edema, wound burn, capsule zonal problems, the PC rupture, and the postoperative inflammations. So pearls and strategies to follow: use trypan blue dye for better visualization of the capsule. Bigger capsular axis in hard cataract, 5.5 to 6 millimeter you can do. Gentle hydrodissection, the high vacuum and the burst mode in a phaco settings. Sculpt a central pit before chopping the nucleus, and sub-chop the fragments. Maximize the chopped fragments. Use dispersive OVDs more frequently for the endothelium. In the posterior polar cataract, the beautiful video shown by Dr. Shalva Savada, but all of us don't have the privilege to have a femtocataract surgery machine. So that basic problem is the strong adherence of opacity to the posterior capsule. There are 26% chances of defective posterior capsule in posterior polar cataracts. The high rate of intraoperative PC rupture, around 36%, is there in posterior polar cataracts, and difficult epinucleus and cortex removal in such cases. So what are the various strategies you can use in posterior polar cataract? Identify the PC defect before the surgery. Look for a fishtail sign on the slit lamp. Capsular axis should be oval, around 5 to 5.5 millimeters, so that you can place the lens in the sulcus. The rotation of nucleus should be avoided. Just avoid the hydrodissection to prevent the PCR, and gentle hydrodilation, also known as the hydrodissection ring, to be done, and low aspiration rate and low vacuum techniques to protect the posterior capsule. The bimanual IA is preferable, as already shown by Dr. Shalva Savada, and inject visco. I have seen in videos while withdrawing the instrument from the eye, just before inject the visco before withdrawing any instrument, so that there should not be a posterior surge in such cases to avoid the PC rupture. And thank you. Just support me for the joint treasurer in the forthcoming election 2026. Thanks a lot.
Thank you, sir, for that wonderful summarization of so many variety of difficult situations. I'd like to invite our next speaker, Dr. Navendu Rai, and he's going to talk to us about anterior vitrectomy, a boon for a cataract surgeon.
A very good morning to all. At the outset, I would like to thank all the AGOS executives, especially Jagdish sir, my friend Parth, Brahmbhatt sir, and everybody for giving me this chance to present my topic in front of this August gathering. So I'll be taking most of the part of my presentation has been covered very beautifully by Dr. Shell, and I'll just go very fast. The posterior capsule is the thickest basement membrane of the body, and mind it, when you stretch it more than 60% of its tensile strength, only then it ruptures. So many times it gets caught in your IA cannula, but it doesn't rupture. So what are the intraop events that lead to presbyopia? The most common is IA. Extension of radial tears, large leaky wounds, vitreous hydrodissection during removal of large fragment of the nucleus, during IUL placement and dialing, incomplete capsular access in which the tracks could be caught and rent can occur, hydroprolapse of the nucleus through a small rhexis like shown by Dr. Gupta just before me, manipulation of the back without adequately pressurizing it during polishing and by direct hit by your probe, chopper or dialer. Now this management of PCR needs three things. One is the immediate management. Then you need a tailor-made plan to manage the things that are left inside the interchamber. And the third and very important thing is counseling. How to recognize? Because the earlier you recognize a PC has occurred, the management becomes easier and the post-op results become better. So sudden deepening of the anterior chamber or momentary dilatation of the pupil, which is known as snap sign, sudden brightening of the frontal glow, or the nucleus now paradoxically moves sideways. The management of PC the chamber should be closed. That is why, as Dr. Shell has shown us, that before removing your phaco probe, the chamber has to be filled with dispersive OVD. So once you fill it, the chances of enlargement of this rent reduces. So the second thing is, anterior vitrectomy is very important, and the most important step if there is a single strand of vitreous, because if it is there, your management becomes difficult and the size of rent goes on increasing, and something which was easily manageable becomes difficult now. The most important way and the best way to recognize if vitreous is there or not is using triamcinolone. Sponge vitrectomy is now obsolete because of the intense traction it gives on the base of the vitreous, which leads to even formation of giant retinal tears. Now we have automated vitrectomies, which are done through the side ports, and because now the main wound has to be closed. Start vitrectomy from the main wound, and vitrectomy has to be done just beyond the posterior capsule. What I do is I go beyond the posterior capsule around 1 millimeter, so that we have time for the rest of the vitreous to come inside the interchamber, if at all it happens. The first thing is, do not remove your probe in hassle. Don't panic. Put some dispersive viscoelastic and then go inside, see if what all things are left. If nucleus is there, you need to manage that. Usually it happens during IEA, so you have only capsule, I mean the cortical matter to be removed. So you can do a dry vitrectomy and dry cortical wash. You require high cut rates, low vacuum, and fluid should be used. And the mode should be cut IA. Now all the phaco machines have vitrectomy with them, so anybody can manage with their own phaco machines. The most important thing is try to maintain the size of rent as much as possible, because if it increases, then the post-op results become poorer. This was to the anterior root, the limbal root. Now what Dr. Shell had showed us, the pars plana approach, that is very physiological, because in pars plana what you are doing is you're actually transecting the vitreous from its base. So you're not pulling it. From the limbal root you are pulling it, from the pars plana root actually you are transecting it. The difference is the cutter is facing upwards when you're doing the vitrectomy from the limbal root, while it is facing downwards when you are going to the pars plana root, because you don't want to disturb or damage the remaining of the capsule, because you require that for putting the IUL. So you can use a trocar or an MVR blade, because if you have trocar, like Dr. Shal has a very wonderful OT with him, so all instruments are there. But if you don't have trocar with you, you can simply use an MVR blade, stab it around 3 mm from the limbus, and you can do the vitrectomy, anterior vitrectomy from the pars plana root. The irrigation can be used from the side port itself, because now the two compartments are one, and you require a deep anterior chamber. Now, confirming the completion of vitrectomy, again you can put triamcinolone, and you can be sure that none of the vitreous tags are present inside the anterior chamber, because if vitreous is there inside the anterior chamber, then you can have post-op complications like CME, rent formation, all those things. The nucleus management depends on the size of the rent and the hardness and amount of nucleus that is there inside. If the size of rent is, if it's a small, the fragment which is remaining inside the chamber is smaller, you will actually plug the BC rent with a dispersive viscoelastic. If there is no vitreous, you don't require anterior vitrectomy, you can go and finish the nuclear fragment with a burst of phaco. If it is larger, it is better to convert it into SICS or ICC, whatever you are more well versed with. If there is vitrectomy, if there is vitreous inside the anterior chamber, that needs to be tackled first. You need to do anterior vitrectomy, and then rest of the things remain same. If it's small fragment, go and directly manage it with a phaco probe, otherwise convert it. Now, if there is a rent and the nuclear material has gone inside the vitreous cavity, it is better for the anterior segment surgeons to stop right there, because you don't go and fish. If you go and fish inside, you try to fish inside, then you'll end up with more and more complications. So what we do is, we do a 3-port vitrectomy with phacofragmentation, and we use PFCl to float the nucleus, so that while doing phacofragmentation, the heat generated doesn't damage the retina. Now, IOL implantation, if you are a primary surgeon, then it depends on the softness of the hardness of the nucleus. If the nucleus is soft, you can go and put an IUL in the sulcus, and we can use phacofragmentation to remove the nucleus from the vitreous cavity. If it is hard, then don't implant IUL. We can sometimes use the limbal root for removing the nuclear material. And do examine the periphery of the retina once the cornea clears up, because there are chances of retinal detachment in 3 to 90% of such cases. IOL placement again depends. Can you please sum up? Yes, ma'am. IOL placement is very important, because you don't want to see such things in the post-op. IOL placement, if it is small rent, you can go and put the IOL inside the bag itself. While if it is and do an optic capture as shown by Dr. Shell so beautifully. If it is large, put a 3-piece IOL inside the sulcus. If the scapular support is inadequate, put AC IOL, SF IOL, or iris fixation IOL, whichever you are more well versed with. So counseling starts from the PCR, the moment PCR occurs. You need to tell the patient that there is some problem with your membrane. What I tell the patients is, आपकी झिल्ली कमजोर है, it will take some time to manage, and the same thing has to be conveyed to the relatives also once the patient goes out. क्योंकि उसको ये लगता है कि बाकियों का ऑपरेशन तो 10 मिनट में हो गया, मेरे में 40 मिनट क्यों लग गए? So that needs to be conveyed to the patient and the staff and the relatives. So take home message is, do not panic, and even after PCR, you can give your patient very good results if that is managed timely and properly. Thank you. Please do support me for member scientific committee post in AIOS. Thank you very much.
Thank you so much for this wonderful talk, doctor. And we have our next speaker, Dr. Kudlu. But before that, I would like to say that today is the birthday of Dr. Jagdish Rana, our secretary. So I think a huge round of applause for him and good wishes to him on his birthday. That's commendable. So we move on to our next speaker, Dr. Kudlu, and he'll be talking on ideal phakic IOLs.
Thank you, Priya. I think last 75 years of India independence, Gujarat is independent. One part I think we have to validate. So as you're talking about ideal phakic IOL, any Indian phakic IOL which has been introduced in Gujarat also. So can anybody continue or bring the slides? Yes. So these are the indications for basic illness, especially patients with very high myopia. Even we can do post-arctic, post-phakic patient. But very important, you should not do phakic lenses in progressive refractive error patients with the old age or immunities, glaucoma, and also anti-chamber depth less than 2 months. Of course, we need to ask the history of pregnancy. But lot of advantages with the phakic lenses because it is not from the end of the year. Always it is close to the moment of the eye, which is also reversible procedure. These are the different types of phakic lenses available in the Indian market. So I will be talking about one of the few materials. Mainly star lenses is a polymer lenses and all other from Indian manufacturers from the So these are the areas. So subject refraction, spectrometry, anti-chamber depth, pachymetry, action length, temperature. So always all my patients I do spectrometry refraction. And so if you are having a well calibrated auto-refractive spectrometry is more than sufficient for the spectrometry. Always anti-chamber depth is very, very important. It is for the endothelium to the anti-capsule, which has for the minimum 2.8 mm. Lot of equipment will take out with this. Those who are doing this ultrasound, always you should remember to detect the factory. So we did a small comparison of this ACD comparison with the most accurate one is ES scan and also with the IOL muscle. Also, ES calculation is quite near to the off which do measures. So why probably I can say this is the single most important measurement in the success of the phakic lenses. Not only in my hospital, 2 to 3 reading I take, then I check with my other consultant, then finally I take the reading. So always both sizing will lead to glaucoma and hypersizing will lead to patient may have better. So again here we did one small study which is the perfect machine to do it. You see a digital, very calibrated digital canvas with the off scan, which gives a perfect reading. So, white always we should make from points of contact and we should get the clear from. But now since last year, we all been taking certain they come to that mid-universe to the mid-universe is the proper accurate measurement for white. Always post-operatively, you should look for the what which is the distance between the posterior surface of the lens to the anterior capsule. So, I just show you the video. This is the first video I have done for fatigue, I think after done after 500 cases of study, then I think acrylic fatigue has been done. I am proud to say that the first person with this acrylic fatigue lens is in India, and we have got a long-term data in acrylic fatigue. Probably I can say the best fatigue lens available in the world. So that much hard work has to put, especially for this particular product. So of course, procedure is very simple. Make a paracentesis, put sufficient amount of this elastic to the paracentesis. Then while injecting, I think 2.8 incision is more than sufficient, not like unlike with the HCL, where you are doing the 3.2. Then keep injecting the very small gelatin. Look for the market roll on your left side. Leading haptic has to have a roll on the left side. Once it is done, put the sufficient amount of this elastic over the IPVT. Then the help of a special instrument called doctor, you should cut underneath the IV. These are the features of IPVT. You are easy to load, presence of cellular and peripheral both, very less chance of quick hand rotation. But I want to tell about two very important about the spot calibration. If you see, you need to have a highly fatigue calculator. Always should have a multiple options for white to white for different equipment. That is very, very important. We need to have a calculator which has got a wall prediction too. So always, I think we should also look for the long-term safety and efficacy data. See, if you go to the calculator, just see here, it has got it. So one is for rest of the world, one is for the European. You see, you can enter all these measurements from manual to white to white, off scan, total, 700, 500, and then so on. Then the machine itself will calculate how much is going to be the sample. The one input is calculated what you are calculating, what prediction. See, if you have any calculator which has the what prediction, then you can get it perfectly. These are experience I can take 30 seconds. So these are experience with acrylic fatigue. You know, the 300 patients last 4 years follow. If you see the result, the wow factor almost 98% of the patients had 6 9 vision. Only couple of patients had an initial high in the IOP can be expected in any of the fatigue. Then if you see the mean wall, how stable it is remaining because of the wall predictors in the calculation. These are experience with the acrylic fatigue. The 100 patients will come for 4 years of follow. If you see how well the results are spread up for 4 years. See, if you see the comparison between the pre-operative refractive astigmatism with the post-operative refractive astigmatism, more than 25% taken ahead, refractive astigmatism less than 0.5 diopters at the end of 4 years. If you see rotational stability, more than 85% of the patients had a less than 20 rotation. So I think you won't get in any of the fatigue. This is just a head-to-head comparison with the Vivo Vision eye here. If you see flexibility, of course, Vivo Vision eye is extremely flexible, but chances of flipping inside the eye is not possible with the acrylic fatigue. It will go through 2.8 and so these are our results of patients. Only 8 patients had increase in IOP, which is controlled by the. In conclusion, acrylic fatigue intraocular lenses are safe and effective for treating a mild to moderate and high refractive error. It gives a peace of mind when it comes to loading, implantation is predictably what and vision all down, which is open access to what prediction, most innovative calculator really unique from any other company in the world. Of course, the customer support from Biotech is very. I thank the entire EKA society to be part of to invite me all the thanks for that.
Thank you so much, Dr. Kudlu, for this wonderful talk. And with this, we will close this session. But before we close this session, I would like to ask Dr. Lahane sir to felicitate the presenters. So I would love to have all the presenters of this session please come up on the stage.
Yes.
ये तकलीफ क्यों दे रही है? इसको बैठे तकलीफ मेरे को सर तकलीफ ही दे रही है। ओके हाँ हाँ यस आगे देखो।
I would request, sir, please be on the stage. I would request Dr. Lahane, sir, to felicitate Dr. Jagdish Rana. We are going to felicitate the state faculties right now, and the national faculty will be in the main inauguration. Shell Vasavada.
Wow. Senior.
Sameer Narang.
इसको तकलीफ दिया जाता है।
Can you wind up your talk?
मैंने डॉक्टर राणा को बोला था बोलने के लिए, उन्होंने कहा नहीं तू ही बोल। Thank you so much. So we close this session right now, and we would like to invite the next speakers, please, to come up on the stage.
He is the first presenter, sir. Okay.
Good morning, everyone. So we move on to the next session, which is very important nowadays, and myopia master class. And myopia is going to be soon an epidemic in India, I guess. So I would like to invite our first speaker, Dr. Nishant Shah. And Dr. Nishant will be speaking on why myopia progression. And I request people to be little quiet here. Yes, please let the speaker speak. Thank you.
Can we wait or?
Yes, you can start.
Okay.
And meanwhile, I would like to request Dr. Bhakulesh Kumar, Dr. Sameer Narang, Dr. Jitendra Jethani, Dr. Kapil Shah, and Dr. Indramohan Rastogi onto the dais. Start. You can start.
I'll start, sir. Shall I start? Good afternoon, everyone. Yeah, thank you for the opportunity. Yeah, I'll be presenting a brief introduction to myopia progression. And why is it necessary to know before we move on to the...
May we have some silence, please? May we have some silence, please? What is happening?
So my topic today is...
I request all the delegates to maintain little silence here. If you want to talk, you can go out, please. I hope you don't mind me saying that. Thank you so much.
Yeah, I'm Dr. Nishant Shah. I'll be presenting the basics of myopia progression before we proceed to the treatment modalities. So we know the basic definition of myopia, but what we are more concerned about is the axial myopia. That is what we'll be dealing with today. So the other two terms are pre-myopia. What do you mean by pre-myopia? Any refractive status of plus 0.75 to minus 0.5, along with some risk factors for myopia, is basically defined as pre-myopia. There is another definition for another term known as myopia progression, which will be dealing with axial progression actually. So it is defined as refractive change of more than 0.5 diopter or more and axial length progression of 0.2 mm or more in a year. That is known as myopia progression. So why are we more concerned about myopia and its progression? It is due to the prediction that we have. By 2050, almost 50% of the pediatric eye group school-going kids will be myopic. That is the grave prediction that will reach epidemic proportions. And as usual, every child, every eye, and every diopter matters. So current prevalence worldwide is around 20 to 25% in school-going kids, with high myopia around 3% of that. These are the basic projections from today till 2050. It is basically a worldwide phenomenon. None of the countries would be spared, including our own. So if we go into retrospect, in 1999, around less than 5% of the school-going children, that is 5 to 15 of the urban population, was myopic, which has increased to around more than 20% or 22% in 2020. And it is expected to rise 10% every decade, reaching to more than 50% by 2050. These are the basic studies that are done throughout the India, and all are predicting the similar numbers. So we had conducted a similar study at our institute. It was a multi-stage study. The first phase was basic screening, which showed around 20% prevalence in Baroda of myopia. Around 2% was high myopia. Second follow-up actually showed what we are trying to show here. Almost 56% of the myopic patients progressed. That is what we are looking at, myopic progression. 56% of the myopic patients progressed. Stage 3 was basically to look for the efficacy of two most important treatment modalities, that is low concentration atropine and myopia control glasses, which will be talked about later on. So what is myopia progression? As I said earlier, it is change in sphere by 0.5 or more, or axial progression of 0.2 mm or more. So it is not a single factor that causes myopia progression. There are multiple factors for that, including multiple genetic factors, hereditary factors, multiple environmental factors. There is a close interaction between these factors to cause myopia and further progression. This is axial myopia we are talking about. Genetic factors, there are almost more than 200 genetic loci that have been found to be associated with myopia. In terms of hereditary factors, involvement of history of myopia in one parent is associated with almost 2 times the more risk of having myopia in the kid. And as this study shows, if both parents are myopic, the chances of the kid having a myopic refraction is almost 5 times. Another study shows that history of myopia in sibling is also an important factor in predicting refractive status of the kid in future. Early onset of myopia, higher sphere at the onset, is a known factor, a known risk factor for higher chances of progression in future. Environment factors, there are multiple environmental factors. Most importantly, increased near work, less outdoor activity or daylight exposure. These are the 2 most proven environmental factors. Other than that, sleep deprivation is also a known factor. Peripheral refraction or peripheral hyperopic defocus is also a factor which causes myopia progression. these are the multiple risk factors that do cause myopia progression. So basic theories about myopia progression is dopamine release. Increased dopamine release is known to stop the myopic progression. That is what low concentration atropine targets. Increased outdoor activity targets. Peripheral hyperopic defocus, that is focusing of the rays behind the retina in the periphery, is known to stimulate the growth of the axial length. This is the basis for treatment by myopia control classes. Yeah. Thank you. Yeah.
Thank you, Dr. Nishant, for the wonderful presentation. Any questions for him, Dr. Nishant? We can take a couple of questions.
If there are no questions, Dr. Nishant, first of all, it was a wonderful talk. Any recommendation or guideline, because a lot of PG students are sitting here, what should be the minimum outdoor activities that one
So it is recommended to have at least average of 2 hours per day. Outdoor activity, not necessarily physical activity, but physical activity is also known to cause more dopamine release. Yeah.
Yeah, one thing I wanted to ask, if a patient goes for LASIK operation, any refractive operation, right? And after that, if he continues using this, iPhones and iPads, so are there chances that again the myopia will, because...
This was a very good question. We recently had a patient at our clinic. She actually had axial progression, myopic progression due to axial elongation. We started her on low concentration atropine, but she was not compliant or not comfortable with that.
But with after the age of 18,
yeah, it has been documented to even after 20 years of age. Yes.
So this can happen like
not directly due to usage of screen, but that is a mechanism known to cause myopia progression.
Okay, thank you.
Yes. Yes.
So now I would like to invite Dr. Anupama, and she will be speaking on myopic documentation.
Before she starts, I would just like to talk about this. Myopia documentation is important because, all the treatment that we are doing for myopia or discussing for myopia is to know whether the patient is progressing or not. So a progressive myope can be treated. Myopia is being treated since years altogether. We are, in this session, we are basically concerned about myopic progression. Yes.
Good afternoon, everyone. At the outset, I would like to thank Gujarat Ophthalmological Society, Dr. Jethani, for giving me this opportunity. Today, I'll be talking on myopia documentation. Why we need to document myopia progression? We need to document myopia progression. As Dr. Jethani said, we can treat or maybe slow down the myopia progression. Treatment for myopia always going to remain the glasses, contact lens, and the LASIK, but the progression we can decrease or maybe sometime we can control. Myopia progression, as Nishant said, every child matters, every diopter matters. As we know, with every increase in the diopter in minus power, there is a chances of increased RD, retinal detachment, increased macular atrophy, increased chances of glaucoma, and the onset of early onset of cataract. So, avoid these comorbidities associated with myopia. We need to control myopia progression. So this is now very, very clear for all of us, like we want to treat or like what we can deal with is myopia progression. And the second, which kind of myopia we can treat. Not all the kind of myopias we can treat. We can only treat the myopia which is associated with the axial elongation. We have different type of myopias also, but only axial elongation myopias we can deal with. So we have only treatment for the axial elongation myopias. So to understand this, we need to understand there are types of myopia. First is axial elongation myopia, where we are documenting on 2 consecutive visits. If the axial length is progressing more than 0.2 millimeter, then only we start the treatment for myopia. So any patient, if he is the first time diagnosed as a myopia, we are not giving the treatment. Second, until it is not proven, even the second visit, we are seeing the increase in the power, but still the axial length is not prolonging, we are not giving the treatment. And second type of myopia could be the refractive myopia, that is known as the index myopia. It can be due to the corneal or the lens curvature. And there could be many other myopias like secondary myopia in the ROPs or the drug-induced pseudomyopias and the corneal dystrophies related myopia. So when we are documenting, in the documentation, first thing is going to be history. Many of the institutes are taking it as a questionnaire. They give it before patient enters into your room, consulting room. They give you a questionnaire where you have to fill the details about the myopia. So as we know, if the earlier age of onset of myopia is there, then the myopia progression will be more. Parental myopia, if the one parent is myope, then there is a twofold chance of getting myopia in the kid. And if the two parents are there, then maybe there would be the 5 times chances of getting myopia. Ethnicity, Southeast Asian ethnicity is more prone, and even we are now. Outdoor time, if the kid is less than 2 hours outdoors, then there is a high chances of getting myopia. And the near activity, if consecutive, like at a stretch, if near activity is more than for 30 to 40 minutes and less than 25 centimeter kid is doing activity near any near activity, be it reading, drawing, or mobile, it can increase the myopia. And then the lighting condition, preferably the natural source of light should be there, but otherwise also the good lighting condition is needed. So we had to document everything because by his behavioral thing, we can predict the myopia progression. So each and every visit, we have to document this. So we can make, and if the patient is using glasses already, then we need to know the power, any other associated pathology, axial length, and everything we should be having with us. You can make any workup sheet of your choice, as you can make a separate workup sheet for each visit, and you can make a big workup sheet where you can enter at each and every visit. So that is going to be your own choice, your own clinic's preference. So what is mandatory? When we are checking any patient of myopia, what is mandatory at each and every visit? So first thing is going to be visual acuity, definitely the unaided and the best corrected visual acuity we have to measure. Cycloplegic refraction, as we know, the patient should be cycloplegic totally, and this has to be done maybe by cyclopentolate or hometropine, whatever is your choice, and still you feel there is disparity between the axial length and the power, then you may atropinize that patient. If you, your clinical acumen is saying this patient can't be this myope, this power is incorrect, then definitely you should atropinize the patient. PMT, to know the acceptance. Baseline keratometry should be done to know which kind of myopia it is, axial length, and eventually to see the progression. There is a new concept where axial length by CR ratio can predict the progression of myopia. Pupil size, because you are planning to go give the atropine. Atropine is like mainstay of controlling the myopia progression or maybe slowing down the myopia progression. So before starting atropine, you should be knowing the pupil size, accommodative lag, and the binocular examination. Near point of accommodation and near point of conversion should be known well before starting any treatment. This is like a specialized thing. Rest of the thing can be done by every one of us, but this is further evaluation. Many of the institutes have this new machine which is known as open field autorefractometer. Open field autorefractometer is a device where we can check the peripheral reflection, and by that, so when we are giving the glasses we can give in the condition where the patient has peripheral hyperopia, then only we can give the glasses. Topography, tear film assessment, because if you are giving the atropine for the longer time, then you should be knowing the tear film status, because this drop you are going to give for the couple of years, like maybe 2 years, 3 years, or 4 years, I don't know. Choroidal thickness is a new predictor, because they say the choroidal thickness is the earliest predictor of the corneal predictor of the myopia progression, because before axial elongation there is a choroidal thickness decrease happens, and then in myopia genetic analysis, many of the institutes have started doing the genetic analysis also. We have myopia calculators with us. The Brand-Handler Institute has their own myopia calculator. This is a free calculator available to predict the myopia. So they can show you, like if you give them treatment, what would be the progression, and if you don't treat this patient, what would be the progression. Thank you so much.
Thank you so much, and congratulations to the person who has created this session, because this is a very important topic, often less discussed in conferences, how to document progression. But I have only one question. A lot of time these patients are being seen by general ophthalmologist, and they may not have this topography, choroidal thickness access. So what would you suggest them? What are the 3 or 4 important things that they must document for all the kids coming with myopia?
So only 3 things are most important. I don't know, mic is not working. I think it's the time. So, no, my voice is quite, only the 3 things are most important. One would be the actual cycloplegic refraction. So it is actual myopia, because sometimes many of the pseudomyopes get treated. So cycloplegic refraction, everyone is doing, anyone is doing. Second is axial length. Everybody is doing cataract and everybody has that machine's A scans. Any scan will do. Even if you don't have those optical biometer, fancy one, you can do with this machine your own A scan, because you are going to repeat with the same A scan next time, because you are doing it periodically. And third thing, you are doing the keratometry. These are the 3 things. If you are able to do these 3 things, that's enough, more than enough. Because my first slide was showing this, and other equipments are very cheaper one, the NPC, NPA, you don't need a fancy equipment. The second slide is definitely these are not with any private practitioner. Most of the institute, the newer institute, the institutes which are the bigger institutes, and they have facilities. They are doing research, they are only doing these things. Thank you, sir.
Okay. No, I just wanted to add that, this is what is important, and everybody, all of us can do myopia practice. You don't really need specialized equipment. Just need to add some time, sit with the patient, tell the patient that, environmental modification is the key. Once you talk about it, next time when the patient comes back, that patient would be more than ready for treatment, because if they progress, you can show them documented that axial length is actually progressing. So that goes a long way.
So for that, some like the myopia software are also coming. So that is also just like a fancy item. Like we can show the patient, like within 6 months or within 1 year, this much axial length change has occurred. So this much amount of myopia will progress at the age of 18 years. It's a predictability value, but there is no clear-cut scientific data about that. But the software are coming, and we can show to the parents that if we don't do any aggressive treatment, then this myopia can progress up to this much amount at the age of 18 years. So that is also we can do.
Okay, now I would like to invite Dr. Jitendra Jethani. He is doing a lot of work on this myopia control. He runs a myopic clinic, and I think he is the best person to guide us and teach us how to control this myopia pandemic.
Thank you. Thank you so much, sir. Yeah. So before we move further, I think a lot of thanks to Dr. Sandeep Arora, Dr. Jagdish Rana sir, and Scientific Committee of Gujarat Ophthalmic Society for keeping this particular topic, which is, fast becoming not only the need of the hour, but also becoming a huge pandemic across, kids who are growing, who have screen time, and the progression is going on. We know that, this is happening across the globe, not just across the globe, in India also. So can we show the slides? Yeah, sure. So atropine, I would be talking about atropine and the current panacea, current understanding how atropine works, how atropine can be used, what are the concentrations which are available. Okay, it has come. So we will move on to so atropine is not, which is very new. Atropine is not something, which has come up just in the market or some 10 years back, or Atom was the first study. No, it is not like that. You can see a list of, a list of articles, a list of peer-reviewed, published articles, RCTs, which were published prior to Atom also. So it was very well known that atropine does work for myopia control. What has come now is the concentration which has been reduced to 0.01 and 0.05 so that, you know, the amount of side effects go down. So you can see starting from 66, 83, a couple of studies just before Atom 1 in 2001, you can see 2006, and the famous Atom 1 study from where all this started in 2006. So currently, when we don't have a specific theory as to how atropine is working, what we have is a lot of hypotheses. So these are a list of hypotheses, whether it works at the level of retina. One thing we know that it is a non-selective muscarinic antagonist. So we know that it does have effect on muscarinic receptors, but whether it is at the level of retina, whether it is at the level of sclera, and the current understanding whether it is at the level of choroid, we are not really sure. What is happening is, as I think Dr. Anupama said, that, you know, it is the choroid which shrinks first, and when the choroid shrinks, it gives way to the retina to grow. Whether this occurs because of peripheral hyperopia, whether this occurs because of dopamine release, whether this occurs because of scleral remodeling at the level of sclera, we are currently not sure. But these are multiple studies, and for the time constraint, I will not go into the depth of it, but you can read this wonderful article by Aradhana on biological mechanisms of atropine control of myopia. It's a free article. You can download and read it. This is the summing up slide of what are the mechanism of action for atropine. And also, you know, since atropine has been used by all of us in our post-graduation for cycloplegic refraction, we all believe that it does have some effect on the lens thickness and power. Some work is published. I will direct your attention to Dr. Rohit Saxena, RP Center. He has published wonderful work on effect of low-dose atropine on lens power. But they concluded that, you know, it is not, the complete effect is not on the lens power, but minimally it does affect lens thickness. Although other studies, like the study from Havid Henson, and there are some follow-up studies, especially from US, UK, who do support that there is not much effect on lens power. But I think where this can be placed is when there is a rebound, maybe it is because of the lens power which goes back to the size which it was. So there are few things which are still unanswered, whether it is just the muscarinic receptors or it also inhibits retinal signals to sclera, whether there are long-term side effects, because we are going to use atropine for almost 4 to 5 years. It is not that we are going to use it only for 6 months and stop. And whether it should be used as drops or we can have other form of delivery methods which directly affect the receptors where we want atropine to be there. So this was the classic study, Atom 1 study published in 2006. We all talk about this. This particular study had a very good power, 400 children, randomized, 1% atropine versus placebo used for 2 years. So, you know, they have ticked all the boxes for evidence. Atropine 1% does work, and, you know, they published their data. What they did was they followed it up and published their study in 2012, where they had a 2-year data where they compared 0.01%, 0.1%, and 1% and found that 0.01% still works. And actually, there was not a placebo because they thought that when you dilute 1% to 0.01%, it actually acts like a placebo. So this was also answered by LAMP 1, where they compared 0.01 with a placebo and 0.025 and 0.05. So now you see we have come up from 1% to 0.1%, and from 0.1% we have come to baby steps of 0.01%, double it 0.025 and double it 0.05. So we have a very small window now. We have 0.05, 0.025, 0.01 and placebo. So this is LAMP 1 published during COVID, LAMP 2, LAMP 3. Yeah, this is LAMP 2, LAMP 3, LAMP 4. So what has come out of all these LAMP trials is that Atom low concentration atropine works. 0.05 works better than 0.025, which works better than 0.01, which definitely works better than placebo. The effect of atropine comes as a summated effect. Long term, after 3 years, 0.01 is comparable with 0.05, but only at the end of 3 years. 0.05 works faster. So obviously it is a dose dependent response. So the side effects and rebound rebound effect will also be more in 0.05, but they felt that they were pretty tolerable when it comes to using 0.05 compared to 0.025 and 0.01. So in our work, we found that almost 8 to 10% of patients do complain of receded near point of accommodation and also problems in when they go out in the sun, which is photophobia because of pupillary dilatation. So obviously, if you increase the dose of atropine, the effect would come, but at a point where there will be some side effects. So if the patient is able to tolerate, so what would be the indication for 0.05? Obviously, younger children who can tolerate it better. Now, whether age effect on treatment response to 0.05, younger age is associated with poor treatment response with low concentration. So you have to escalate the dose. So we will just skip this, and these are some of the studies which we have done. I think we really don't have time for that. So we will come to the two last slides. So the first question is whether it is safe to use low concentration atropine for a long time. Bulk of work we have done, published work is there by other reviewers, other publishers. I think now if you go on PubMed, you will see more than 800 to 1,000 studies on low concentration atropine, which has been used for more than 5 to 8 years. In fact, there is a study published 2 years back in JAMA, Atlas study, which they worked out on the patients when Atom 1 patients whom they saw in the long term and what was the effect. So atropine has been in the market for now almost 15 to 20 years. It works, it is quite safe. And Atom 0.05% has just been launched 1 year back. Fortunately for us, the company was kind enough to give it to us 5 years back. So we have been using this. Whether it is safe to use in higher concentration, yes, it is safe. But as Dr. Anupama said, you have to check near point of accommodation, near point of convergence, and check for pupil size and accommodative lag. This is the last slide. And what are the indications? Initial patients who are fast progressors. Any patient who progresses more than 0.75 diopter in a year is definitely a fast progressor. Younger patients, because their tolerability is better. You know, they can tolerate better because their amplitude of accommodation as such is better than elder patients. Non-responders to 0.01. So if you have already using 0.01, there are patients who are not responding. You can use or escalate the dose. Combination therapy patients who are not responding only to glasses or only to 0.01 can be escalated. Rebound, whether it is more, of course it is more because it is a higher dose. So you can de-escalate it to 0.01 and then stop. So atropine 0.01. And this is the last slide. Just remember one thing, that despite all this, you will see that even LAMP study had 30.4%, 48.4%, and 56.2% patients who are not responding at all to atropine 0.05, 0.025, and 0.01. So there is nothing wrong when you have a non-responder. Don't think that, atropine has not worked. You can suggest another mode of treatment, another mode of therapy to treat myopia. And for that, we have our next speaker for optical treatment of myopia. So this was regarding atropine. I know I went very fast, but this was a huge topic and I had to sum up in 6 minutes. So thank you so much for the opportunity.
Thank you so much, sir. That was a wonderful talk. And only one question again, when to start, when to stop, and which are the patients where to avoid?
Okay, so normally when to start is when you have a myopia patient who's progressing. So without progression, atropine has got no role. So you don't start them at the first instance. There is no role of atropine in myopic astigmatism. There is a role when there is a progression. Progression means axial elongation. There should be evidence that patient has axial myopia. It doesn't work in curvature myopia. It doesn't work in index myopia. When to stop? When you have at least 2 years where patient has not progressed or patient is above 15 years. For some patients, some doctors, the cutoff of 15 years, we stop after 17, but that is variable. Bulk of the evidence-based study will tell you that it will be only up to 15 years because they cannot study in 17 years because the natural curve stops at 15 or 17 years. So, they will get rejected in their peer review. And when not to start, if there is a history that patient has an allergy or something to atropine, then that is the contraindication.
Yes, I'm Dr. Sharad Lakuti. I'd like to have a question because myopia is very important these days, and starting any therapy like atropine and all has to be very judiciously has to be put forward in front of the patients. I have a question here that when we are asking all international opinions that even you have to be in the sunlight for children for at least 2 hours a day, or the screen time has to be reduced, and the atropine has to be used. All these things, have there been any parallel study, and even the lenses, particularly the myocare lenses and other type of lenses, a study to prove that one line of treatment versus the other line of treatment, the deficiencies versus whatever the atropine effect it is there? Because in one of the study it has said that if there are genetically, if they are not having myopia, and if the parents are normal, they don't have myopia, the chances of that if the patient is using or the child is using 1 hour screen time, the possibility is 5% developing myopia, whereas if he's using 4 hours a day, that is the possibility is more than 90%. So all these things have to be combined in a form, in a way that we can actually say that this is the reason, and for this reason, this mode of treatment is the right way to go. So I'd like to have your opinion on the role of atropine specifically in such situation.
So I think fortunately or rather unfortunately, in India we don't, so there's a device known as Cloud Clip. We tried to make our own Cloud Clip, but since it was already available, so Cloud Clip measures how many hours you are sitting indoors and how much near work you are doing. Unfortunately, we don't really have data to correlate that, near work, this much amount of near work with atropine would respond and this much amount of near work would not respond. So that is obviously a confounding variable. But the first line of treatment, whenever a myope walks into your clinic, even if he is progressing or not progressing, you have to set a baseline that you have to stop near work. What is near work? Anything close to 30 centimeters is near work. So it's not that they cannot study. So the first question from the parents is that if he will not do near work, how he is going to study? So near work is not, near work is not that he cannot study at 30 centimeters. And the second intervention is environmental modification, that is to sit outdoors in open areas. So typically these two are the baseline, but they would be confounding variables. I don't think that we can, give more atropine to the person who's sitting more closer, because it is very difficult to measure these things. These are huge variables. That is unfortunate, but that is true. And how their genetic profile, what is the epigenetics, how their genetic profile responds to these environmental factors is also not known. They have done a lot of work. In fact, in 80s, we only had one gene. Now we have more than 200 genomes which have been identified, which are responsible, and now they are moving on to single nucleotide polymorphism, because they are more into SNPs, trying to find out where that single nucleotide polymorphism has occurred and trying to isolate that this particular genetic profile would respond to near work and indoor sitting.
So now, due to paucity of time, we are not taking any more questions because we are already running half an hour late. So I would like...
Samir, just to when to stop, as Dr. Jitu has already mentioned, but one thing we have to remember, we have to not stop abruptly, but we have to taper down the atropine. Gradually we have to stop, and again we have to measure whether it is progressing or not, and then we can stop. But it should not be stopped suddenly, otherwise there will be a rebound effect.
So,
yeah, please. We can.
Yes.
Okay, now I would like to invite Dr. Ankit Bhavsar, and he will be speaking on newer therapies for myopia. Dr. Ankit Bhavsar.
Good morning, friends. I'm thankful to AGOS for inviting me. Now, Dr. Jitu has covered the very well-established modality of treatment for myopia control. So I will go through some newer modalities which is not widely accepted, but authors in the world, they have researched very well, and they have come up with promising results, and probably will get more modalities for myopia control management. Before going to newer modalities, I will go through some old modality known as orthokeratology, which is very old line of treatment. It is a corneal reshaping therapy done by rapid gas permeable lens, and it is to be wear overnight 6 to 8 hours daily, and during daytime patient will get freedom from the glasses, and patient will have clear vision without the glasses. Basically, it creates the peripheral myopic defocus, which tends to reduce the elongation of the eye. So basically, it is a reverse geometric design lenses where there will be a central push of force and peripheral, mid-peripheral pull force. You can see here in the image that it will lead to central flattening of the cornea and mid-fairy 7 millimeter steepening of the cornea, which leads to the myopic defocus, and which is the probable mechanism of action to prevent myopia progression. And particularly in orthokeratology, there will be the redistribution of anterior corneal tissue rather than the overall bending of the cornea. So it will not change the entire curvature of the cornea, but it will change the anterior surface, particularly the epithelium curvature of the cornea. And it is very well known that around 15 millimeter change in the 15 micron change in the epithelial curvature leads to around 2.5 to 3 diopter of correction for myopia. And it can be given for age group between 6 to 14 years, and it can correct the power up to minus 9 diopter of spherical and 3 diopter of astigmatism. And adverse effect, the most common drawback of the ortho lenses is the risk of corneal infection, and there may be some corneal staining, and success rate for ortho lenses is 60%. Now, another contact lens is known as the dual soft or multifocal soft contact lens. It works same as the peripheral defocus glasses, like what we are using, the DIMS or Hall technology. It is to be wear 10 hours per day, at least 6 days a week, and success rate is around 40 to 50%. Another good promising therapy known as repeated low-level red light exposure to a child with myopia to prevent the progression, where child is exposed to a red light of 650 nanometer, approximately 1600 lux, and session will be 3 minutes per session, twice a day, 4 hours apart minimum. It is to be given 5 days a week, and the basic mechanism of action for this modality is it increases the choroidal thickness, just like atropine therapy, which helps to prevent the myopia progression, and it has a good promising outcome which prevent or decrease the myopia progression. It is studies in the mainly Chinese population. It is also observed and documented that in high myopic patients, there has some documentation that axial length was decreased when this therapy was given. But limitation of this therapy is that it is studies only for 1 year. Long-term data is not available, and rebound phenomena was not measured, and there was no clarity about the foveal photoreceptor toxicity, so it is not still widely accepted by the clinician worldwide. Another therapy, another modality is the dot glasses, side glass spectacle lenses. How does it work? So it has a central aperture. It is a spectacle lens. So it has a central aperture of 5 millimeter and peripheral micro dots, which leads to the decrease in the little contrast to the eye, and which it mimics the natural contrast. So it will help to reduce the myopia progression and axial length elongation. This is a simple design of that dot glasses, and it was studied in the North America for 4 years, and they have come up with some good results. Now, EDOF contact lenses, just like EDOF intraocular lenses, it has the same mechanism of action. It is studied by the LV Prasad Eye Institute, and it was the contact lens, it is a soft contact lens, and it is designed by the Brian Holder Vision Institute. It has come up with some good results also. And to come with the last slide, there is some role of AI in the myopia control management to basically to document. So there is some algorithm developed, deep myopia algorithm or deep myopia system, where they have taken the pictures of the fundus and they have collaborated that just combined with the history, lifestyle and family history, and they have come up with some strong data that after doing imaging of the fundus, one can comment that this child may develop the myopia. So to some extent we can prevent the onset of the myopia, or we can delay the myopia. And in particular, it can comment according to the fundus picture and anatomy of the fundus that this patient will progress rapidly and end up in the high myopia. Thank you.
So thank you so much, sir. So in the interest of time, we take questions later. And now I would like to invite Dr. Vibhuti Kashyap for his talk on retinopathy of premeditated, very important topic. Dr. Vibhuti is doing excellent work in retina, and he has won a lot of international awards. And he is an alumni of RP Center. Welcome, Dr. Vibhuti.
Good morning, everyone. At the onset, I would like to thank AGOS for giving me this opportunity to come and present my work over here. And I wish Dr. Divyang Brahmbhatt, Dr. Jagdish Rana sir, and Dr. Jethani sir all the best for the elections. So before starting my talk on this topic, I would like to share two things why this study is important. This study was conducted by us when we bought the first pediatric angiography machine of Bihar, Jharkhand and West Bengal. When we bought this, people questioned the clinical utility of it, and we also questioned the clinical utility of angiography because we never had a blueprint of what is the clinical use of it, although much has been talked about the FFA in ROP from the research point of view. This study was the first presentation to see the face of podium in World ROP Congress ever from Jharkhand and Bihar since past 20 years. So I'll start with it. We have named it AIM ROP, Addressing Inaccuracies in Management of ROP. So the purpose of this study was to evaluate the clinical utility of FFA in addressing the inaccurate interpretation of disease activity and regression in eyes previously treated for ROP. It was a prospective intervention study of 200 consecutive eyes previously treated for ROP elsewhere who were received at a tertiary care setup in India. Treatment history, follow-up schedule, retreatment advice, and presenting fundus pictures were evaluated. In every eye, the FFA, conventional FFA was performed, intravenous route. Persistent avascular retina activity and leak was taken as the criteria for activity, and regression was defined as absence of active leak and PAR. So the results were as follows. 13 eyes had retinal detachment post-treatment and were excluded from the analysis, such as this eye. It was a case of stage 5 ROP post combined therapy for zone 1A ROP. This was stage 5 ROP status post anti-VEGF. This was a stage 4 ROP status post laser photocoagulation for stage 4. Now here's the interesting part. 51 eyes, that is 26%, slightly more than 1/4, had objective discrepancies in final diagnosis of disease activity. 16 eyes who were advised further course of retreatment were actually they did not have any activity and consequently received a non-interventional follow-up, such as this eye. In this eye, we can see there is this eye is a status post combined therapy for zone 1A ROP. Because of this ridge, it was diagnosed as a persistent case of persistent activity, but on FFA there was absence of leak and it was just a reactionary ridge rather than a reactivation ridge. In this case, this case was diagnosed as residual activity, but because of the vascular tortuosity that was persisting, but on FFA there was no leak and PAR, and actually was a completely regressed disease. This is a 3-week status post both eye anti-VEGF, clinically diagnosed as persistent AROP, advised repeat anti-VEGF. This was not AROP to begin with. It was bilateral congenital vascular tortuosity with no leak and PAR. 35 eyes who were further advised non-interventional follow-up consequently underwent FFA-guided retreatment, such as this eye. This was diagnosed as regressing ridge because of resolution of the tortuosity, which actually was an active ridge showing active leak on FFA. And it collapsed post-treatment, post-laser augmentation and anti-VEGF. 10-week status post both eye anti-VEGF for zone 2 posterior, diagnosed as zone 3 vascular, had actually persistent avascular retina in the periphery, and it was treated with laser photocoagulation. This was 10-week status post anti-VEGF, diagnosed as a regress disease with vascular zone 3, had PAR in zone 3 and zone 2, treated with laser photocoagulation. This is a case of combined therapy, diagnosed as regress disease. This actually had persistent avascular retina posterior to the laser marks, which required laser augmentation. This was a case of status post combined therapy, diagnosed as regress disease. In view of tortuosity, we did the angiography, and this is what we found. There was reactivation within the laser marks, a very rare type of reactivation with persistent avascular retina posterior to the laser marks. And this was again treated with laser augmentation. And after 3 months, there was no leak and PAR. So 136 eyes, that is remaining 68%, had no objective differences. This is clinical reactivation post anti-VEGF with ridge and leak, treated with photocoagulation. It was diagnosed correctly. Uniform zone 3 passed post anti-VEGF, which was advised for laser photocoagulation. Status post combined therapy, diagnosed as regress disease, showing no leak and PAR. Status post anti-VEGF for zone 2 posterior, diagnosed as zone 3 vascular, requiring no further anti-VEGF. So basically what this study highlights is a possible routine clinical underutilization of FFA. Primarily a research tool, FFA may be implemented more routinely in routine clinical practice for ROP management as a routine protocol to objectively confirm disease activity and regression post-treatment, which may help in preventing undertreatments and overtreatments of the disease that can lead to a potential cause of, that can lead to potentially an iatrogenic cause of blindness that is caused in retinopathy of prematurity. Thank you.
Thanks a lot.
Any questions from the audience? Or else we'll move on to the last talk of this session by Dr. Kalpit Shah. And Dr. Kalpit is going to show us some new classes for myopia control. Yes, okay.
Yeah, good afternoon. Just because of the shortage of time, I am not going into the detail for different glasses for the myopia progression. But just to understand why we need some glasses for the myopic progression, we have to just understand the basic anatomical part. Like when the eye is normal having a myopia, what happens, the rays coming from infinity are focusing in front of the retina, but in the peripheral part, you can see the rays are focusing behind the retina. So what happens that the retina gets stimulation, that eye is little smaller one, so it need to increase in the size so that the peripheral rays will focus exactly on the retina. So due to that stimulation, the retinal that axial length will increase, and that will increase the myopia. So this is the basic theory for the uncorrected myopia which having a progression, and that could be the one of the reason like why the high myopic patients are not progressing so much, because when there is a high myopia, the peripheral rays will focus still in front of the retina. So that could be one of the reasons. Still we are not knowing the exact theory, but that could be the one of the reasons that high myopic are not progressing much, while the mild and moderate myopia will progress. So that could be one of the reason. Now, when we give the glasses, the normal single vision glass, what happens? Now the peripheral rays, the distance rays coming from the infinity will focus exactly on the fovea. But still, because of the retinal contour, the peripheral rays are focusing behind the retina. And that's why That's why the retina gets constant stimulation, they increase the axial length, so that the peripheral rays will also focus on the retina. So in process of this, the axial length still increases and the myopia will progress. So to correct this, now we have a different glasses available. So in that case, the peripheral hyperopic defocus will convert into the myopic defocus, so that the peripheral rays, so what are these different glasses? They have a, in the central part, they have a corrected myopia glasses, but in the peripheral part, they have a hyperopic elements, so that the plus elements will convert the more rays from the peripheral, so that these rays will focus in front of the retina and there would be no stimulation for the myopia progression. So this is the basic theory for the myopia progression, having a different glasses. That the theory is called as a defocus theory. And for that, the defocus, we have a different type of glasses, like the Hoya has developed the DIMS, that is a MioSmart, that Stiles has developed that the whole technology, that Essilor has developed that Stiles. The third one, that is the Zeiss has developed with the MyoCare. Each have a different technology with that glasses manufacturing. And the Nova has a horizontal progressive addition lens. Like normally we have a vertically progressing addition lens, but if we make a progressive, the horizontally progressive addition lens, so that will focus the peripheral rays in front of the retina. So there would be no chance for the myopia progression, or we can say less chance for the myopia progression. But before giving the defocus glass, one should first understand whether this myopia progression is due to a peripheral refraction or not. And for that, we have to make a habit, when we do the refraction in the children, we have to do the peripheral refraction. If the difference between the central refraction and the peripheral refraction is more than 0.75, then and then there is a role of defocus glass. But if it is due to accommodative leg, myopia could be of two reasons. One theory is like this, what is that we can say the peripheral hyperopic defocus. The second theory that related to the near work, that is the accommodative leg. So if there is an accommodative leg, so there is a chance, or that in this case we need to give the progressive glass or the bifocal glass. So these 2 points we have to understand, whether it is a peripheral hyperopic defocus or whether it is an accommodative leg, and accordingly we have to give the glasses. And same like the defocus glass or the progressive glass, we have a contact lens that already Ankit has described, that MySight ability and the multifocal contact lens. So just these are the different glasses available. That Hoya is a MioSmart, the central clear, and the peripheral part has a fixed power, that is a plus 3.5. Then, regarding when we give the defocus glass, the some points we have to be very selective regarding the choosing the frame. Here, like sometimes that myopic patient or any children could have a squint also. So instead of the binocular IPD, we have to measure the monocular IPD, and then we have to ask the manufacturer to fit that glass. Second, we ask the parent to first select the frame. And with that frame, we ask the child to come, and we have to make the marking for the pupillary. What happens, like when we say or when we write the IPD, it is only the horizontal IPD. But we have to make the vertical height adjustment. So we have to make the line passing from the horizontally from the pupil as well as vertically passing from the pupil, and we have to make the centration of that frame. So first select the frame, ask the child to come with that frame, and we have to do the marking. And we need little larger frame compared to the normal we prescribe in the single vision lens. So the Stiles here, that Essilor has come with the different, like a progressive glasses. The central have a more plus power, and as we go into the peripheral rings, the power, central has a little more less power, and with the peripheral it has a more power, so that will give more hyperopic defocus. Zeiss has come with the different technology, that the back surface having a clear focus design. So what happens when we prescribe the defocus glass, when the child is looking from the periphery, there could be a little blurring of the vision. But this blurring of the vision can be taken care by the Zeiss MyoCare lens. Ortho-K already Ankit has described. So these are the different lens design which can be, we have to prescribe, we can prescribe when there is a myopic progression. But we have to be selective, which case we need to give the glasses.
Thank you, Kalpit, for the wonderful presentation, something new to understand. So now we come to the end of the session.
Dr. Kankaria sir wants to give some comment. Yes, sir, please.
Sir, you can come to the stage because we'll be inviting you to give this mementos also.
I just wanted to add a few comments. Number one, the repeated low light therapy, the red light and the amber light therapy, we purchased that Australian machine and reverse engineered that machine for a very affordable cost we can make to the patient, because that machine costs nearly 2.5 lakh rupees. So for the patient's parents to buy that machine for every child is not feasible. It really works very well. Really works very well. The second thing is that if we give yellow tinted glasses, basically what we want is to cut off the blue wavelength going onto the choroid, because blue wavelength induces the scleral thinning. Red wavelength induces the choroidal thickening as well as the scleral thickening. So cutting off the blue wavelength going onto the retina is the key. And I'm also working with another group who is working to give methylene blue a tablet per oral and then expose the posterior pole from the temporal aspect, asking the child to look on this side with red light, which induces the posterior pole scleral thickening. Same thing like what we do is for cornea cross-linking, this will be a scleral cross-linking. So a lot of work is going on, and many new modalities are coming. And these three are really going to be very promising. Thank you.
Thank you so much, sir. And we all know, sir, as an innovator. I hope he will come out with something for this also. Now I would like to invite Dr. Jethani, sir, to collect his memento. Dr. Nishant Shah.
Anupama Noti. Noti is not.
Dr. Anupama. Are आप भी आओ Sonali. You also come now. Come in. Next one. Dr. Sonali. नहीं ये है ना हमारे, अरे वो देंगी. ठीक, किसका ले लिया उसने? उसको देना है तुम्हें. डॉक्टर अंकित. डॉक्टर कल्पित सर नेक्स्ट. डॉक्टर निशांत. So I think done, right? So thank you so much. So all of you can stay here so that we can have a group photo. In the meanwhile, I would like to invite the panelists for the next session to take over the stage. And we had a wonderful session. We started with myopia progression, and to the takeaway message is please ensure the kids go to outdoor for at least 2 hours per day. Check axial length keratometry and cycloplegic refraction with each follow-up. And use atropine, not in all, but in cases of progressive myopia, and new methods you can use depending the cases. Thank you.
So quickly we start next session for before lunch, and it is on glaucoma. So I request all presenter to be ready before one lecture finish. Okay. So Shital, start.
More chairs. Excuse me. We need more chairs on the dais, please. Okay. Now we'll start the session with Dr. Jatinder Bhalla. He is an alumnus of the Maulana Azad Medical College, New Delhi, and was the head of department, senior consultant, and academic in charge at DDU Hospital, New Delhi. So Dr. Jatinder will be talking to us about target IOP concept and practical application. Yes, sir.
That's great.
So we have the session chairman, Dr. Hitesh Ramanuj, convener, Dr. J.S. Bhalla, co-chairman, Dr. Jignesh Gosai, moderator, Sheetal Jani, co-convener, Dr. Vinita Ramnani, panelists, Dr. Meher, Dr. Kamini Prajapati, and Professor Manisha Rathi, and myself, Professor Arvind Maurya. First speaker is Dr. J.S. Bhalla from New Delhi.
Yeah. At the outset, I'm thankful to AJOS for this opportunity, and Dr. Jagdish Rana sir and Dr. Divyang. The topic I'm going to cover is the concept of target intraocular pressure. We all are born with about 1 million ganglion cells in each eye, and about 10,000 ganglion cells are lost annually from aging alone. And it is said that if every human being lived up to age of 150 years, almost 100% of us will get glaucoma. We know what is glaucoma. These are chronic progressive optic neuropathies in which raised intraocular pressure is the single most important modifiable and treatable risk factor. What exactly is normal intraocular pressure? We all harp about this value of 21 millimeter mercury. This is actually a statistical construct. There was a survey which was done way back in 1966, where they found that mean applanation intraocular pressure was 15.9 in males and 16.6 in females. So 2 standard deviation above mean accounts to about 21 millimeter mercury. So this 21 millimeter mercury is actually a statistical construct. So what is target intraocular pressure? European Glaucoma Society and AAO has given that mean intraocular pressure that is achieved that prevents further progression, and World Glaucoma Association said that it is the estimate of the mean intraocular pressure at which risk of decreased vision related quality of life due to glaucoma exceeds the risk of the treatment. So target intraocular pressure is actually a guesstimate range of intraocular pressure that is expected to slow down the progression, and while chalking out the target intraocular pressure, we have to assess certain parameters, and every patient needs to be individualized. So these are ocular and external follow-up intraocular pressure, perimetry, which should be reliable perimetry, central corneal thickness, presence or absence of pseudoexfoliation. The non-ocular parameters is age, because if the patient is elderly, then we need not be very aggressive in achieving the target intraocular pressure. And these studies, CISTES, EMGT, and Advanced Glaucoma Intervention study has told us that elderly the patient, more is the progression, and ocular perfusion is decreased in certain comorbidities like diabetes and hypertension. And if there is a family history of glaucoma, we need to be more aggressive in achieving the target intraocular pressure. We all know that normal disc appears to withstand pressure close to 28 to 30 millimeter mercury, but if there is a cupping at either of the poles, and if both bipolar knotting you cannot, then the target intraocular pressure has to be less than 15 millimeter of mercury. Perimetric staging should be done in every patient depending, and then we classify depending on the mean deviation and pattern standard deviation as early defect, moderate defect and severe defect. So perimetric staging is very important, and EMGT told us that if there is a greater mean deviation loss at baseline, that it becomes a risk factor for greater progression. So having ascertained the degree of visual field damage, baseline intraocular pressure and optic nerve head parameters, we need to set an intraocular pressure that would prevent further damage. And what are the methods of determining target intraocular pressure? One is threshold or cutoff value, second is percentage reduction, and third is formula-based values. Percentage reduction and threshold IOP are the most popular methods used in many randomized controlled trials. Threshold value, advanced glaucoma intervention study told us that maintaining a target IOP less than 18 millimeter mercury in moderate glaucoma showed no progression over 8 years of trial. Percentage reduction has been used variably. OSTS found that IOP reduction of 20%. CNTGS showed that reduction by 30%, achieved 5-year progression in 12% of treated patients as against 35% in untreated eyes. EMGT showed that when IOP was lowered by 25%, early glaucoma 72% progressed off treatment as compared to 45% on treatment. So there was a statistically significant decrease in the progression. And sisters also showed that mean IOP reduction by 38% and 46%, the 15% progressed and 15% improved. There are formulas also for setting target intraocular pressure, not very popular clinically. There are medico-legal considerations because most of the professional glaucoma societies across the world now recommend the use of target intraocular pressure. So failure to do so may confer medico-legal liability in the event of a glaucoma-related claim. So we should set a target intraocular pressure, but don't mention on the OPD prescription of the patient. You can keep your own records because failure to achieve what you are targeting may land you up in trouble. There are arguments against target intraocular pressure because the concept of 18 millimeter mercury in ages was a wrong interpretation, and there is no adequately powered prospective or retrospective study which shows the value of target intraocular pressure. So if we compare the benefit versus risk, we have to also take into account the side effects of the drug, the cost of the drug, and adverse consequences if we are hell-bent upon achieving the target intraocular pressure without seeing other parameters besides intraocular pressure, which may be important. And then there is a concept of dynamic intraocular pressure concept. This target intraocular pressure has to be changed at the follow-up visits, because if there is progression, we have to change, and then also the diurnal variation has to be kept into mind. Dr. Kuldev Singh has taught us that the concept of target intraocular pressure is more useful in advanced glaucoma than in mild to moderate glaucoma. But so this has led to consensus expert recommendations by CGIC guidelines, American Academy of Ophthalmology and European guidelines. They all advocate the use of target intraocular pressure. I'll just take a minute more. And World Glaucoma Association consensus statement promotes the use of target intraocular pressure. But there are potential limitations, that is lack of validation, which method is best, target IOP is a guess, IOP fluctuation, and other non-IOP factors like transcribrosal factors. So this is the most important slide which I find in my presentation. If there is an ocular hypertension or PAC without raised intraocular pressure, target intraocular pressure less than 18, early damage 15 to 17, moderate 12 to 15, and advanced glaucoma we have to keep less than 13, that is 10 to 12 millimeter mercury, and normal tension glaucoma 30% reduction from the baseline. But secondary glaucomas and pediatric glaucomas are different ball games altogether. So the above factors cannot be applied with similar predictability in pediatric glaucomas. So I'll also take this opportunity to request all of you to support my candidature for the post of Joint Secretary AIUS. Thank you everyone for your kind and patient hearing.
Thank you so very much, Dr. J.S. Bhalla. My question for the panelist, Dr. Vinita Ramnani. So, regarding the target IOP, do we need a customized, tailor-made approach? Is it the way forward?
Yes, it has to be individualized, not only each patient, but each eye also, because angle closure glaucoma, they behave differently in each eye. And it has to be a range. It is not like a fixed digital number that 8. It has to be 8 to 12 millimeter of mercury, and it has to be repetitively checked and can be reduced or can be increased depending upon the disease progression. So what is more important is you have to reduce the progression of the disease, the speed at which the disease is progressing. Our main aim is to control that progression.
And one more thing, nowadays we are seeing more cases of pseudo-exfoliation as well. And patient has history of acute angle closure glaucoma. That should also keep in mind when we are risking the factors in mind. Thank you.
Thank you, Dr. Jatinder. I would now like to invite Dr. Manisha Rathi. She's a senior professor and unit head at RIO PGIMS Rohtak. She's going to talk to us about late presentation of phacomorphic glaucoma.
Thank you so much. And I'm really grateful to all the people here who are fighting their hunger to attend this session and not joining the lunch crowd. So when we talk about hunger, I am going to talk about those who are perpetually hungry, who do not get food, the forgotten, the neglected, people in rural areas, the underprivileged. Why are we talking about this late presentation? Because see the magnitude of the problem. In 2021, I have published this article in which in 30 patients of hypermature cataract with delayed presentation, 8 of them, 27% were of lens-induced glaucoma. This is our typical patient who comes to us. We are a tertiary eye institute who are a government institute. So let's take a look here. A lot of us are aware, but statistics. The richest 1% in the country own more than 40% of the country's wealth. And I know a lot of them are in Ahmedabad. A lot of people sitting here also maybe, yes, madam is nodding her head, maybe in the top 1%. But the lower 50% hold only 3% of the assets. In our experience, this is a series of 24 patients over 50 years of age who presented to us. First of all, phacomorphic glaucoma itself is a delayed presentation. But within that also, when they come very late, it is alarming. So why is this happening? Let's take a look. No surprises here. In women, it is much more common to present late than men. Residents, rural. We mainly cater to the rural. So this may not be really reliable. Education status, just see, even in today's India, how many of our patients, 83% were illiterate. Occupation, most of them were not earning. So homemakers, they were not earning money. Socioeconomic status, can you imagine people living with less than 5,000 rupees per month of income? This was 66% of our patients. Causes of delayed presentation, in males, other eye good vision or pseudophakia, which was throughout. 50% of our patients had pseudophakia and good vision in the other eye. Females, they did not want to disturb their children who were going for work to take leave for them. Lack of communication and lack of awareness. What are the reasons? In both rural and urban combined, it was a lack of awareness. So we've also done a study on awareness of glaucoma, even among glaucoma and non-glaucoma patients. And this was followed by family issues. So just to tell you, lack of awareness and a very loving, typical family. So these issues also come up. Duration as presentation. Already it's very late when a person gets phacomorphic glaucoma. But even after that, the majority of patients, 1/3 presented at 7 to 14 days after the phacomorphic glaucoma set in. And more than 6 months, these 3 patients came more than 6 months later. So you can imagine 3 of them were PL negative. 1 patient came at a duration of 3 to 6 months. So that was PL-PR inaccurate. Presenting intraocular pressure, more than 40 in more than half the patients, in 58% patients. The presenting vision, as you can see, the PL negative were more than 6 months and PR inaccurate was the 3 to 6 month patient. This is one of the post-operative. We have been very lucky, although they tell us the pressure of 50 for 3 days or 5 days will knock out the vision. Although there are field effects, but the patients do get good vision. I do not have time to show you a typical W trabeculectomy that I'm doing for these patients, but it's very effective. And status of the other eye, most of them were pseudophakic. So a lot of them had gone to ophthalmologists. And a lot of them were sent back home with painkillers. So that is another alarming thing which we need to look at. These are the post-operative results of the patients who presented within 7 to 14 days. So in other studies, late presentation causes can be 53 kilometers or more away from the center, pressures above 40 millimeters of mercury, lack of awareness, lack of education, lower socioeconomic status. What do we need to do? Education and awareness program. Improved access to care, patient counseling and support. So we have an increased need for screening programs, outreach, go to their doorstep. If they don't come to us, we must go to them, because glaucoma remains the leading cause of irreversible blindness in the world. So this is us at one of our camps. We had 885 patients in 1 year. Dr. Kirti had told me not to wear this black suit, so I wore it every year. The next year also I wore this. The next year we had 750 patients. We screened everyone 40 plus. For only the intraocular pressure, they came back to us. The results will be published. You will be surprised how many people did finally have glaucoma among them. I'm still learning. This is our OPD on any given day. I'm still learning to provide quality to quantity. Thank you so much for listening to me. Thank you.
That was a wonderful presentation, Professor Manisha Rathi. I think India is a land of extremes. In cities, while surgeries are done before cataract develops, in villages, surgery is delayed to that an extent that they come with advanced phacomorphic glaucoma. I think really a dilemma and tragedy of this thing. Dr. Arvind, do you find similar advanced presentation of phacomorphic glaucoma? You have worked in both north and south, because there's better vision centers, satellite centers in south, better coverage. Do you have similar incidents of phacomorphic glaucoma presentations in south as you saw in north?
So when we talk about the patients from cities, so the presentation is early. But when we talk about right now, we are catering to the tribal area of Telangana, so they come quite late. And it was on a surge post this COVID pandemic, it was on a surge, these cases of phacomorphic glaucoma.
I had got the OT open during COVID, and well-to-do patients also, they landed up with phaco, which we operated despite the huge scare and saying, oh, you're going to die with COVID, but we still operated on those. And one of those patients, her son was a computer engineer, she got 6/9 vision.
And most of these tribal village area having pressure of above 50, and I don't know how come they are...
I have 90 patients, a series again about to be published of pressures above 50. So, and then the post-op results also.
Dr. Kamini, if I may ask, which are these cases you will manage only with cataract surgery alone, and which are these patients you would like to have combined surgery?
Most of the cases can be managed with cataract surgery. With intraocular pressure should be controlled either with the hyperosmotic agents and topical anti-glaucoma medications. Most of the patients will not need any trabeculectomy surgery. And I would like to say that we might have a challenge while getting this phacomorphic type of glaucoma patient. The patient might have other systemic diseases like diabetes mellitus, which is uncontrolled because they are not aware of even the blood sugar level and the blood pressure. And second thing about this other eye, they are not aware of the other eye. As madam has already told about the other eye status, that the pseudophakic eye or phakic eye. But if the patient has immature cataract, then also we might have a patient need to have a peripheral iridotomy as well. Thanks.
So what are the treatment protocol before going to cataract surgery?
Yes,
so
sir.
you told hyperosmolarity agent and
Yes, sir.
anything else?
It depends on the patient's intraocular pressure and the slit lamp examination. What we are getting the findings in patient might have a other systemic disease. Patient might have a uveitis also sometimes. So we have to take care about or not to instill the pilocarpine, but use the cycloplegic agent, steroids or NSAID as well as the systemic
Few
anti-glaucoma.
areas of caution. Everyone, we all rush to give hyperosmotic intravenously. We all give hyperosmotic intravenously. Please check the blood pressure. We've had patients with hypertensive crisis. Also, we have to use carbonic anhydrase inhibitors, but maybe a simple history of liver disease, kidney disease, and sending electrolytes. So these are also things which can be life-saving as well as sight-saving for the patient. Above 50s, I have found that when you look at these patients with the whole pigment dispersion and cloudy cornea, and there's hardly any place. The anterior chamber depth also is another factor which helps you during biometry. So I would go for combined in all those. And I remove a large part of the sclera. And by God's grace that they are doing well. But it is a difficult surgery, but the only option that we have at that time.
Exactly.
So preference of liquid glycerol in non-diabetic patient, because it will liquefy the vitreous also, so you will get more AC depth during surgery. So it is preferable or mannitol.
Yes, agreed. Phacoemulsification is a challenge in these patients because of raised intraocular pressure, shallow anterior chamber, swollen lens, because there are chances in a very small space you have to do and protect the cornea also, corneal endothelium. All these factors have to be considered. And also there are chances of Argentinian flag sign when there is a swollen lens. So you have to really use you have to decrease the intralenticular pressure, and this is where mannitol does not decrease the intralenticular pressure. It causes shrinkage of the vitreous, and there is a very nice paper published by Figueiredo from Brazil, where it showed that this decreased volume of the vitreous, once you neck the anterior capsule, it prevents the forward movement of the nucleus. It is the forward movement of the nucleus because raised intralenticular pressure is matched by the intracameral pressure. The moment you neck the capsule, this intralenticular pressure is decreased, and at the same time leakage of fluid from the anterior chamber decreases the intracameral pressure also. This causes the capsule tear to extend peripherally. So this shrinkage of the vitreous helps because it slows down the movement of the nucleus anteriorly.
So better is to phaco punch technique. You give
burst and pulse, everything. A lot of things have to be. So now we come to the next talk by Dr. Vinita Ramnani, who's a renowned glaucoma surgeon from Bhopal, and she is going to tell us about management of coexisting glaucoma and cataract.
At the outset, I would like to thank Dr. Rana and AGOS for giving me this opportunity. The glaucoma and cataract commonly coexist in elderly, and they affect the diagnosis and management of each other, and it becomes sometimes difficult. So you can treat this by only doing phaco with or without anti-glaucoma drugs. Can be two separate procedures or can be a combined procedure. So you need to individualize each patient and each eye depending upon the requirement and the severity and density of the cataract and glaucoma. You can do only cataract surgery because it reduces intraocular pressure by 2 to 4 millimeters of mercury only in cases of very early angle closure glaucoma, ocular hypertensus, or IOP well controlled with single drug. But then you have to be careful. You have to remove the viscoelastic thoroughly and can put a timolol at the end of the surgery and keep a watch on IOP on a follow-ups. Whether to do a combined surgery or a sequential surgery, that primarily depends upon like which disease is more. Either the cataract is more or glaucoma is more, what the patient desire and what the surgeon is expertise of. So two separate surgeries is one which we should be doing it as a staged or sequential surgeries. We have two options. We can go for cataract first and then glaucoma, but usually it is to be done when there is a cataract which is very dense and the glaucoma evaluation is difficult and glaucoma is well controlled. But most of the time we have to do the glaucoma surgery first because we have to control the pressure, and then if you are able to see and continue without doing a cataract surgery, probably you can wait for 3 to 6 months before the bleb stabilizes. But then problem becomes more when the decision becomes difficult if the cataract is also dense and glaucoma is uncontrolled. So in that case, probably you have to switch to the combined surgery. So if you do a cataract first, you have to take care of glaucoma, otherwise it will progress and the patient will have a severe disease. So doing a sequential surgery is problem oriented depending upon whether the problem is more of a glaucoma or of a cataract, and you can do the TRAB or AGV or whatever the per se the glaucoma demands. The disadvantage is that the patient has to go to the theater twice, the visual rehabilitation is being delayed, and there is a risk of 2 surgeries, because when you do the TRAB first, when you do the cataract surgery, there will be a problem because patient doesn't think that there is a visual improvement. So he may go for the cataracts, he may refuse to go for a cataract surgery later on. So combine gives a better outcome because it gives the visual recovery soon. And there could be a cataract progression, and because of that cataract progression, the patient thinks that the vision even deteriorated after doing a trabeculectomy, and you can do a combine so that this thing can be taken care of. And doing a cataract surgery in presence of filtering blab is lot of challenge. So to avoid these challenges, you may have to think of doing a combined surgery, and you can prevent the blab failure, which can subsequently happen because of the cataract surgery, because 30 to 40% of the blabs may fail by doing a cataract surgery because of the inflammation. So I'm a great promoter of combined phaco and glaucoma surgeries together. It gives me a chance to do any of the glaucoma surgery, be it trabeculectomy, valves, non-penetrating, nowadays MIGS, and even the cyclophotocoagulation. So the phaco MIGS is one of the upcoming trend, because it comes in between the laser and the medicine, and other end blab-related complicated surgery of trabeculectomy. So probably in a mild to moderate glaucoma, combining a cataract and MIGS procedure, which are of different type, which are blab saving, is also a good option. And you can do the trabeculectomy also with good visual recovery and proper results. It becomes very good and comfortable even for the surgeon and patient, because financially also it is having a lesser follow-ups. It is cost effective, convenient, economical, and most of the patients you have to counsel. The counseling is one which decides whether you want a combine or sequential. Though it is time saving, but sometimes there is complication, so you have to be careful. You can be doing combine either through the single site or 2 site, each having its own advantages and disadvantages. I will be showing my video. I do a single site combined phacotrabeculectomy. This is, I think, 10 years old surgery in an angle closer glaucoma patient. You can see the iris atrophic patches. You can see the PI. So make a triangular scleral flap. You can do it with the help of blades, which are now available for SICS, but I used to do it initially with the 15 number blade. So you just raise the triangular flap. You can make it rectangular also, depending upon your choice, and you have to go deep when there is a transition from gray towards the cornea, which is 1 millimeter inside, and then you penetrate. So once you are inside the eye, the cataract becomes the same the way you are doing a cataract surgery. Only thing, this is an angle closer glaucoma patient, so there is a bulky lens. The pupil, as you see, it's not being dilated much, and there is a shallow anterior chamber. So you have to give pre-op Dimox or Maninagar depending upon the intraocular pressure, and you have to be careful not to extend the capsular axis, because the capsular axis is a one which you have to be careful. Otherwise, if there is an extension, there is more likely a chance of vitreous loss and rent, which you never want in cases of combined glaucoma surgeries. So you just rotate the nucleus and do the phaco. Doing the phaco in such cases is really difficult because the pressure is more, the chamber is shallow, so you have to be careful about the endothelium, you have to be careful about the posterior capsule, so you should not rupture the posterior capsule. As I said, this is my older video, so that time I used to do a stop and chop technique, but then you can do any technique you want to, and then proceed further and remove the iris, the whole epinucleus, cortex, implant an IOL. And once you implant the IOL, if you have done everything for the phaco, now comes the internal window formation. So you can catch hold of it, do it with the scissors. Be careful that not to injure the iris, but then see that pigment on the back of the back of the sclera, which indicates that you are cutting the trabecular meshwork, and then you do a broad-based iridectomy. So that's an important step. You can do with the punch. Just see that there is nothing coming out of it, and then be careful. Put a suture depending upon whether you like it 1 or 3 sutures, maybe the apical suture as a releasable or other type of the sutures, whichever you want. You can put a releasable at the end only at one side, and then you can think of the way you want to proceed further and put the sutures. The tightness of the sutures will also depend upon whether, so you want a one suture or more sutures, and then you can tie the conjunctiva and then proceed further. So my preferred approach initially was single side, but now I have shifted to 2 sides because most of us, we are doing a topical phaco on a temporal side. So temporal clear corneal phaco and 12 o'clock trabeculectomy definitely gives a good bleb survival, and it gives us the purpose of doing both the surgeries together with ease. Only thing is you have to shift your position from 12 o'clock to the temporal side. That doesn't matter. So to summarize, if you have a case of ocular hypertension and mild glaucoma, probably you can think of only a cataract removal. But if it's a moderate glaucoma, you can think of a single-site phacotrabeculectomy. But if it is advanced glaucoma, either you have to go for sequential surgeries or you have to go to the 2-step procedure. And the same applies for the end-stage glaucomas, the secondary glaucomas. And even in case of secondary uveitic neovascular glaucoma, you can go for AGV because these are the cases where you want to control intraocular pressure at any cost. So to just summarize that cataract and glaucoma, you have to deal with it. And now because the patient has become aware, you can do it with phacoamagius. The trend are increasing, but that's definitely trabeculectomy has a role in Indian scenario. Though there is a controversy that way somebody else can manage the glaucoma in a different way, I managed glaucoma in this way. So we need to individualize as per our results, and we need to individualize as per the patient's requirement and the type of the glaucoma we are dealing with. Thank you so much. With this, I request my candidature for member scientific committee. Thank you so much for the patience listening and opportunity.
Thank you, Vinita ma'am. That was very nice presentation. Just one question. If you have to use mitomycin C during combined surgery, will you change the dosage, or what precautions will you take if you have to use?
Usually nowadays I use 0.02 milligram of mitomycin C. Initially we were using 0.04. So now we have reduced the doses, and even the duration you can keep it to 1 or 2 millimeter or 1 or 2 minutes, not more than that. And if you are doing a single site, you have to be very, very meticulous in washing. Otherwise, there is all chances that it will go to the anterior chamber and it will create a lot of complications. So a patient, I decide on OPD itself that this patient requires a mitomycin C. I will definitely go for a 2 site rather than a single site.
One question to the panelist. If the patient requires toric IOL, will we do single site, 2 site, or sequential surgery?
Sir, you obviously have the maximum experience. What is your take? Sometimes when you ask the question, I want to ask you, what would you like to do?
Definitely, I will not do combined surgery because the astigmatism becomes unpredictable. It's better to do one surgery, wait for some time, let the cornea stabilize, let the keratometry reading stabilize, and then take up the patient for cataract surgery.
Because somebody who's getting toric does not want residual astigmatism.
Exactly.
So that is the big
combined
issue.
surgery is a big no for me in wherever I contemplate using toric IOLs.
Sir, even in cases of like toric IOL post trabeculectomy, it is really difficult to calculate the exact amount of the astigmatism. So you cannot promise a 0 astigmatism even with the toric IOL and even with the 2 sequential stage procedure.
So, ma'am, to take home message, as you told that you prefer the change now techniques is double site combined approach. So, is there any specific reason to do that, or now you prefer some of the cases where specifically you do a single site superior techniques, especially in
See, single
cases.
sight is really good when you have lot of volume. So you don't want to shift your microscope. You don't want to change your settings. So when I was in a trust hospital, I used to do lot of glaucoma, as Dr. Manisha said, that such kind of a patients where the approach to the hospital is not that easy. So they have lot of glaucoma and they don't want to come for glaucoma surgery again. So you want to get rid of glaucoma there and there itself. Probably I will think of a single site phacotrabeculectomy for those patients. But in a private practice, when you have enough time to shift and they are more worried about the outcomes, and if you think that if it is mild glaucoma, probably the single site is good. But if it is an advanced glaucoma, definitely I will take 10 minutes more to shift my position and give a good blab structure.
Madam, patient with below 30 pressure, cataract is there, and you do cataract surgery, you told 2 to 4 millimeter will down, then medical management, or you will do combined surgery?
I'm a good fan of doing a combined surgery, but it absolutely not determined by doing only the intraocular pressure. You have to look for the fields, you have to look for the disc, you have to see for the progression of the disease and the severity of the disease. If it is mild glaucoma, well controlled, and it is not showing progression and the patient is well comfortable with the drops, probably doing a phaco and continuing with the drop is a good option. But then most of the patient, if you talk across the table, they will definitely ask, Madam, kar hi rahe ho na, to mera glaucoma bhi nikal do na.
Okay, now we'd like to invite Dr. Kirti Singh.
Yes, advanced glaucoma, 2 sequential is, yes, correct.
Dr. Kirti Singh is a Director Professor of Ophthalmology, Guru Nanak Eye Center, Maulana Azad Medical College at New Delhi. He's going to talk to us about gaps in glaucoma practice.
At the outset, thank you very much to the Ahmedabad Society for having me here in this beautiful weather. So, I don't know how many of you have seen Hindi movies in the old ones. उसमें होता था ना, गीता के हाथ पे सौगंध खा के कहता हूँ जो कुछ कहूँगा सच के सिवा कुछ नहीं कहूँगा. Have you seen that melodramatic dialogue? So I'm going to do that. I'm going to actually tell you what I have seen in my 3 decades of glaucoma practice and how we all, including me, don't walk our talk. So we know some facts that India is home to over 20% of the world's blind population. 70% of the blindness is preventable, and of course that includes cataract, but 6% blindness is glaucoma, which at a later stage becomes irreversible. So is glaucoma at any stage reversible? Let's see. We did a gap analysis. For any gap analysis, you want to have 2 stakeholders, the person who is treating and the person who is being treated. So we did for the patient and for the doctor. So data of 1700 plus patients, we found that, again, a no-brainer, that open angle glaucoma and angle closure glaucoma was similar in a hospital setup, a tertiary care center. 1/4 of the patients who come to us required glaucoma filtering surgery, unlike those in private practice. How about the disease severity? Almost 14% were blind in one eye, means PL negative. And of all the blind patients, angle closure glaucoma comprised 46%. Prior treatment, 80% were undiagnosed. If I could have your ears here, because this is for all of us. 80% were undiagnosed. Most PIs were done in our hospital in the OPD scenario. So gonioscopy was not being done. Let's talk about the referral practices of the doctor. Prior diagnosis only 80%, 20%, despite a qualified ophthalmologist being the referring physician in 92% patients, and 1/4 cataract का operation हो चुका था, still glaucoma had not been diagnosed. Gonio suspects were very poor. Most case of referral was for IOP, so gonioscopy was neither performed or, if performed, not documented by the primary care ophthalmologist. And this has been consistently said many years ago by the Chennai glaucoma study and the Venkatraman study in Coimbatore, and it has been reiterated by our study. Please remember, angle closure glaucoma is 1/4 of all glaucomas, but it's responsible for 50% of the glaucoma blindness. Can you drive a car like this? Can you drive a car like this? Can you sleep on a cot without one pillar missing? Then why do we treat glaucoma with the gonioscopy not being done? That was the first gap we identified. Second, the patient behavior, a CAP study and the referral practices. 85%, my center is same as Manisha's center. We have patients who are poor. 73% traveled more than 30 kilometers just for drug refills. Delay in seeking treatment was enormous, and ignorance was the common cause. Dependency on the hospital supply was high, and only 40% had some income. 1/4 were blind in one eye. So these are the type of patients who come to us. What was the reason for this poor compliance? It wasn't the cost, because most of them got the drugs from the hospital. It was forgetfulness. You and me all take antibiotic therapy for 5 days, 7 days. चौथे दिन के बाद कौन दवाई लेना भूल जाता है? Right? So patients generally do forget. So forgetfulness followed by fatigue. Cost was not a problem for our patients, but obviously it is. Side effects surprisingly were there in 1/3, but that wasn't the problem. And we did find something not talked about, white coat adherence, which is, and the day of surgery, they had put medications, so the IOP, on the day of the checking up in the clinic, they had put the pressure, so the IOP was less. Drug installation practices were very poor. How to put drugs? Almost 1/2 had a dependency on their escort, and more than half said, do an operation, we can't put the drugs. And this is how they actually put the drugs. For want of time, do I have time for this? So this is how they open the drugs. Just watch and see how they do it. I mean, just watch them, see how they do it. It's very difficult how they put the drops. So we think they would put it properly, but they don't. We also remember that glaucoma is a lifelong medication. Cost, availability, improper installation technique, disease of the elderly, hand-eye coordination, forgetfulness. Look at your patient. What type of patient it is? Why would they stop medications? Which type of patient it is? This type, or this type. So let's titrate our therapy and always look at the hands of the patient. Can they put the drops, or they would depend on someone else to put the drops? Third gap we found was the nocturnal dip. We are not checking the blood pressure of most of our patients. They are something called as dippers and non-dippers. So we do need a 24-hour ambulatory BP or IOP. Office diurnal is not enough. So what we can do is that you take a BP at night, tell them to take a BP at night, and try to see how you can manage that. We all know this textbook, PG analogs cause this much, beta blockers this much, alpha adrenaline this much. So combination would be 25% plus 20 plus 20, 65%. Yes, it never is. Let's do the math. 5 AGMs for IOP of 20 millimeters of mercury in this patient. 3 AGMs for a disc damage, very mild. Let's start doing our math. Over-medication has been there. Glaucoma is underdiagnosed and over-medicated. Last slide, ma'am. We did a study on the conjunctival cellular and inflammatory profile in trabeculectomy. We found pre-existing fibrosis in 1/4 of the patients. We call this sick conjunctiva. So to rectify these 4 errors, we did a gonioscopy and perimetry workshop, which we do. Ensure adherence by titrating with strategies and schedules. Gonioscopy is not being done. Treatment has to be dictated by patient profile and diseases. Follow the adherence. Check for the drug installation. Dry eyes or iatrogenic imprint, sick conjunctiva is our creation. Let's remember we are surgeons. We need to do trabeculectomy in time. And requesting you for a vote for me for member ARC North Zone. Thank you.
Thank you, Dr. Kirti. In the interest of time, we'll move on to the next talk. Dr. Palak Patel. She's a glaucoma specialist from Ahmedabad, and she's going to be talking to us about microinvasive surgery in primary angle closure glaucomas.
Until she reaches the dais, I did not add in my presentation. I'm Manisha Rathi from Member Scientific Committee. Thank you so much. See, time utilized.
અહીંયાથી કરો.
Patients, we being Asian ethnicity come across lot of occludable angle patient in our daily practice. As per the newer guidelines, they have been divided into primary angle closure suspect, primary angle closure, and primary angle closure glaucoma. While the first category, usually the management comes in the form of observation or the peripheral iridotomy as per requirement, while rest of the segment require treatment in one form or another because of the rising in IOP and changes in the disc. First line of management comes in the term of medical treatment and peripheral iridotomy, but with combining both, if we don't achieve the target IOP or have any side effect with the medicines, we have to move forward with the second option. In the term of second option, usually comes conventional glaucoma surgery in term of trabeculectomy or drainage devices. And in past TVT study has shown us they also carry their own risk or complications. The next landmark study came is the EAGLE study, which was based on that the angle closure happens because of the bulky lens, and removing that lens gives us a good IOP control over a period of time. Over sequential studies that have found that on the longer duration, they are also not very adequate in controlling the IOP alone. So there comes newer technology, newer techniques. They are the minimal invasive surgeries. The aim of this surgery is to restore the traditional or conventional aqueous drainage pathway with doing minimal scleral dissection or conjunctival manipulation via ab interno approach. MIGS proclaimed to have a shorter surgical time, higher safety profile, and faster recovery. Under the umbrella of MIGS, there are many options available right now, and many are going to available in the future. With due respect to time and popularity, I'll be talking about only canal-based procedures. The aim of this procedure is to enhance the aqueous humor outflow through Schlem's canal by de-roofing the trabecular meshworks. These are the few techniques they are covered under this group. In the glaucoma continuum, from pre-perimetric glaucoma to advanced glaucoma, MIGS are claimed to be used in the early to moderate stage of glaucomas. They were primarily approved to use in the open angle glaucomas only. Using MIGS in the angle closure has its own stage of difficulties in terms of assessing the trabecular meshworks due to synechia, higher chances of post-operative inflammation, and predilection for the fibrosis and synechia in the future. These are the two good meta-analyses that has been published recently regarding comparing the outcome of MIGS in the PAC and PACG patients. I'll be discussing their outcomes. The inclusion was any PAC or PACG patients, but they are phakics. In exclusion criteria, only phaco with goniosyncytial or any patients who have underwent previous trabeculectomy or tube. Any previous surgeries and PACS patients were excluded from the studies. Overall results at 1 year, that IOP reduction was found around 10 mm of Hg, and mean droppage in the anti-glaucoma drops was found around 1.89. In subgroup analysis, the GAT and KDB was found to be having more IOP reduction compared to I-stent group. If we go for the rate of complications, they were around 33.4%, but majority of them is being hyphema, which was transient and self-resolving. If we exclude the hyphema from the complication, the rate comes down to 16%. In subgroup also, I-stent has to had a less number of complications. So overall result, phacoemulsification, if combined with the angle-based surgery, gives us the better IOP control compared with the phacoemulsification alone. But we should not overlook the complications. And in any of these studies, the MIGS were not done as a standalone procedures. They were always been combined with the phacoemulsification surgeries. So my take-home message in this process is, microinvasive or minimal invasive surgeries in primary angle closure and primary angle closure glaucoma patients do have a promising future, but we need to look at the results over the long-term basis. One size does not fit all. Should titrate your treatment according to patient and according to eye. Before adapting to any new techniques, one should do a thorough literature search and proper training. And at the end of the day, the bottom line comes is what works best in your end, one should follow. Thank you for your patience listening.
Thank you, Dr. Palak Patel. Now I request Dr. J.S. Bhalla to please honor Dr. Patel with a memento. Yeah, I request everyone to come on the dais. Please. Sheetal, how many, ma'am?
खाना खाते हैं अपना मोबाइल भी लेते हैं मोबाइल
Good afternoon, everyone. Welcome back the post-lunch session, interior segment symposium. I would like to invite on the stage Dr. Vishnubhai Patel, sir, Dr. Amar Agrawal, sir, Dr. Kankaria, sir, Dr. Narendra Singh Verma, sir, Dr. Rajesh Joshi. Please, welcome, sir. Yes. Hi, Joseph. Our first speaker is Dr. Narendra Singh Verma, sir. His topic is on indigenous topographer with imaging guided platform. Dr. Verma is the renowned ophthalmic surgeon at Surendranagar and practicing from less than more 20 years. Our next speaker is Dr. Priya Narang. I will request her to please prepare with her talk.
Very good afternoon to everyone. I will present something new, which is our work for 6.5 years. So I will present you the Made in India topographer, which we made integrated in it, just like telescope and value. If we see, these are the potential source of error during torticollis implantation. If the domino effect of these give you a reflective substance in some cases, if you want to prevent the errors, you already first you have to check that clear film stability is there, cornea should not be blind. You have to measure the amount of astigmatism, you have to take multiple pictures and compare them. You have to confirm that the astigmatism is regular. Then only you can put evidence. Intraoperatively, you must have some system like an API system for the precise alignment of the coordinates. And postoperatively, there is some weakness alignment, there are defective subtypes. You should have some instrument which can give you the current axis and which can give you the formula. So how much is necessary to decrease the defective subtypes. So can there be an instrument which covers all these features? Because we are seeing the right side there are multiple instruments. Can there be an instrument? So we are trying to make an instrument. So this is our topograph. Just like you see, it is NDS topographer. So it is having 600 color LEDs.
LCDs measuring the central 9 to 10 millimeters of the cornea. Here are the results.
So it will provide the keratometry. So we are capturing picture at the 3 distances. So in 4 color patterns. So we will get 12 pictures. You can compare 12 pictures, keratometry, it will give you elevated map, excellent map, radial curvature, then wavefront model 2, wavefront model 3, total wavefront, and also the 3D model of the cornea. So all the features which are given by the separate topographer, you will get all these features. In addition, it will give you EKA Arena analysis in this form, graphical form. It will also give you the topographic indices analysis of different indices. And in addition, it is having AI-based this analysis of keratoconus. So whatever the KISA, TCI model, this how much is their value, they will give you the analysis. So in the left lower side, you can see that in this patient keratoconus is suspected. They examine the patient after 3 months and educate the patient of Purabai. So whatever is there, you can print all these photos in the print color photos and give the patient. And previously we were having nano image guided system. This was with us. Nano image guided system. So what model you can see?
The anterior surface keratometry is measured in 3, 5, and 7 millimeter zones. In the 3 millimeter zone, there is a 1.1 diopter cylinder at 172 degrees. The steep axis shows no skewing of steep axis, indicating regular astigmatism. This is the manual image guided module. The system automatically marks the steep axis at 172 degrees. In this topography image, identify 2 prominent limb ball structures and mark them as landmarks. On the right side, I have marked a pigmented spot at 179 degrees. On the left side, a whitish pigmented structure is marked at 23 degrees. These 2 landmarks serve as reference points. This method reduces errors from head tilt and cyclotorsion. If the patient moves their head during topography, the distance between the landmark points and the steep axis remains constant, unaffected by head movement or cyclotorsion when the patient is lying down. And save this image on a tablet, laptop, or mobile device. This image is displayed in the operating theater on the tablet or mobile device. The surgeon can easily identify the pigmented structure at 179 degrees on the nasal side and the white patch at 23 degrees on the temporal side, and will manually mark these points on the patient's eye. Mark 179 degrees and 23 degrees on the degree gauge. Align these marks with the corneal markings and mark the axis of alignment at 176 degrees. Postoperative day 3, the axis of the toric lens observed on the slit lamp is at 170 degrees, as confirmed by the retroillumination picture. The intended axis of alignment was 176 degrees, indicating a 6-degree misalignment of toric lens.
So in this there's no need of preoperative marking, which is the commercial. Now we have developed this new camera system, which is universal camera, which can be fit on any microscope. And we have developed the image guided system. Yesterday I operated this patient. So this was my first patient for this method. You can see that our system is telling where is the extra alignment. So this is just like an instant video. The camera will be universal to all microscope. Tomorrow we will demonstrate it. I will keep the system here for demonstration. So this we were doing since last 2 months. So on the dummy eye, so when you move the eye down, so it has registered the eye, now the axis will move with the eye. So you can see it will provide you LRI, whatever you want, from 4 to 7 centimeter. It will give you cytophysical, it will be LRI and CC source. PCC, LI, and cytotoxins. So we are also having this toric error analyzer accuracy. So it will take the post-operatively, after two hours post-operatively or second day, third day, you can take the picture of the patient in which the toric is implanted. Then it will give you the current axis. What was the axis, proposed axis, pre-operatively on the left side, and it will give you how much the current axis is. So how much misalignment is there. And we have also developed the toric error analyzer here, which is similar to Dr. Barrett Ryan's formula and estimatrix.com. Same, it will give results of that estimatrix.com and Barrett Ryan's. You have to acknowledge two data. So all the features, we are trying to include all the features in our photographer in this imaging system. Those who are interested, I will display tomorrow.
Thank you so much, sir. It was a very nice presentation. I would like to request Dr. Vishnubhai Patel, sir, to present a memento. Meanwhile, Dr. Kakade.
Dr. Verma, many congratulations for developing this. We all are eagerly waiting for this. But we are waiting for this to be available, and I will be the first person to have it. Why not to escalate the team? But this is something which everybody needs.
We want everything perfect, then only we will see.
Right.
So for demo we can provide you, but for sale, when everything is perfect, then we'll see.
So, really, great work. Now I request Dr. Priya Ben Narang to come on the stage. She's going to speak about pinhole pupilloplasty. Dr. Ankur Singh is next, so I request Dr. Ankur Singh to load his presentation on the other dais so that we can save time. Dr. Ankur Singh, please.
Good afternoon, ladies and gentlemen. And also, I would like to thank Dr. Jagdish for this wonderful opportunity and all of his parents. Well, I'm going to talk about pinhole pupilloplasty, and I'll try to cover as much as possible. The modalities, we all know how to achieve a pinhole size of 50, but the problem is actually how you go ahead with that. Actually, why is it needed? It is actually needed in cases with higher order aberrations. Because actually these are the cases, even if they have vision, they do not have a good quality of vision. And that is what we try to emphasize and get ahead with giving a pinhole vision to these patients. These patients with higher order aberrations, for example, this is an animation that shows the case of an RK. So the patient of RK is never going to be happy, no matter whatever you do for this patient, no matter how good is your IR power calculation, nothing works for these patients. These patients, but when they are treated with additionally with a pinhole pupilloplasty, what actually happens is that they start getting the pinhole vision and the clarity of the vision that they are actually looking for, that actually every patient looks for in the post-operative period is what they actually achieve. And you get those central rays focused and the peripheral distorted rays are just wiped out with the procedure. So this is how this technique it works around. I'm just going to show you one of the cases for better understanding. So I had a case of an operative patient. The patient was the patient had undergone surgery, pseudopalia, had a very high diffractive surprise in the post-operative period, around 15 hours or something. And this patient had very high order aberration. So what I had actually decided for this patient was the first thing was to explant the area of turbulence because 15 hours is too much to handle. So what actually I have done, you can just see, you are seeing the scleral tunnel made here because that tunnel is made because, obviously the cornea is so weak, so you have to expand this. So I just made a little flat excision and get that IO out of place in an exterior. Now what actually I'm trying to do is that, with those deep arcades, you won't have a cystic cornea out there just here. So I'm trying to do a pinhole pupilloplasty for this patient, and what actually we try to do with these cases is that, we have done that technique that we adopt as the single pass four-throat pupilloplasty procedure. I think that in itself is a different procedure to understand basically you are not actually doing a pinhole. But actually it is so simple and easy to do this surgical procedure repair of single pass four-throat because it's just a single pass that you need in the anterior chamber with 4 throws due, and then when you just focus it to it, beautifully slide inside and you get it. But the trick here in doing a pinhole pupilloplasty is that you have to center
the pupil on the Purkinje-1 reflex coming up from the coaxial electrical microscope, and you need to have that bang on with it. Now, the problem here is that it's a tissue. It's not something like, you can have a good centration always. So there are tips and tricks to fall into that, but I'm just giving you a brief outlook of how we go about and try to get a good people. Now what actually happens is that, having done that many times, you realize that, because it's a tissue, it might be overlapping the Purkinje-1 reflex. So you cannot give the patient that section there. You have to clear the Purkinje-1 reflex area. And then to do that, in these cases, you have two options. You can either use a vitrectomy probe and cut off the iris tissue that is lying on the obstructing the Purkinje-1 reflex, or secondly, many of the surgeons, we also use endolite probe and, to have that complete centration of the tubule going around the Purkinje-1 reflex. This was a very simple case. It's just done twice, and I could get the tubule of the way, but many times we need at least 3-4 attempts to get that big hole back on the Purkinje-1 reflex. So that is a very important thing to be taken into consideration. But the beauty of this procedure is that, actually, you can optimize the size of the pupil. You can have the size of the pupil that you actually want in these particular patients. So I think having done this, is that complete, or what we call an optimum size of the pupil? Yes. We have already analyzed this. What we do in the pre-operative period is that we use this device to place it in front of the patient's eye, and the appropriate size of the pupil that the patient says that, I see less than 1.5, so you try to achieve 1.5 during the surgical procedure. If the patient says 1 millimeter, try to achieve 1 millimeter size of the pupil. How do you do that actually? Because then you should have an intraoperative calibration system, something going on. So now there are two methods to this. This is an intraoperative reticle. You can place it in the iris of the microscope. And the second thing is that one of the Russian doctors, he has designed a device you can just insert it through the corneal incision, and then it's made up of 105 millimeter size. So you can actually measure it at the level of the iris, the first size of the pupil which is achieved. So coming up with the thing is that this is one of the peer-reviewed paper in the Journal of Refractive Surgery. This is just for academic, where we analyze image quality and adapt the focus. Already there in this one. So we did a great study with this, assessing the photopic and the mesopic light conditions, how the visual activity, and actually all patients were very happy with the surgical procedure. So just to mention in brief, it's such a short while, I would just like to see if anybody has these are some of the suggestions you articles if you actually want to go through them. Thank you so much.
Thank you so much, ma'am. It was a wonderful information. Already we have learned from Dr. Amar Agrawal, sir, today morning. I would like to request Amar, sir, to felicitate Dr. Priya, ma'am. I would request Jagdish Kankaria, sir, to be ready with his presentation. I would like to request Dr. Ankur Singh to start his presentation on when this goes south.
From India segment, I move on to the process. So to begin with, I'm very thankful to the Ahmedabad Ophthalmic Society for Gujarat Ophthalmological Society for inviting me for this occasion, as well as the complete team for giving this opportunity. So I'm going to talk about when it goes out, because whoever we are, we might be ATA segment surgeons, process surgeons, cataract surgeons, or split specialists, we tend to perform cataracts and cataracts can go wrong. So what happens during cataract surgery, you can have PCR, and that will lead to surgical failure. And we need to put a secondary eye in this kind of patient, which will be done at the time of the surgery, or it will be deferred for some time. And we see the rate of complications like PCR and surgical failure very higher than ECG and KDMCG. So I'm just going to talk about very few important secondary eye which I can do. One is the surface implantable PPCIL, where and about PPCIL. Then we have sir who is the pioneer of blue diodes. Then I'm going to talk about a managed technique. And then a modified iode, that is CMT flex iode. So when the PCR happens, two things is important. We will discuss this morning that do a good NTA refracting, use triangles on if possible, and leave the drop nucleus or the part of the cortex of the vitreous to handle. Don't do fishing. Don't use your NTA current down to the vitreous, but try to remove those particle pieces. You can do it, but try to avoid it. So why is it important to know about such a fixated ion? Because these are the most stable ions. And if you are putting it if you are doing an optic capture, you literally don't require to change the IOL cover. So if you have an IOL of the same IOL cover, you plan a single piece IOL. You can put a 3-piece IOL. You can fixate it. You can do an optic capture. You can even do a capture into the PCR that has happened. So it's very simple. This is just a video that is going to demonstrate how simply you can put a 3-piece IOL. But there is a caveat which I'm going to talk about. So after doing a creating this is a different secondary IOL, 3-piece IOL. So I have seen the surface adequate or not, ruled out any posterior side areas with the anterior capsule. This is what I'm doing, building up the surface with the help of the scope. And this is a 3-piece IOL, no financial interest over here. And I'm just going to put it in and voila. And you can optic again, which says that you can do a posterior optic capture. It's going to stay like as if it was in the back eye. So this is how much time it takes to do it. Such as that. Now just imagine if you were not able to do it, and this 3-piece IOL falls down into the vitreous. So then you should only manage it. Because this is a technique by which you can fixate this broad 3-piece IOL to this sclera in a very rapid and fast technique. But this has a problem. The problem is that you need to fixate it well. You don't need to know the angulation of the needle that is 5 degrees horizontal and 16 degrees vertical. But that's difficult to achieve. So you have devices for this. But what is the problem? If it is so easy and so doable, the problem is IOL tilt. This surgery does provide very rapid visual rehabilitation and very good, very easy surgery, but it leads to an IOL tilt, which is a problem. So I'm just going to show that the same IOL which I have put in surface, if it collapses with the vitreous, how you take care of it. You just pick it up with the help of a VR surgery, pick it up with the help of a forceps. This is 26 gauge needle. The MNA that the wide bone cutting is 26 gauge. You turn the leading haptic into this 26 gauge. You take it out, you do the same to the other side, and then you authorize the haptic tip with the help of any heat copy, which you can make by yourself. In fact, they will use those cobbler nails, which I'm going to show you in the next surgery. So now the same, which you are not able to put that to the vitreous, you well fixated, you have done the copy to the knobs, to push those knobs into this little tunnel that has been created by this little because you are traveling in the skull also, and then the surgery is done. As simple as that. This is how much time it takes. So now what sometimes happens that the same patient comes late. You put a 3-piece IOL, now the IOL and the back complex is gone. No problem at all. Same MRI technique you should know. Remove the back from this IOL, externally happy again, and in this video I will show you using the cobbler's nail. We are using as a heat body. Of course, it was sterilized. So again, the leading haptic was put into the 26 gauge level, which has gone to the intrascleral loop, and this is externalized. The same is done on the other side. That is also taken out when heat body. This is the nail I was talking about, the cobbler's nail. You can just do the heat body, put this back into the level, and this gap. This is how you push it in, and it's done. So apart from this, if you don't have 3-piece IOL and you have done it before surgery, you need to know about a modified IOL. This is T-flex IOL. It's an IOL which has a T haptic, if you can see, and it's very easy to do. I am not going to go into details of it. It's very simple. You just have to mark the center of the cornea and identify the place just one observation, and you just extract the haptics with the help of any forceps. And this is very simple, and you just have to put it in the benefit is you are putting this IOL, it is cheaper than the 3-piece IOL, you are putting it to the same incision side, and you can do it at the primary surgery itself if you have a PCR. So you just hold the haptic, the teeth haptic, take it out, you do it on the other side. You can leave these flap as it is, you can put it in, or you can suture. So because we in a normal practice, we can suture them, because you don't want to see the patient again and again. So you suture it, the flap is low, I'm saying again, you can use a glue, or you can just let it bleed and the people will take care of it. So sometimes it happens then when this IOCD is wrong, and you know that you don't have accurate equipment like those paper-based cutters, you can just put the same IO into the sulfur, whether there is a radiating. Please don't do it. Because these IO are not made to be these sulfurs. They are happy to keep rubbing in the hairs and can lead to UTS syndrome. But certain old patients where you don't have anything in your mouth, they can be done also. That's how easy it is. So this is one thing, this is one patient who has a Hoffman disease, came with a broken one side suture of the suture diode. So this is a technique which we have published where we intraocularly decanalize the haptic with the thread and we refixate the diode. This is how it is done, it has been published, and I'm going to show you a small video of doing this in continuation to this. This is the last video. So you see the haptic, the trick is that when you are cannulating it with the needle, it tends to move. You have to be careful that you don't break the other haptic. So once the needle is solved, it is externalized from the reverse with the help of the again 26 days needle. Once that is done, you rotate it back, you try it, and the patient is good to go. So there are different examples where things can go wrong, and all can be taken care of very easily. But by knowing a few techniques, and you all can do it. So there's nothing, there's no magic science into it. So, and then I would just like to conclude. So when we come about talking about secondary error, there is no technical. It's the surgical skills and the patient anatomy that is important. ACIOL, Harris flow oil, SFIOL yield similar outcomes. Surface ion and optic capture are the most stable. The MNA, which I described before, you should know about it. And as modified IOL, as CMT plus IOL, is minimally invasive, very stable secondary IOL solution. And while operating at patients, I always say keep it IOL. I have been working in AIOs for the last 5 years in the various criteria which I have invented and all the AIOs for the last 5 years and whatever we went on. This is my work that I have contributed to AIOs. Now, after doing that work for 5 years, I request, humbly request you for support for members and scientific doctor. Thank you.
Thank you so much, sir. It was a very nice presentation. I think Dr. Anand Parsarthi is not available here. So I would like to request Dr. Jagdeep sir to present his lecture on elevating cataract standards care with monofocal plus. If we get time, we will
Near works. Oh, Dr. Saab, in spite of spending 1 lakh for 2 eyes, I still have to wear this much high power for computers, reading and needlework. That is their response. Most of these patients had some degree of moderate myopia due to nuclear sclerosis. So they will definitely say, till a week before I could read newspaper without glasses, and now how come I lost my near sight overnight? Many of them are not ready to undergo the second eye surgery, which is the low myopic eye. Because nowadays, even an illiterate Maji or Dada of 75, 80 years of age have been gifted a good smartphone by their computer-savvy grandchildren for their 60th or 75th birthdays. They want to see Asta Channel or Dharmic Kathas without any need for news and glasses on their handheld devices. With 2 eyes, we all expect monofocus techniques 1 for our case. Even after getting 6x5 or 6x4 vision, they were unhappy because they still have to use, find and fumble for those plus 2.5 reading glasses. That too after spending 1 lakh for 2 eyes. So we slowly and completely shifted to eye hands. Techniques eye hands has central 1 millimeter zone having about 1.25 diopters gradient add power, not in the form of refractive addition, but by modified interior hyperaspheric surface. So it gives excellent and stabilized and seamlessly continuous distance, that is 4 meters and beyond, as well as intermediate, that is 66 centimeters to 4 meters, good quality vision. Techniques eye hands behaves almost like a pure spectral monofocal for the distance vision, giving 10 to 11 lines out of 14 on logMAR chart, without glare, halos or starburst phenomena. For intermediate distance, it works excellently well. So laptop and desktop computer screens, car dashboards, kitchen platform work, seeing stair steps, undulations of terrain while walking in jungles or driving an off-road vehicle, etc. are very comfortable and easy. Even after bilateral techniques 1, intermediate vision is slightly hazy and near vision is a blur. With unilateral eye hands, distance and intermediate visions are crisp and clear, and near vision is also much better than the techniques 1. Bilateral eye hands with micromonovision, if the corneal Q values are more negative, this pair works almost like multifocals, giving crisp vision at all distances, even at night. Getting a polyfocal youthful vision without haze, halos or starbursts commonly associated with rigged multifocals. That too at less than half the cost is a real happy and great advantage. Eye hands is also a very good advantage for post-LASIK eyes also, where it will work like a pure monofocal. And almost same is true for the post-RK eyes also. Someday in future, when I'm given more oxygen and more time, we will dive much deeper into the Q value and spherical aberration-based customized IOL selection, and how to achieve more and more multifocality from monofocal plus IOLs by using anterior and posterior astigmatisms to our advantages. By the way, we did 800 eye hands implants at 15,000 rupees extra charge. That is 12,800 extra money. That is 1 crore plus extra income, which may become 1.25 crore by the end of this financial year. Well, thanks a lot to you. And thank you all very much for your kind attention and patient listening. Thank you.
Thank you so much, sir. It was a very nice information about the
purely refractive EDOF IOL. By a proprietary refractive technology, they've basically created a continuous depth of focus from distance all the way to functional near, while not enhancing the dysphotopsia profile from a monofocal IOL. The change in elevation which is created on the posterior surface in the 2.4 millimeter diameter, and this change in the refraction is not like a step or edge in a multifocal IOL, it's almost like a monofocal IOL. This continuous wavefront which is created gives crisp vision for distance, intermediate and near, and basically also holds onto the contrast in these values. Now comparing it to the IHANS, where there is a gradual change from the center to the periphery, the PureC has a very different power map, showing that under the 2 mm zone it has a very big peak, which is helpful for the near vision, even in smaller pupils. The broader defocus curve which we see with the PureC basically helps in when we don't exactly want to target zero, or when we are doing micro monovision, and this can be seen in comparison with its closest competitor as well as a diffractive IOL from the Technis platform. The PureC actually holds contrast very well even in pupil independent conditions. So even while the MTF values, when you come down from a 3 mm to a 5 mm pupil, the contrast loss is the least with this particular IOL. Comparing the spec sheets, why I think that this PureC lens is giving this contrast, enhanced contrast, is either first thing, obviously because of the quality of the Abbe number or the quality of the material, which leads to least chromatic dispersions, but also the posterior surface is what is modified, which is closer to the nodal point, I think, which may be helping with the refractive power. We have seen a study where there is a dissatisfaction with a few EDOF lenses, especially for distance, and the reasons for this were usually blurred vision or photic phenomena. In our practice also, we saw that there was a lot of waxy vision, which was a complaint which a lot of EDOF patients were complaining of for distance. So comparing the quantity of the PureC IOL, the PureC IOL actually works exactly like a monofocal for distance. It gives very, very crisp distance vision, and most of our patients, actually none of our patients complain for that distance visual acuity. The intermediate vision compared to its counterpart on the same platform, the modified monofocal, the intermediate vision is much more consistent with the patients, and most patients are very comfortable with this. Talking about quality, which is one of the major factors where EDOFs and multifocals were struggling, the dysphotopsia profile for the PureC is exactly like the monofocal or the IHANS. It does not differ in hyperopic or myopic targets, which is extremely important again when you're doing micro monovision. If you see the multifocal targets with hyperopia and myopia, the quality of the halo changes, and that's why the dysphotopsia profile in both eyes being the same is also important for neuroadaptation. The halo size in the PureC compared to even an emmetropic target, as you can see, is very similar to myopic targets. This helps in quality of vision and not only quantity of vision in relation to defocus. The second thing about the PureC which I like is that it tolerates myopic corrections as well as hyperopic. As an EDOF, all lenses basically tolerate the hyperopic corrections very well. But when you're doing micro monovision, it has to also provide tolerance to myopic refractions. And in this study, as you can see, that myopic and hyperopic refractions were controlled very well and were tolerated very well by the patients. A very important thing to do with EDOF lenses with basically the central zone which has been slightly changed is that you need to do a maximum plus refraction, which is basically you do a little bit of micro fogging. So you put a +1 diopter lens in front of them and try to make them read 6.6, 6.9, and when they come to 6.6, then you give the addition. This also helps in understanding where to do the microvision, how much micro monovision to target for the next IOL in the other eye. There was a case study which was done for PureC IOLs where 3 different patients went to their optical outlets and basically had a myopic correction which was given to them unduly, even though they were emmetropically targeted, and all of them got headache, nausea, especially while driving. And this is an important thing to understand and tell your patients that you are doing something which is an extended depth of focus IOL. So the AR machine might not always show the right results. And these are the different reasons which have been noted in the study itself. And all of these reasons are related to basically the wavefront which has been created. So with the PureC, we are seeing a lot less dysphotopsia profile than other EDOFs. We are seeing consistently distance vision is 6.6. We get a lot of patients which don't require reading glasses with micro monovision, and they tolerate that micro monovision very well. This leads to high patient satisfaction. In our practice, the biggest change I've seen is that my colleagues who are basically in retina, glaucoma, they have become bigger fans of this IOL than me, because they have been suggesting this lens left, right and center in stable ERMs, in post-SOR eyes, in RKIs, in all these post-LASIK patients where there's no history, we've been able to deliver good results with the PureC IOL. I still believe that multifocal IOLs cannot be totally replaced by the PureC, and that is because multifocals have their own place. If you want crisp near and crisp distance, it's not going to happen with the PureC. But functional near with crisp distance, PureC is the IOL to choose. So with comorbidities in our practice, we still use the PureC, but the synergy is the Technis Synergy or other multifocal IOLs still have their place in our practice. Thank you for your patient listening.
As presentation, Dr. Ivan, you have compared all these EDOF and other lenses nicely. Now I request Professor Subhash Dedia sir for this concept in amblyopia. And there is amblyopia not in the patient also, there is amblyopia in the society also, sir. So he is... At the outset, I would like to thank Gujarat Ophthalmological Society for inviting me and especially Dr. Jagdish Rana. Thank you, Chairman sir and esteemed guests on the dais and off the dais. I'll be speaking on concepts in amblyopia. So basically, what is amblyopia? It is derived from Greek word which means dull vision, and clinically it is defined as unilateral or bilateral reduction in the best corrected visual acuity, which is caused by foam vision deprivation and or abnormal binocular interaction without any visible organic cause. The visual acuity should be less than 612 for bilateral amblyopia, and there should be difference of 2 or more lines for unilateral amblyopia. And most important thing is it is correctable if appropriate measures are applied at appropriate time. So for diagnosis of amblyopia, there must be presence of evidence of reduced visual acuity, presence of amblyogenic factors, and there should not be any alternate cause for loss of visions. Various treatment options are refractive correction only, patching, penalization, near visual activities, pharmacological therapy, omega fatty acids, smart gas, smart glasses, pleoptics, and chem stimulators. Although a large magnitude of studies have been done on above mentioned treatment modalities, but none of them is foolproof. In amblyopia, there is questionable compliance, failure rate is high, treatment is challenging. So when to start amblyopia therapy? It is better late than never. It should be started at the earliest. What is the role of refractive correction? Proper cycloplegic refraction is must in case of each and every case of amblyopia. ATS 5 was conducted with aim to elevate effectiveness of refractive correction in moderate amblyopia, and they concluded amblyopia resolved in 27% of the patients, and improvement of more than 2 lines was seen in 77% of the patients with refractive correction only. So refractive correction is pre-occlusion treatment phase of amblyopia. In some cases, occlusion and penalization may not be required. And secondly, the child starts with better visual acuity and hence better compliance. So should you go for penalization or occlusion? ATS 1 was conducted with the aim to compare patching versus atropine penalization for treatment of moderate amblyopia in children of 3 to 7 years of age, and they concluded both are appropriate modalities for initial treatment of moderate amblyopia. There is no shortcut or substitute for occlusion in amblyopia therapy. However, variability exists in number of hours prescribed to treat amblyopic patients, and it should be according to the age. So what you have to observe during the therapy, you have to see the vision, whether there is any improvement or worsening, change in fixation pattern, and what is the endpoint, free alteration, equalization of vision, and if there is no improvement in vision after 3 to 6 months of proper occlusion. Occlusion failure is defined if there is no improvement for at least 3 follow-up visits after proper full-time occlusion. So duration of patching was tackled in ATS 2A and 2B. In ATS 2A, full-time patching was compared with 6 hours patching in severe amblyopia, and they concluded similar improvement in both the groups, and hence 6 hours patching is as effective as full-time patching as per ATS 2. In ATS 2B, 2 hours patching was compared with 6 hours patching in moderate amblyopia, and they concluded similar improvement in both the groups. Then what are the indications for penalization? Moderate amblyopia in uncooperative patients, anisometropic amblyopia, maintenance therapy after occlusion failures, non-compliant patients, and latent nystagmus with strabismic amblyopia. Then what is the role of daily atropine versus weekend atropine? It was studied in ATS 4, and they concluded weekend atropine produces an improvement in visual acuity which is similar to daily atropine.
ATS 8 was conducted to compare weakened atropine augmented by plano lens with weakened atropine alone for moderate amblyopia, and they concluded augmentation of weakened atropine with plano lens does not substantially improve vision. Then this ATS 11 was conducted with the aim to evaluate combined patching and atropine for residual amblyopia, and they concluded amblyopic visual acuity improved similarly in both groups, and it is suggestive of no additional benefit of combined treatment in residual amblyopia. So can amblyopia be corrected in adults? The answer is yes, because regardless of person's age, the visual system, which consists of eye, brain, and visual pathway, can be retained due to brain's plasticity. So is there any age bar to treat amblyopia? ATS 3 was conducted, whether amblyopia can be successfully treated in older age group of 10 to 18 years, and they concluded it can improve visual acuity in older children also. These are some of the studies which are mostly lab-based, just to gain widespread support, and tried in small number of patients, and longer follow-up is lacking. Levodopa was thought to be a promising agent in augmenting conventional occlusion. However, there are recent article on American Academy of Ophthalmology which says enough is enough, and these drugs have no role. So is there any role of near exercises in treatment of amblyopia? Near visual activities are often prescribed during patching for amblyopia based on the assumption that those activities, they stimulate the visual system. ATS 6 was conducted to determine the role of near activities, but they concluded performing common near activities does not improve visual outcome in treatment of amblyopia. However, there are a lot of other studies which are contrary to recommendation of ATS 6, even our own study. So near activities, they are useful in treatment of amblyopia. In amblyopia, visual impairment is lifelong. The child dislikes patching, eyeglasses, drops, and even using the amblyopic eye. Television has been a very popular mode of entertainment, and there has been a general myth among common men that television viewing, and especially too near, has been the cause of many eye problems, mainly of refractive variety. So we have done a thesis on this choice of television as a modality of near activities. It was easily accessible in every household, colossal influence it enjoys, and fondness with which children watch it. It is an effortless method of providing the stimulus to amblyopic eye in children. And we concluded there is improvement in the distance visual acuity, near visual acuity, but was found to be better in television game group as compared to the full-time patching in treatment of amblyopia. And we recommend use of television games activities in the form along with patching in treatment of amblyopia. Another important topic is role of LASIK in adult and isometropic amblyopia. So in those cases in which treatment failure is there, because in anisometropic amblyopia, the success is achieved only in 2/3 of the cases. So refractive surgery could play an important role in this difficult subset of patients like conventional therapy failures, successfully treated patients with subnormal visions, and residual amblyopia. So we recommend LASIK in desperate cases of adult anisometropic amblyopia. So is there any role of mobile game in treatment of amblyopia? Another thesis was conducted from our center, and we concluded mobile games are useful in treatment of amblyopia. Then another study was conducted from our center regarding role of omega fatty acids in treatment of amblyopia, and we concluded that there is not much of use. Then smart glasses are the area of recent research, and patching is the most effective treatment but has undesirable side effects. But these smart glasses, they are ultra safe, proven efficacy in built frame for prescription of the lenses, and they are most advanced glasses for programmed intermittent occlusion. So they have been found to be useful in treatment of amblyopia. Only thing is they are costly. So another topic is amblyopia with eccentric fixation. Conventional occlusion is still treatment of choice in this sort of patients. Then which comes first, amblyopia or surgery? Classical treatment is amblyopia should be treated prior to the surgical intervention. So I would like to conclude conventional occlusion is still treatment of choice, although part-time occlusion is gaining acceptance after ATS reports. Penalization is useful alternative therapy. Levodopa does not have any role. Near exercises, especially in the form of television games and mobile games, are beneficial. LASIK should be tried in desperate cases of adult and isometropic amblyopia. Smart glasses are gaining popularity in Western world. Pleioptics and chem stimulator, they are outdated. Thank you.
Thank you, Dr. Dadia. What is your opinion about orthoptech for the amblyopia therapy?
I don't recommend these things. They are costly affair. Simple mobile games with the software, they can be tried, and we have found to be useful. Because many companies, they have approached me for these things. I simply ask you, see these mobile games, and we have found it to be useful. Why should we purchase?
Same is true for Binox also?
Yeah.
Your opinion is same?
I don't recommend.
Okay. I request all the speakers of the session to be here for a group photo, and chairman and all. If anyone has any question in the meanwhile from the audience. So with the group photo, we conclude this session and hand over the dais for the next session. Thank you.
So I'd like to invite our next session, Chairman Dr. Gopal Arora sir, Dr. Sandeep Arora, Dr. Jignesh Shah, Mukesh Patel, and Dr. Chirag Shah, Dr. Satya Shah, Dhaval Modi, and Monica Jethani. Next session will be on polishing cataract surgery outcomes.
Good afternoon, all. Thank you, engineers. Thank you.
Hello. Yeah. Thank you, Dr. Praful. That was giving a wonderful insight of a difficult surgery, converting it to look like a very simple one. Thank you. May I invite the next speaker, Dr. Parishit Gokte, to tell us more about how to improve the outcomes in pediatric surgery. Dr. Parikshit is the past president of Maharashtra Ophthalmological Society. All over to you, Parikshit.
The outset, I would like to thank the authors, Dr. Jagdish Rana, the team for giving me this opportunity. Well, all of us, I'm standing in a hall full of great cataract surgeons, and Gujarat is known for its very great cataract surgeons. And all of us do pediatric cataract surgery, though of course pediatric cataracts are different from adult cataracts in so many ways. So at the outset, thank you for inviting me over here and giving me this opportunity. Well, we know the standard practice for a pediatric cataract is we do a baby and a PPC till the age of 24 years, 24 months. After that, we put in a PCIOL. The anterior vitrectomy and the primary posterior capsulotomy is done till the first decade of life. If we have patients who are learning disabled who come from very far, whose follow-up we are not sure, we do it even in the second decade of life. And we have to ensure that the lens is kept into the back. And whatever we say, suturing is a must because the scleral integrity is very, very less. When children's eyes grow and develop, so obviously what we are doing today, a lot of it is going to change. We have to understand. There is going to be a refractive shift after surgery for sure. And this myopic shift in the first year can be about 8 to 9 times. So when we are choosing a lens to be put in a child, Western norms say you undercorrect and you do a reduction and you put in a lens. But then if we are putting in a lens, hoping that this child will become immature, when this child achieves, say, adulthood, when the child is 21, it's like looking at this small baby and saying that yes, we can design this baby's bridal suit when the baby is going to marry after 22 years. Is it possible? No, it is not. So we don't know how the power is going to change. So in case we get a power of say 30, we will not do a 20% under correction. We will put 30 diopters only because that will make our management easier. Yes, this child will become myopic later, but then we can do piggyback figures. For currents, we can do LASIK. There are various ways to deal with it, but there won't be any unlike. The earlier speaker, Dr. Daria, said, amblyopia is a lifelong necessity. So I will skip on all this. We have to have, of course, perfect biometry. And doing biometry in children is difficult because a lot of has to be done under general anesthesia. A-scan will, keratometry has to be done under GA. We have to think of piggyback IOLs later, so it's best to put in the IOL in the back at this point of time. And then some considerations before planning a surgery. Suppose it's a unilateral cataract and this 7-month-old infant. We will put an IOL. And which power? The power that even if it is plus 30 or 31, we'll try to do that here. In a bilateral cataract, will we do it in a single sitting? Ideally, no, because there is always a risk of endophthalmitis. But suppose it's a difficult anesthesia, it's a very small child. So as a routine, when I operate children who are less than 2 years, then as it is, they are keeping them topic. So I will do one eye, dewash, have a separate trolley, have everything separate, and then do the other eye. But it's done under the same anesthesia. Because if we intubate a child, anesthetists don't like to intubate the child again after 7 days. And of course, surgery is risky, but anesthesia is riskier. Will we operate cataracts like this? No. If the vision is better than 618, then even if we operate, we are not going to get very great results, but the child may lose accommodation. So ABPPC till about 10 years. Automated retractor is a must. And should we do the PPC AB before or after putting in the lens? Well, both are the same, but now I prefer it doing after putting in the lens because there have been instances when we did the PPC AB and while we were putting in a foldable lens, the PPC got extended. I am a great proponent of manual small incision cataract surgery, but this is one place where doing phaco emulsification is vastly superior. Because with phaco, we can actually do a proper PC polish and we can polish the equator, we can polish the rim of the anterior capsule and see to it that there will be less amount of data. And suturing the pores is definitely a must. We can even use 8-0 or 10-0 V-grill for that. Nowadays, we have sevoflurane, which gives great anesthesia. There are masks, so we need not intubate the child. That makes the post-operative recovery faster. And all of us are fantastic phaco surgeons. So if it's a child which is older than 13 or 14 years of age, then even under local and topical anesthesia, we can perform pediatric cataract surgery and put in a good foldable lens. And iOS, of course, ideally after 2 years is the best. Foldable lenses for sure. Hydrophobic lenses are definitely better. But multifocals not. Because when we do a multifocal lens, Dr. Kankaria was showing, he looks at, reports from 3 optical biometers before deciding which lens to put in. In multifocal implants, we want to get our lens power calculation bang on. In this child, the child's IOL power is going to change every 6 months. So how can we put a multifocal? And of course, we plan for emetropia now. Follow-up has to be every 3 months. I'll quickly go this over. These are results of a 7 years follow-up in Mirage, the Mirage pediatric cataract study with the longest follow-up ever. So the best follow-up is done by children of educated mothers who are not traveling from far. And if a proper follow-up is done, the proper follow-up definitely improves outcome. Because then we give proper refraction, we can do young lasers, and we give amblyopia treatment. This has been seen from studies from other parts of the world also. Vision in pediatric cataract is best if the child is slightly older. We are doing phaco surgery for developmental cataract, and there is no uveitis. So the multivariate analysis, age of surgery, better pre-op vision, and phaco, when the main factor and just take an example. Again, secondary glaucoma is more common in infantile cataract as compared to developmental cataract. Surgery is not just for vision, surgery is also for seriosis. So if we do bilateral pediatric cataract, about 1/3 gets some amount of seriosis. In unilateral, it's less than 20%. Generally, traumatic cataracts have better results if the cornea and the retina are not affected. Because in traumatic cataract, the child's visual system has developed well, and so the post-operative outcomes are better. So I would like to conclude, visual acuity after pediatric cataract surgery is better when pre-op vision is better. When it's a development rather than a congenital cataract. When we are using phaco and automated detectors in older children who don't have post-op uveitis and who have a proper. Pediatric cataract surgery is expensive. Pediatric cataract surgery takes more time. And these are the results from all over the world. WHO says 90% of adult cataracts would be better than 680. If you will see results, and some of them are from USA, Ed Wilson, perhaps USA's most famous pediatric cataract surgery. The British congenital cataract study done by Chuck, and in all of them, better than 680 is less than 50%. So we have to understand that the chance that the child will get vision better than 680 is less than 50%. But then he or she can definitely get that if we do our best to it. So in pediatric cataract surgery, we worry about the sphere. Torics are rarely needed, but children tolerate progressive spectacles very well. Specs will always be needed, so we have to counsel parents for that. And surgery is just one important step in a series of steps that are needed to improve a child's vision. It is important, but it's not the only thing. Thank you. Thank you for the opportunity.
Thank you, Dr. Parikshit. It was an excellent presentation. Please collect your memento from Dr. Gopal. Dr. Gopal, please. Okay.
Good afternoon, all of you. Today I'm going to be talking to I'm from Asia India. I get my MD from AIMS New Delhi, and I'm currently practicing at
and especially the pairing approach that comes with it. So before we directly jump into the pairing approach and the tricolor, we briefly go over the history. So the first IOL, the tricolor PC connecting IOL was in fact discovered by mistake. So Dr. Hoffer, whenever he had a patient, we saw that the patient had a slightly descended IOL. And imagine, he was expecting the patient to go all about complaints. The patient in fact only had excellent distant vision and get great near vision. And that laid the stepping stone for all the respiratory IOLs that we currently have. Obviously, the first credit goes to Dr. John Pierce, who made the bullseye approach to the PCIs. So basically, when we talk about a multifocal IOL, there are two types of multifocal IOLs. The initial version, which was the refractive version, then came the refractive version, and then came the combined IOL. So when you talk about the refractive model, you can see there will be two options. There will be a two-zone lens, which initially had a zone for near in the center and a zone for distance in the outer. Now, these lenses are very good at correcting near vision. Unfortunately, the problem was in bright light, it caused a lot of problems for your distant vision. Then came the bullseye approach, where there was a zone for distant, surrounded by a zone for near, followed by a zone for distant. But again, while these lenses are very good at distance and near, they did not serve that purpose very well in bright light conditions like right now, when we're looking at a CR and near distance and bright light. So this was then followed by the refractive approach. Now, what was diffraction? So basically, diffraction is a phenomenon in physics where the light bends when it passes through a very sharp object. And this made scientists think that what if there are multiple activations or steps? There would be sharp edges where the light could be bended, and then it would have multiple focus. So this led to the combination of something which we call as the refractive multifocal IOL. Obviously, current generations are a combination of the refractive and the diffractive elements, where the whole IOL is the refractive, while the diffraction steps are present either on the anterior or the posterior side, giving you the multifocal. But again, there was no perfect answer, right? When it came to this, it led to certain complaints. One complaint was the stray light. A lot of steps led to a lot of stray light, which caused a lot of photic phenomena, including halo, glare, starburst. Also, because the light was getting bent at different focuses, there was something which came to the loss of light. This is what we term as the loss of contrast and sensitivity. And currently, if you so these are the photic phenomena. So currently, if you look at all the generations of IOLs that are coming in, they are mainly focusing on two important things. One is the light distribution. In fact, next year we are going to have the span optic flow, or we are going to have the synergy. All of these IOLs mainly focus on increasing the distribution of light and reducing the light loss of the light scatter. But what if I told you that there is already a beautiful lens which caters to make both of these two important answers? Which lens would you ask? That's the geometric lens that I'm going to be talking about today. So the most important thing, how do they manage to do this? So initially when these steps were made, they were of different sizes. Then the companies came with steps which were of equal sizes, which going from very center to very, they would start reducing in steps. This was called as apodization. This led to more focused light and less light scatter. However, it was not the final answer. And therefore, currently we have something which is called as the Gaussian smoothing. So this is one step ahead of apodization. This is basically Gaussian smoothing, where the light distribution and the smoothing of the steps is done so well that the light scatter is much less and the distribution of light can be practically controlled. And that is why geometry has now become my choice of IOLs. For two reasons. Geometry comes in two options. It comes with the geometric and it comes with geometric plus. Let me be very clear, the near and intermediate at both the lenses are same. It's like Jekyll and Hyde. Both is the same person. Only thing is, one lens has a light distribution that is focused for distance and intermediate, while one lens has more focus for intermediate and near. Thus, when used as a pairing approach, with the geometric in one eye and the geometric plus in the other eye, you have a continuous range of vision. Also, surprisingly, they have the entire refractive zone which is restricted in the center, 3 mm zone, 3 to 4 mm zone. And thus, for a viscous fluid in an ambient lighting condition, you have the use of all these rings, making vision quite good. As I told you, they have different light distribution. So if you see at the 3 mm zone, the geometric has 30% distributed for near, 70 for intermediate, and 50 for far. And in the geometric plus, it's 30 for near, 16 for intermediate, and around 40 for far. So basically, the light distribution is only that changes, it's not the power that changes. So the pairing strategy is very simple. You go ahead and implant the geometric in one eye. You do not need to focus for a distance dominant eye. You don't need to get for it. Just if you understand, most of the patients who have cataract will have blurry vision. So it's very difficult to differentiate between a dominant and a non-dominant eye. Geometry keeps it very simple. Go ahead and implant geometry in the first eye. And then if the patient is happy, give him geometric plus in the other eye and make sure he has excellent continuous range of vision and very good near as well as distant vision. So again, just a quick thing. In case of a geometric, you have a great far vision, good intermediate, and a slightly less near vision. But the same thing in a geometric plus, you have okay distance vision, good intermediate, but an excellent near vision. And thus when used together, the same lens, the same thing, behaves excellently well and the patient has great vision. So in our study, again, I was curious and I had attention, right? What if we use geometric in both the eyes? What if I use plus in both eyes? I wouldn't it be great? I get great near vision, patients, putting in needles and threads and everything. So that is what we did. We first put geometric in both the eyes. We put a geometric plus in both the eyes and we used a geometric and a geometric plus in both the eyes. To our surprise, the results were as follows. In a patient having geometric and geometric both eyes, the result was same if you have good doctor. Yeah, just find it out. Similarly, for your near vision, both the geometric plus was good, but it was not as good as the combined. So basically, summing up, it was very simple. Most of the times we would pair. So we would go ahead and put a geometric in one eye, and then a geometric plus in the other eye, and the patient has a very, very good vision for continuous range of vision for distance, intermediate, as well as near. So as I told you, most of my patients would be very happy and had spectacle independence. I don't say zero spectacle or zero power. Spectacle independence 97% of the times. So yes, that I basically conclude my talk. Thank you so much.
Thank you, Dr. Ishan. Please collect your memento with Dr. Gopal. Next, I call on Dr. Rajesh Joshi.
Good afternoon, everyone. At the outset, I thank AGOS for the opportunity. I am working as a professor and head at GMC Yavatmal and heading the Journal of Clinical Ophthalmology and Research. And I am very happy to tell you that I get many articles from this area, particularly from the Nagari and the BJ Medical College. Thank you. Now, this talk is on intermediate vision in the cataract surgery. As everyone knows, accommodation is a process by which eye changes its refractive power so as to get a clear image of an object at a distance varies. So the eye can focus at any distance within the accommodative range. Reduced accommodation range leads to residence of the near point. So that's why we have to focus the object from the distance when we approach towards the presbyopia. Now this restoration of accommodation in pseudophakia can be done with the help of monovision, that is one eye myopic and the other eye emmetropic, by multifocal IOL, by accommodative IOLs, or with the help of using EDOF IOLs. Now, after cataract surgery, expectations are rising day by day. Patient wants near vision, patient wants intermediate as well as distance vision. So how this is possible? And why EDOF is essential? Because most of us now have working on computers, mobiles, so we need intermediate distance more commonly than the near vision as such. The optics of IOL, if you see, there is a monofocal lens which has got distance either near or distance vision very clear, but we have to supplement the remaining with the help of glasses or multifocal IOL. There are two distant foci, one for near and the other for distance, and other one is EDOF IOL, which is having elongated focus of vision. But there are certain demerits of multifocal IOLs. There is reduced light intensity, there is reduction in the contrast sensitivity, there are perception of the rings, particularly in few patients, which takes long time to get accommodated to those rings, and visual aberrations like glare and halos, subnormal intermediate visual performance, thereby impairing the quality of the life. So this one is the new EDOF by Hoya technology. Between the diffracting and the non-diffracting surface, there is a pseudo non-diffracting beam. So that is taken help for the intermediate vision. So what is this pseudo non-diffractive beam based EDOP and what are its benefits? This optical technology is designed to replace the accommodative function of natural lens. This technology enables extended depth of focus characterized by constant resolution and peak of light intensity. This peak of light is obtained through a constructive light wave interference concept generated by a spheric surface of the center of the lens. So this allows the patient to pursue the intermediate vision without compromising on the distant vision. So these are the various types of EDOF IOLs. There are surface modifications in the optics of the IOL, which leads to intermediate vision, which is very clear, and a certain, which is recently available, is with Vivinex Impress. Now, if you see the center part of the optic of the IOL, there is an optical element with a smooth surface profile, creates variations in the power to provide depth of the focus. That is the main principle of this IOL. Now, the long-term outcome depend upon more than the optics alone. The optic is aspheric, spherical aberration correction is there, which is tolerant to coma. Aberrations, aspheric design is tailored for improved intermediate vision, distance visual outcome that are more tolerant to residual refractive error than standard monofocal IOL. The material is hydrophobic acrylic, glistening free and no calcification, and design is C-loop with very low PCO rate. It is available in a preloaded system. With our small series of the patients, in 16 patients, wherein we implanted this IOL in 12 males and 4 females. Routine cataract surgery was done and perfect vision was obtained for distance. Near ad was 1.5 diopter and there were no glare and halos in these patients. This is the defocus curve. This is important to understand. On the left hand side, you can see the defocus curve of multifocal IOL, wherein there is a deepening of the curve, while on the right side you see there is a smoothness of the curve, which is very important. So this is about this IOL in a nutshell. Natural crystalline lens is a perfect multifocal or varifocal lens. Independence from glasses comes at the cost of unwanted disturbing photic phenomena, but in EDOF IOL we can avoid it. High cost continues to be deterrent for the patient, but this is of low cost, and despite having low cost, patient gets the intermediate vision. Thank you so much for your patience listening.
Thank you, Dr. Rajesh. Next, I call Dr. Mohita Sharma.
So, good afternoon, everybody. Respected dignitaries of the dais, all the seniors, juniors, and colleagues who are sitting in front of me. First of all, I would like to thank the Gujarat Ophthalmological Society for inviting me here and giving me a chance to speak. I will be talking about vapor-emulsification with IOL with laser capsulorhexin. This is a new technology which is entered into the market, and I'm working on it with indigenously with Ophthalmology Associates for the last 1.5 to 2 years, and the technology of Ophthalmology will soon be launched into the market. And this may be a game-changing technology because since it is indigenously made, it is economical and it may enter into every ophthalmology clinic. So I'll straight away go on to the video. So this is our very own microscope in which the laser is attached. And there is a console of the laser in which the laser settings are also displayed. So this is a routine vapor-emulsification being performed. You can soon see the two dots which are there, and these two dots are meant for focusing. Staining is a very crucial step in this because this is a laser, which is a coagulated laser, and if the capsule is well stained, then only the laser will be taken up by the capsule, and the stain that is used here is of a higher concentration than what we normally use. So we have worked on various permutations and combinations in the last 1.5 to 2 years to see which is that concentration where this would work the best. Apart from the stain, the visco that we use here is also of a higher concentration than what we normally use. And again, this has been worked out as the most optimal concentration for the laser to pass through. And this is how that magic in Brexit happens. It's actually a magic when it happens. You can see that it is complete with no tags. And as I said, it's a coagulating laser, so it's a continuous laser. It's not like zigzag, like we had the Zepto before, where it was zigzag. So it has a very, very good strength and it is very strong. Now, one very good thing about it is that here we can control the size of rexes also. We have an option of choosing from 4.5 millimeters to 7.5 millimeters, and then we can choose whatever size of the rexes we want. I'm purposely demonstrating a hard cataract, and I purposely made a small rexus of this to demonstrate that this rexus has got enough strength, even in hard cataracts, when the hard pieces come out, then also it sustains and it does not give way. And when I'm putting it with two instruments, it is not giving way, which shows the strength of the capsule. It's a patented technology, and the good thing about it is consistency and reproducibility. Many of you who are sitting here may be wondering why I should do this when I can actually do a very good practice myself in the cystotome. But friends, these are times where we are dealing with presbyopia correcting lenses. We are talking about more and more precision. We are talking about effective lens position, and we are talking about lens centration. So when we want to go more towards precision, we have to become more precise, and we have to adopt technologies which are which take us towards this precision. This type of rexus is effective in almost all types of capsular rexus. Probably where it will not work is when it's a very fibrotic capsule or if there are corneal opacities. Because if there are corneal opacities, the laser will not pass through. The reason for stress is we have seen it under the electron microscope that when we see the edges of the capsular rexus, these edges are outturned, and when we see the edges of the flap, we find that they are inturned. And if you see very carefully, in some parts of the video it is visible that at the margin of the rexus, it is a little whitish. This is basically because, as I said, it's a coagulating laser. We have also done specular endothelial counts also, and we just to check if this laser was damaging the endothelium, and we found that there was no difference when we compared it to a case where the normal cystosome rexus was done. Can I take this out? So this is the lens implantation, and Thereafter, I've already talked about the specular electron microscopy. We have done it. We have been doing these cases for the last 1.5 years, and we have done all these in the form of a study where we have compared cases with when we did and compared with cases which were the laser exercises. Now, another laser axis has already come into the market, but if we compare this laser axis with that laser axis, there are huge differences of price. And when the huge differences of price, that is why I said that this is something which may enter into every ophthalmology clinic. It will be launched over the next 2 to 3 months, and then it will be available for everybody. So the wait starts now, and the wait will soon be over with this laser axis. Thank you so much.
Thank you, Dr. Mohita. Next we call Dr. Rakesh Shah.
To engineers and developers, friends, seniors, and all my colleagues. If I come back to my MS in retina foundation where I did my fellowship, and then 20 years back now to private practice. After studies of different IOLs, and then over a period of time we see all our past knowledge activities now getting big and they are getting different changes. So these are the two things which you can learn. No financial interest in any of the products or instruments which I have used in this video. What is a simple oil opacification? There are different types of oil opacification where the oil is getting big, other haptics are getting tired, we are getting missing effect, maybe the hydrophobic or hydrophobic, but ultimately it's the patient itself concentration. Sometimes we see the entirely totally white oil where it is like it's not been done. Most common what we are seeing the hydrophilic acrylic oil which is getting a calcium phosphate deposit, but there are different triggers. Plastic, humidity, the gas what we use for a keratoplastic anti-killer, it has a vitrectomy where we are using different gas. Sometimes it is just the hydrophobic also oil that is also getting glistening and the loss of vision. The silicone oil which we used to use in the past for the vitrectomy. These are series of my cases which I tried different things to get it inside and get a perfect outcome. Most important is to separate this IOL from the capsular ring, which we can use a different way of active composition or you can use an iron dialer. Use good amount of cohesive viscoelastic to separate the IOL from the capsular bag. You need to be very careful when you are separating the IOL because the haptics are badly adhered to the bag. While separating it out, you may just damage the retinue, which I did in the initial first 2 cases. Be very careful, you can see the bag is getting actually protected. So these are the initial microwaves which I learned because you have to be very careful, you don't just remove this haptic. I'll show you the next stage where instead of removing this haptic from the bag, we just start off with this haptic and just use that haptic and step out of my new one. With the new pixelation, we just had multiple blocking was there and there was sending opacity. Is a total opaque oil that we have done. Get these separated from the bag. With a good oil pattern scissor. Now these are scissors which we need to have use this haptic as a sample for the new order.
for a group photograph. Next, Dr. Rishi and the team to please be ready for the next session.
Hello. We'll change gears now. I am Dr. Rishi Swaroop from Hyderabad, and I'd like to invite the other chairpersons if they are available. Dr. Parimal Desai, Dr. Mohak Shah, Dr. Amit Patel, Dr. Mohita Sharma, and Dr. Vanati. Any of you here? This session is called Advances in Cataract Surgery, but actually there are a lot of refractive talks in this session. So perhaps we can call it Advances in Refractive and Cataract Surgery. We've had some great talks in the previous session, and I'm hoping that we'll have equal vigor in this one as well. The first speaker of this session is Dr. Ashish Bhojak, and he's going to tell us about goals of preoperative evaluation in refractive surgery. Is Dr. Ashish here? Dr. Ashish Bhojak? We'll move on to the next speaker. Maybe he'll join us later. Dr. Mohita Sharma? She's also not here right now. Dr. Aditya Desai? He's going to tell us about silk. Where does it fit in today's refractive armamentarium? Dr. Aditya Desai. All the speakers have 6 minutes per talk.
Good afternoon, everyone. Thank you for having me here. So today I'll be talking about distal glamour surgery from GNJ Arena, and my perspective about how it fits into the armamentarium for any refractive surgery. So firstly, say acronym means the smooth incision lenticule keratogenesis. It is basically a lenticule-based procedure. We know about the slide. That's it, procedure. It can correct myopia from half number to -12 and the case signalizing from 0.25 to -6. So basically, lenticule is made by a femto laser with photo disruption technology. The air bubbles form into the stroma and create a trace-like structure which we remove the lenticule and make the cornea. The main goal for any myopic patient to make it necrotic is to make the steeper cornea flat. The whole purpose is that we remove a chunk of cornea in a disc form and remove it with a 2 to 3 mm. So talking about the platform, this is how it looks like. Has a big screen, which is either controlled by the engineer or the operator. The small screen by the surgeon, screen, has a prism, optical prism which acts like a camera, and as well as it also works for detection within an eye motion during the surgery, and the joystick for the docking process. So, what are the key features of this technology, the same procedure from other lenticular technologies? There are 3 or 4 things I can point out. One is that it has the shortest pulse width, which is of 150 femtosecond. It has the smallest, I would say, the spot size. The laser which forms consecutively. It is just 1 micron distance from each other, so it makes the dissection very smoother. And has a uses a very less energy pulse, which is just 40 millijoules from 90 to 40 with the companies, and now it is even reducing towards 35 to 32 nanojoules. So to explain how these energy, low energy is helpful, the high energy causes a lot of large cavitation bubbles, and glass radiation creates OBL, which is an opaque bubble layer, which gives during the dissection part, to remove the lenticle, it becomes very difficult for the surgeon. Here, it uses a very low energy, and then consecutively it is one of the fastest machines, which is 10 megahertz. So consecutively the lasers are very fast, and so there is no thermal damage as such, and the lenticle remove is very smooth. Another thing which I have talked about is the contiguous spot spacing. So, like I said, traditionally the femto lasers fall at a spot distance of around 3 to 4 micron distance each, but in the silk it is consecutive from 1 micron spot size. So it becomes effortless to remove a lenticle. The one novel feature of it is the only platform which gives a biconvex lenticle, which is all the other platforms gives a plano-convex lenticle. So while removing it retains the original shape of the cornea, it gives better nerve regeneration, less diffraction, and gives a better clarity as well. So these are the comparisons of all the other platforms which provide lenticular movement. The key things which we can see is the pulse duration is just 150 femtosecond, the spot separation is 1 micron, and biconvex lenticle. Now talking about my experience with the same lenticular procedure, since I was one of the first person to do it in Gujarat, I didn't have any place to call on, so I had a learning curve. And like every other new surgery, initially you just dive into it with excitement. Then you realize it's hard, but you still keep on doing because you want to get it right. Just when you feel that you have got it right, you get many surprises. But as you learn from your mistakes, you master the craft and you get it. So I divide the surgery into steps. First is the marking of the axis, which we do it on the slit lamp biomicroscope. Either you can do it with a toric marker as well, or a bubble marker, or 180, marking the axis. The main thing which I love about this technology is that we can compensate this active torsion and hide the centration after the docking process. As you can see in this video, after the marking, when the patient is sleeping in the supine position, we mark the center of the pupil. I would just hydrate the cornea and not keep it dry before the docking process. After putting the suction ring and going ahead with the docking process, as you will see, that is the center will shift a little bit. The point which I marked will shift a bit to the right when we apply. So in this machine, even after docking, I can arrange the centration and even do the cyclone rotation adjustment manually. The lenticule removal is also very smooth, nice and easy. I do it with 2 techniques. Generally, what I do is this is the 2 mm entry point. Usually people open the anterior and the posterior parts. I will open the anterior part. With the I will just go right, left, in one swipe, and go below to the posterior segment again right here. With one swipe, as you can see, the dissection is very smooth, and the lenticule is removed very easily. Obviously, we check whether it is circular. Once that is done, just hydrate the cornea, and I would say I would iron the cornea, iron the normal layer. Another technique is what we call is the lenticular axis. After opening the anterior process, tell the patient to look down. With one swipe, I just remove the lenticle easily. Due to the good spot size, like I mentioned before, the resection is very smooth. So in my experience of 100,000 nights which I have done so far, I would say 89% of them have achieved at least 25-20 vision next day. And by the end of 1 week, almost 96 to 97% have achieved. It works beautifully in pure astigmatic case as well. As you can see in this case, the refractive is pure. I take a minute. And in right hand, you can see minus 3.7 and left hand minus 2.5 pure. And the parameters are good, and you can see the next day post-op result is wonderful. It also works beautifully in a very high map. As you can see in this case, it is minus 8.5 half. In right hand, almost the same in the left hand. And the post-op result is super patient and wow. So in my observation, I would say that almost 90% of them by 1 week don't complain about any dry eyes or night glare, and they resume to their work within 1 week. Out of my 1,000 cases, I would say 3 patients had vacuum loss, which I managed by doing a PG trial in 2 patients and doing a flat surgery at a super patient. Since I don't have time, I just say the super patient came at 90 microns at 3 months. One patient had black spot. Don't have time to discuss that, so just conclude that it is an excellent tool for a surgeon as a learning curve, but once you get it, it's wonderful, and as the name suggests, it is smooth as well. Thank you so much.
Thank you, Dr. Aditya. That was a lovely talk, and you covered all the aspects. I request you to come and take a memento. Yes, please do.
What are the 3 important cardinal points for which you would choose still over smile growth? Because these lenticular extraction now they are top of the top for the dry eyes and learning, and because the concentration of the myopia patient also increased. So in that perspective, for the sake of the knowledge of science, can you tell me 3 important points which make the decision that you should
honestly, I don't have much experience for Spinal Pro, so I can't compare it that much. But I would say my experience would say is that the dissection part, which I feel is great, even the flap making part, because it's just the dissector just glides. You don't have to struggle inside the interface. And the lenticule just comes out like we said, instantly there. That is one aspect I love about it. Second thing I love about this is that I can adjust the saturation and cyclotolerance according to my way. So that which I feel. One drawback also I feel about this thing is that I don't give a microscope. So I have to always shift a patient to another operation theater, and it takes a lot of time in that process. So that is one of the drawbacks as well. Another thing I would say, small drawback, very deep eyes, it becomes very difficult to do it with a speculum. So you have to do it without a speculum and just block it without.
मैं करने वाला हूँ
इसी वाली
आशीष पूजा किया
पहला वाला
पूरा मैंने चेंज कर स्पीकिंग आपको पहले बनाना कर दो
ओके ठीक है तो आपका एक साथ करोगे दोनों टॉक That is a very nice point you made, and I think one more thing which Smile Pro has it going in its favor is that for enhancements you don't have an option like a circle software, and you'll have to end up going for a surface ablation. Thank you. Dr. Mohak, you'd like to speak first? Yes. So I think Dr. Ashish Pojak is not available, and Dr. Mohak is going to give his talk and then also his own topic. So the first topic is goals of preoperative evaluation in refractive surgery, after which he will talk about his most difficult case of the year.
So, I'm just gonna make it quite simple, and I'm gonna talk big on the basis that is the digital medical practice common signal indication of a daily living practice. Before we begin, I would like to keep, remembering this in your mind. We don't require all those fancy instruments like topographers and all. This basic event in your mind is sufficient enough, and I'll be showing you basis for the same. But normally it should be a symmetric toe type. But here you can see there is a symmetric skewing over here, inferior skewing, superior skewing. This is how it should be ideally. So first is 20 period, having an effective around 3.25 square with 0.56 in both the eyes. Documentary is quite good, 550 microns, white to white horizontal 10.9, ACD from 2.56 and 2.50 millimeter. Just have a look at the maps over here. This looks like quite a regular low eye appearance. Or no, all the indices, KI, TKI, PKSD, they are normal. And just have a look at this guy. You have this side posterior close over here. And if you see this map here display, it is absolutely normal, the primary. Let's look at the left side again, symmetric low eye appearance. Nothing abnormal in KI, TKI, PKSD. And again, there is a smile, with small posterior close over here. So what would you do? Whether this is abnormal cornea, whether you go ahead with this or no. So I don't really guys pay attention or no. The patient's right to white was only 10.9. So this pentagram has a limitation. So once the patient's right to white diameter is less than 11.5, sometimes it will be false positive results. Alright. So in this scenario, it was only the culprit is a small white to white and not the patient's total report. So you don't see the patient as a whole. Just don't blindly cover one of these indices along the map to show it. That's a take-home message. So here you can operate the patient easily for any of these procedures, such as the present smile, whatever. In this case, patient 25-year-old PA, minus 4.5 square with 0.5 millimeter, minus 2.75 square with minus 1 to definitely around 500. ACD from 3.39, 3.37, right to right, 11.5, 11.2. Let's look at this map. You see, you can find anything abnormal over here, nothing in the indices. Okay. Nothing on the bearing map. Just take a look at the left eye. You can see here everything abnormal. And you see this bearing and all is absolutely normal. So we decided to go ahead and offer this patient. So we offered this patient back in 2019. We did the SPK 90 microns, the optical zone of 6, residual corneal thickness more than 320 microns, both the eyes. But look what happened when the patient came back in 2022 with the lesion of the vision. And you can see here, when you guess what this is the failure. So although everything was normal, this patient has no rectus, and we did actually take this, but when we look back and we try to find out what was the cause of this, and then we saw the patient's photography. If you can see here, his right eye is having as a shoulder in the first figure, you should have his photography here in the front. You can see here, the side thing is there. And you see this story, again, it's just a crowding and increased doing this there. Although the photography is showing 76%, 78% normal, nothing is showing on the bad, nothing is showing on the bad D and all. So, this do not use the basics, even if you are finding with one thing is abnormal, especially the patient shape, you should not operate that patient. Next case is the young female, 26 years old, minus 5.25, 0.25 sin, left eye minus 7.25 silica with 1.25 sin, 520 is with oblique with 1 against female step, 2 ACDs, and this is how the patient related to the patient that is severe obesity. And this is how the ratio will look. You can see here, this is showing slightly bigger beginning. Now the conducting is showing up. You can see there is a crowding over there, the opacity over there. If you see the value and the battery, absolutely normal. That's why you can see the crowding where opacity was there. And the battery are normal. So whether you will, I think my question will be to whether you will operate this patient or no for this, this option, or you will just wait and watch.
I'm sorry, I was not paying attention. I was just looking at something. Yes. 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 Yeah. Yes. Yeah.
And now patient reports are this. This is the anterior basio base, and this is the Kankaria. This is how it looks like. So 5.25 7 would definitely whether you will be observing this patient.
I think we can do a surface ablation, but I would definitely not do a flap or a cap procedure for this because of the way that graph is going. Yes. Yeah. Could be. And it will also take care of those opacities.
And this is the last case before I speak to another one. This is another case where the 19-year-old female effective error minus 2.75 minus 1.56, 3.75 minus 1. Good ACDs, regular contact error. This is how the report shows. The rotograph, if you see the right eye, symmetrical good eye, absolutely normal. Left eye also seems good. And just have a look. The value is just showing the mild and weird elevation over here. And again, the left eye, you see, it is showing only mild and weird. This is just and the cross patient is contactless where the only anterior loop on this pattern. This everything is normal. Whether you will operate this patient or not.
All my doubtful cases, I'll either do surface ablation or nothing. Yes.
Patient use copper and contact lenses. Whenever the patient is contactless where everything is normal and you get only anterior load on the pentagram and do not worry, do not try to operate the patient there when it's possible, just start a low reading in the load.
Actually,
ask the patient to come back after 10 to 15.
It's useful if you have an epithelial thickness map. Actually tells you if something is going on in the epithelium.
So this is as far as my cross-plot is concerned. So you want to, I think which one? The next topic is my most difficult case, I would say. So this is a 24-year-old young lady came back in 2022, minus 3.5 sphere with 0.5 cylinder, minus 3 sphere with 0.75 cylinder, approximately 559 plus 542. Only trouble were all sense were normal. Only thing was the patient had the primary issue of the sibling. So as the rule says that you should not operate for the laser, and patient wanted to go for the army and the police, patient wanted to 60 season without getting diagnosed, the patient has been operated. So considering the family history of the keratoconus and ultimately soft profile, we decided to go ahead with the trans-PRK. We usually use the side platform, we use the two-step trans-PRK also. This is how the surgery went to. Because you are absolutely pretty common if I'm doing many of the steps wrong. So first we went to pretty more depending on the patient's corner thickness of the OCT. We remove the epithelium like this. First in the PTK mode, you can see with the laser. And then next for the patient retraction, we did the soma ablation. The thing is again the soma ablation. First part was the removal of the laser. And after that, we apply the micromagnetic. We just put down one drop of micromagnetic very along the area of the ablation only nowadays. And we don't use the narrow surface. And after that, washing it with the cheap ESS, which we get usually we do a lot of ESS. So we keep the ESS in the refrigerator. And we also use the treated soap VCL as well. And this is how the patient was after 2 weeks of the follow-up. Absolutely fine, this is individualized, no way and nothing. Then the patient got recruited for the army and was lost on the follow-up because of the training. The patient came back after 11 months with a significant complaint on the division of the visa. And this is how we saw the treatment and the significant benefit to the raise in the center. And patient's pet corrected visual activity from 6.6 went down to 6.26. The patient has this refractive error of minus 6.25 square and minus 5.75 square. And this is how we look for the pendant, and here you can see most of it is not really showing the raise, central reticular raise. But just like any other way, the first thing which comes into our mind is to get the steroid. So we treated the patient with the aggressive steroid, we gave the cyclosporine, we gave the tacrolimus ointment as well. But unfortunately, the patient was still responded and another doctor passed. We had to stop the serious after the 1 month, we had to stop for any someone. Then still I shift the patient to the Dr. Karan Johar, the cyclosporine, tacrolimus, and anti-glaucoma medication. There was no improvement. We followed the patient for a long time, around 6 months. And then finally I gave up and I gave the reflective correction of this patient vision into to 656 partial. And we observed this patient for at least this month, I would say January 2025. And yeah, so patient would like to go for the PTA because it's very was not going to. So I asked the patient whether you want to go for the PTA and then we can take the rest of the year. The patient was too anxious to go for the same thing. And this is how it looked like when the narrative here was there. This is how the mental can look like. So I thought we should have this review. The review every 2 or 3 years regarding the reason and all. It was quite interesting. And I thought that you want to get a good ACD.
It is any.
So ultimately, I
It is just subepithelial haze causes refractive myopic shift.
And now it looks like you can see there is some slight reticular vacancy there. You can see the center hole over here and center hole over here as well. Now, actually, the basic biceps are individually organized. Last exams again.
आमी में allowed है देखिए क्या नहीं ना
Patient both are happy, but this was the right week. It started with the PFA and went back to classes.
Dr. Mohak, if I may interrupt you, how much was the refractive error before the surface ablation? 3.5. It's very unusual for, it would have been nice to see the topos and the OCT post-op. Basically the haze, if it's subepithelial haze and there's significant thickening, that can cause myopic shift, but I have not seen refractive error double like this.
Exactly.
Yeah. Sun exposure, yes. So I think that's the dilemma. They don't want a mark, so you do surface ablation and then you end up with this. So such cases, I think you need to maintain them on steroids a little longer. And it may also be a good idea to kind of maintain them on cyclosporin and other agents which have a role in preventing haze.
So do you use mitomycin in all your cases? All cases. And what? And you did a surface ablation because you wanted to go into army or for any other reason? Okay. That was another reason.
And after that, -8 and up to -5, only operated something. Then I would go more than -5. This is not very in my hands. It was very and then I'll go back. Just go. Thank you.
Now I would like to invite Dr. Rishi Swarup to talk on refractive surgery, complicated case scenarios. Dr. Rishi Swarup is from Hyderabad and he's a well-renowned surgeon from India who does a lot of work on refractive as well as in cornea.
US and specifically China. Orientation and Sandeep was my friend. It's nice to meet all. I'm just going to present 3 challenging cases and I'm hoping that we can have some good discussion and some learning on each of these cases. So this was the first case. The 23-year-old male referred to me by my colleague who had on individual LASIK elsewhere with a microkeratome, a pendulum microkeratome. Early post-operative surgeon had noticed some significant collapse prior, so the patient the surgeon had attacked him and iron and repositioned the flap. Subsequently, the patient felt significant drop in vision and had persistent photophobia, watering, and irritation. This is how the patient presented to me. You can see that in this area there is a staining of the flap, and there is something like a necrosis of the flap right over there. And the flap was sedimented, the upper half of the corneal spine is some filaments there. That's how it looks on staining. You can see that basically this inferior edge of the flap is completely necrosed, and that's basically what is left of the flap edge. And there's a lot of edema and staining at the edge of the existing flap. So, yes, this is flap necrosis. What has caused it, and what would you do now? Flap necrosis probably happened because of the flap relief, the epithelium would have gone in, and the flap edge is not getting enough nutrition. and started melting. The Cariazo pendulum microkeratosis, which is used in this case, is known to be very thin flap edges, and that might have been one of the reasons. So now, if you have a necrosed flap like this, it's really not going to grow back, right? So we decided to see if we can give some medical management for this patient. We apply bandage contact lens, give him supportive medical therapy, topical antibiotic, physiotherapy, lubricants, so that the child see if we can heal this, and somehow if we will fill up all those irregularities, and hopefully we get some visual vision, and then we can do some propagated treatment to regularize the cornea. That's what I was trying. So we gave lubricant, that's how it was. But this edge is continuing to stay, and the patient was very symptomatic. And this patient was from US, wanted to go back very soon and was getting very restless. So a surgeon, I discussed with the primary surgeon, and then we decided, in spite of 1 week of treatment, patients like this, which was still was corrected 680 even with glasses. So we decided to go ahead and do something which was basically amputation of the flap. So the situation was explained to the patient, and essentially this is what we did. You can see the epithelium has grown in here at the area of the enclosed flap, so you have to reflect that, and then reflect the rest of the flap and then excise it, so that whatever grows back then will be uniform and coherent. If you leave that epithelium that's a bit irregular, you want everything to grow back smoothly and at a uniform plane. So we just reflected that flap, just took a scissor and cut it flush, and then washed the bed and left it. One could have applied mitomycin at this stage, but I didn't feel the need for that. So we went there and just put BCL and antibiotics and steroids and lubricants. This is how the patient looked 1 week after the amputation, and you can see 2 weeks after the flap amputation, the cornea is cleared up very nicely, very minimal gaze paracentrally, and the patient actually got very good vision with just a little bit of a cylinder. So the point I'm trying to drive home is these are the reference maps you can see before and after the excision. You can see the OCT, how irregular the interface was. Now a little bit of anterior hyperreflectivity of finalized. So it's okay to excise the flap. If you have complications like very bad ingrowth, whatever it may be, just go ahead and sacrifice it if you're not able to sacrifice the situation. And sometimes you get a very nice regular bed, little bit of residual error will be there. But anyway, we know flap does not contribute to the tectonic state of the cornea. Just get rid of it and get it good out. This is the second case, a 28-year-old female underwent LASIK elsewhere 4 months back. This is an appeal of a white spot over the black part of the eye. This is a month with decreased vision dryness. So this is right almost clear, but left eye is significant cylinder for post-LASIK patient. And when I looked at the patient, the right eye was normal, but left eye you can see that there is whitish deposits and scarring of the flap. And again, you have some necrosis of the flap there with some fibrosis. So essentially, there has been a epithelial ingrowth, resulting in focal necrosis of the flap and irregularity. And you can see all these 40 islands of epithelium as well. So that's what topography was, and that's why you have a cylinder. So the area of the ingrowth is elevated, and then you have compensatory plating. What would one do in this case? One could go ahead and just try to excise the flap like in the previous case. That's definitely an option. Because relifting and putting it back is not an option because the edge is already enclosed. What I decided was to try something different. I tried to gag to eliminate the exterior ingrowth because it's not yet in the visual axis. We use very low energy, 10 shots of 0.5 millijoules, and the endpoint is having little tiny bubbles, which tell you that you keep adequate laser on the epithelial ingrowth. So you may have to do multiple sittings. So this was after 1 month after this laser. You can see it reduced, but still not completely gone. And the topography is significantly regularized. Earlier it was like a symmetric kind of a pattern, now more like a symmetric outline. And the peripheral sticking is there. Even one more sitting of laser like this, and then it became like this. 3 months, so 3 months the same. Repeat react to those remaining islands, and then after 6 months, you can see the epithelium is completely gone. There's a little more scarring in the area where we have done some react. To my surprise, there was also some atrophy on the iris. So this react will sometimes go back and hit the these structures, you don't do any fix in the visual axis. And this is how it was over a period of 6 months. We could eliminate the entire visual growth. The topography became more regular, but of course there was still a lot of cellular left behind, but it was more of a symmetric astigmatism, which is easy to deal with, and we could regularize the surface elevation to meet the current outcome. This is a 32 mirror image, again, key for laser vision correction, the standard for LASIK. This was the refractive error. I thought I'd done uneven LASIK, but first post-operative day, patient is unhappy with vision in only one eye. Right eye is clear on 2020, left eye is 2200 after LASIK. Glass intact, of course, everything is good. I'm just wondering what happened. When I look at the autograph and there is refraction, complete astigmatism in the left, right, and right eye is clear. So, and then you go back to the original refraction, 5 and minus 1.75 cylinder at 170, and here you have a residual 3.5 at 170. In any cases, what happened? While entering yes, my assistant had entered instead of 170, 70, and astigmatism at doubled. Of course, the responsibility lies with us as a resident, but sometimes in a busy clinic, you can make mistakes. You make your entries when you don't have a EMR, you can have writings like this which can be mistaken and can cause entry errors. So that's what happened. You can see the elevation map there, and it's 70 instead of 170. So basically, lesson to learn is always enter the check value personally before you press the foot pedal. Don't depend on anybody else, because ultimately you are answerable to the patient. Inside errors, you can quickly relieve. You don't have to wait 3 months. Within a week, I related this and enhanced the topography guide enhancement. You have to take a slightly larger optic zone, and we got this kind of a pattern of ablation, mostly a hyperotic ablation, so not really the center ground much more. And as you can see, we got a pretty good outcome. This map. And this patient actually came to Ahmedabad 2020, and actually today he prefers taking 2-time laser dive over the eye which had only 1 year. So enhancements of reprints is definitely possible. Sometimes it can be as high as 37.9% as in reported literature. Human error is a rare academic cause of residual error. That means enhancement, and it can be completely prevented by having proper systems. Timing ideally 3 months, but you can do it early, and make sure you don't have the wrong patient, wrong eye, or wrong axis. And of course, protocols and checklists, double checking, having especially checking yourself. So these 3 cases I thought I'd share. I'm standing for members and the EKA Committee of the Gujarat Ophthalmological Society, and we appreciate your support for my candidate. Thank you.
Thank you, Dr. Rishi. Very interesting cases. So just referring to your first case, that I just wanted to ask you, suppose there is a free flap while you're making a flap and you don't know which is upside down. Would you like to just get rid of the flap, or would you like to still try and put it back?
We can always make it staining.
By staining.
The stoma side will stain it, the side will not stain it. There's no chance of missing that, even if you're not.
So you would like to put it back?
I would like to put it back as much as possible, because will have some refractive contribution. But of course, if it's not able to damage in some way, you can get rid of it.
And 6/9 is a reasonably good vision that your patient achieved finally. So I had a free flap where I lost the flap and I had to leave it like this only and put a bandage contact lens. My patient was 6/18 vision with some haze.
With the flap in place.
With no flap. Just put a BCL, and then just like your first case, it healed on its own.
Go back into the circulation.
Yeah. That is what I was considering. So this. And just one more question. What was the YAG energy that you used for that epithelial ingrowth? Okay.
The endpoint is to get those tiny droplets.
Okay. Thank you.
So next we have is Dr. Mohita Sharma ma'am. She doesn't need any introduction, and she will be speaking on the transepithelial PRK. Can it be the first choice?
Can somebody from the AV team come?
वहाँ
While the ma'am is setting up, Rishi
Dr.
sir.
Kudlu, please join us on the panel.
Yeah, Dr. Kudlu sir, please come. Sir, my question is, once you have removed this flap, Rishi sir, while the ma'am is setting up, when you are completely removing the flap, so usually it tends into the hyperopic correction or the misastigmatism,
yes.
if I'm not wrong. So how did you end up with this only minus 0.7? But that was a
So
subjective.
you won't get much, you know, in my experience, I've not had too much experience of losing flaps, but usually it's about under 1 diopter, whatever it is. How is sir? I thought you're not there. It's here only.
So once again, good afternoon, and once again, thank you to the society for participating. I will be
Long time.
I will be talking about trans-epithelial PRK can be the first choice. All of us who practice are familiar with PRK, which we had been doing a few years back, and then this procedure went into final institute, and the two main reasons were pain and pace. With time now, in the last few years, we have seen that there is again a resurgence of service prevention. And this is because, however good our pre-operative assessments may be, we do come across cases where we find there is bacteria and it is and even if it's a very small incidence of bacteria, that one case also becomes a challenge for us. And we don't even want one case also to go into bacteria. And we do not know the reason as to why a patient where we had done a good pre-operative assessment and everything was within limits, why this patient went into bacteria. It could be because of biomechanical instability, or it could be any other reason. However, so this is the reason why there has been in the last few years a resurgence of surface inflammation. One, it is a more biomechanical stability and there is less risk of bacteria. Apart from that, it is also better in borderline pachymetries and borderline physiographies. There are less chances of dry eye. Since there is no flap, there are no flap-related complications. We just saw so many flap-related complications. And since you are not increasing the pressure, there is no stress on the retina. And from the marketing point of view, it is flapless, brainless, and touchless, because many of our patients come to us asking for a brainless surgery. So now there are many studies which are showing the effect of showing the efficacy of this trans-epithelial PRK. The technology that I'm using is the Washer-Long TNO M2 technology, and nowadays most of the machines with trans-epithelial PRK in its modified and better form is available. What is important is the truncated version. The advantage is that it is a very smooth surface and it's a low soft spot energy with a 1 millimeter spot size, and smoothness is important with minimal thermal effects. And this also is something which is responsible for circumventing pain and gaze. Pain and gaze were the two major challenges that we were facing with PRK and with the previous surface of patients, and this is what we have brought over. So in my practice, my majority of cases are now surface ablation and they are in the form of trans-epithelial PRK. As I said, since there is no flap-related complications, there is minimum chance of minimum incidence of dry eye, because even in lenticular surgeries, it is the sub-atrial plexus corneal nerves which are affected, but in a surface ablation, only the terminal nerve fibers will get affected. So the least chances of dry eye are with surface ablation. So what is finally this trans-epithelial PRK? It is a one-step for both corneal epithelial removal as well as total ablation, where epithelium that is removed is equal to the separation zone plus a transition zone, which means that the epithelium that you remove is much less than what you were removing with the PRK. And there is a gap between the EKA and PRK for around 5 seconds, which is a cooling time to avoid any rise in stomach temperature and to avoid pains. Just to demonstrate this procedure, now, as if you follow the rule, first there is an epithelial removal. Just to demonstrate that it is touchless, weightless. Then second, there is a friction. And after that, what I wanted to stress on was the third, which is basically the third layer removal. Because we know that the epithelium is not of the same thickness in the center and the mid-periphery. We used to come across cases of post-operative hyperopia after PRK. Now, with transepithelial PRK, we do not get any cases of post-operative hyperopia because we also, in this third layer removal, we remove extra epithelium from the mid-peripheral region so that the profile remains prolate and it does not become a complete profile. Epithelial thickness maps are important when we are talking of transepithelial PRK because we cannot assume that the epithelial thickness is the same everywhere. We know that the epithelium is thicker inferiorly than superiorly and thicker nasally than temporally. And there is a high inter-individual variability. So what we need to do is that we need to take epithelial maps and then we need to fill in that value only into the machine. This is an article showing that if the epithelial thickness is somewhere around 121 microns. Now, if epithelial is thicker than normal, assuming that normal is 50, when we do a transepithelial PRK, we will land up in undercorrection and vice versa. Hence, feeding in the right epithelial thickness value is important. As I was talking about pain and pace, we have almost gotten over the problem of pain, and this is how we do it. We use contact lens, which is soaked in either we used to use Acuvue before, now we use any Nepathanak or Campinac. And along with this, we use special drops which are diluted proparacaine, which is basically 80% of lubricant and 20% of proparacaine, which is given to the patient for the same day. We prepare it and give it for the same day because it's the same day which is the more crucial day. We remember that when we used to do PRK, we used to get phone calls from our patients at night, shouting with pain, saying that they have lost their eyes. Now this is no longer there because we have supplemented pain with this. And so I'll just quickly wind up. The pain is also less because the diluted epithelial area almost the same. We don't have a very large removal epithelium, and the epithelium that is removed is not irregular. It's a regular removal. As far as post-PRK case is concerned, after transecting PRK, we hardly see any cases. Out of more than 350 or 400 cases that we would have done, we have seen some amount of cases in 2 cases, and there also the visual acuity was 6/9 and patient was not disturbed. And these are the classical ways of getting over case, wearing sunglasses for the first year, using topical steroids for about 3 months duration, using intraoperative micromycin, and we also use cephalosporin for around 3 months, and postoperative vitamins. So finally, transepithelial PRK is a procedure which is there to stay because it is a safer procedure with wider application. Thank you so much. And I also want to request you that I am testing for the post of secretary in the coming AIS election. So I am very happy to seek your vote and support. Thank you.
Thank you, Dr. Mohita. I think Trans PRK is really good, and some of the platforms which have a single step Trans PRK like the Schwind and EX500 are very good because they save a lot of time. They don't allow the cornea to dry, and the epithelial defect is exactly as much as your ablation zone, allowing for quicker epithelial healing and better outcomes. The next speaker is Dr. Krishna Prasad Kudlu, and he's one of the leading refractive surgeons of the country from Udupi, and he will talk to us about choosing the right patient for Press Beyond.
That's where we really practice almost around 60 years. So this is my financial years. So we are not talking about the definition of post-PRK. We are normally before what we used to do, we used to correct the dominant type for distance and non-dominant type from here, but we used to have a blur zone. Now we started doing something called a gray zone where the vision from dominant and non-dominant type meets up and dynamically remains. So why we do this micro vision? Very easy to attack, and that you know that in children very tend to suppress certain blood from one eye to the other. In the patients who can undergo this presbyopia, up to -8 diopters I have done, hypermetropic of +5 diopters, and even I have done even with the metropic also. So make sure that patient doesn't have to get. So normally, being a doctor myself, I see the patient. My chair time for prescription doctor is around 45 minutes. That's very important. I'll ask their family history, what medication they are on, and how their symptoms. Once I ask them, then normally you need to look at the patient particular reaction, whether about ocular motility, cover recover test, pupillometry, if you suspect, and also confrontation in field testing. Once it is done, I think next, this is a very, very important step about the patient knowing the patient dominant eye. So after the secondary refraction you have done, then complication after 3 days, then start doing the refraction. So once the refraction done, both eyes, make sure that duochrome is balanced. Once duochrome is balanced, the next step is to know the patient's dominant eye. So I think even in every patient you are doing cataract, also better to know the patient's dominant eye is very, very important. Make a small aperture in both the hand. Tell the patient to see at 636 independence. Then they need to get that both the hand near to the eye. Whatever the dominant eye, you try to close it. And when you close both the eyes, then suddenly when you close the dominant eye, patient will tell that I cannot be able to see. That means it is the dominant eye. Suppose this patient, the left eye is dominant. Once dominant eye testing done, the next testing is microphone vision testing. Put plus 1.5 diopter in the non-dominant eye. Tell the patient to read for near with the same correction of. Then tell him to read for distance. When you start reading for distance, then keep you continue till the 6-6. If you won't complain of any crossword, these are the patients who really well after presbyopia. Some percentage of the patient can cross, but then we may have to repeat couple of times. Still, patient is not happy. Then these are the patient I don't take them more to presbyopia. Once they go all like dry eye outcome, it's very important indirect outcome, whether the patient has everything they are immediately do. So once it is done, I think these are the different tests to know the ocular dominance. I will not talk to detail. Most of the patients will have a very clear cut dominant eye. That is, dominant eye, always you should treat them for distance and they are non-dominant eye for near. Some of the patients may have alternate dominance, then you need to be double sure that you are doing the perfect test. Once it is done, I think the entire data you will take from the Vasca analyzer for the agrometry, then the data will be transferred from to the CRS master, which is the special software computer system given by the science. So there, but before that, I just want to do this particular test, no financial interest about the eye test, just to know about this dysfunctional lens in there. If the DLI is very low for this patient, that means patient is already, there is some signs of cataract. These are the patients I don't pick them for presbyopia. Once it is done, then all the data is done, then what I do is, I will go to the software. Normally I don't change. For a younger patient, what I do is from 1.5, I just can talk to 1.25. For elder patient around 50-52, I increase from 1.5 to 1.7. So 1.5 with some amount of special application, it will become almost 2.25 for the eye effect, so that they have good vision for distance and near entire journey. So then the entire data has been transferred to the from the pendrive to the either NLAD or non-division. So of course I do flap with the Digimax. It is excellent flap. Once the flap done, I think to be able to see some amount of mobiles also there. Can make the patient during the workup done. Once the flap is done, then the patient has moved from frontal platform to the exam material. Then the flap has been lifted. Once the flap has been lifted, then can give the exam laser. Half a minute more. Just take half a minute. Then exam is done. Then of course the simplest procedure, we will exam laser. Then flap will be put. Once the treatment done, we can rotate both the physical adaptation phase and neural adaptation phase. I think some of the patients get adapted within not even 10 to 15 minutes of the treatment. So some patients even took up to 4 months also. So you need to be considering the patient very well. This is what I did. I told you, we make the dominant eye make non-dominant eye myopic by 1.5 diopters, along with creating a controlled spherical aberration in both the formulas. So basically, it's a binocular treatment. So these are the few two cases actually. You need to know their profession also. This is a regular type of occupation with a 3.25 refractory error. So what we did, we need to do sometimes the contact lens monovision trial also. If he is happy with plus 1.25, you should go with the 1.25 presbyopia only. There is a patient with a 24 years to over human hypermetropy. We did a year this one plus 1.5. Then wanted to see from the glasses. So we wanted to then we did a cycle expecting plus 1.75 for the window. So we need to ask the patient what is their profession. Is the patient jewelry? I think he needed more addition. So even with these single patient, we went with the 1.7. So probably I can say the lesser blended vision still I feel that one of the best available option for presbyopia, provided patient doesn't have it. Thank you so much. Thank you.
Excellent talk, Dr. Krishna Prasad. I have a doubt for you. In pseudophakic eyes, does it work as well as in phakic eyes? And can you do it for patients who have enhanced or advanced monofocals?
See, pseudophakic patient that already those are undergone monofocal ions. I have done around the 18 to 20 patients. Patients do it. Again, free of workup is very important. But patients already undergone I use it advanced monofocal. Patient undergone multifocal. I never been to presbyopia practice. There is no change. So monofocal, definitely you can do it again because you have cataract surgery, plaque with Vizumax does not increase much pressure. It increases only 20 to 30 millimeters of mercury. So still you can do it for patient with pseudophakic. Even patients started coming with cataract I've been doing last 15 to 16 years.
If we don't have a MEL and we were to try some other platform, would you suggest that we can plan by increasing the spherical aberration in the non-dominant eye? Yeah, that is supracore. Yeah. Yeah, but then in this, basically you're also doing a mix of monovision along with increasing the spherical aberration in the non-dominant eye, correct? Yeah.
So they come with a new machine, but single machine, it will be the femtograph also. Then within that machine only they are going to get an examiner with the presbyopia solution. So they are going to launch the ECA machine to see coming.
Interesting times.
So one more thing I wanted to ask you. Suppose there is a patient who has undergone a cataract surgery and a monofocal lens in one eye and wants an EDOF or trifocal in the other eye. Would you do a EDOF and trifocal in the other eye and a presbyopic solution in the other eye? Would you do this combination?
Yeah, again, because 90% of the patients will have it. I don't know many other things. Right eye is dominant, I put a monofocal, it is almost around 16 years ago. Non-dominant eye is the multifocal. The teen has no more.
Non-dominant, you put a multifocal. So in the dominant, did you do a presbyopic solution for LASIK or could you do?
If you put a multifocal or trifocal, any of them, there is more than sufficient for the real. You don't have to touch the platform.
And one more question. You've done a presbyopic LASIK and patient comes with cataract. What lens do you implant?
Patient, couple of patients, I think 5-6 patients have come to me. What I do, I put both eyes, not aspheric monofocal lens. So my preferred one is, of course, no financial interest. I put the model number 209 from size. That is the non-aspheric monofocal lens. And making a non-dominant eye myopic by 1.5. So the amount of spherical aberration is correct in the further remains of a state even after the treatment of
Okay. Thank you. Thank you so much.
Thank you all. It's a good session. Request all the speakers and panelists to just be there for a picture. Yeah. Dr. Mohak. Photographer. Madam, आप भी मैडम आप भी आपका तो दे दीजिए ना आपका भी है
चलेगा
करा दो मैडम
This video illustrates the edgeless phase matching technology of the Naturo Panfocal IOL. The edgeless phase matching technology transcends the boundaries of refractive and diffractive optics. In refractive optics, multifocality is achieved by different regions of the lens having different curvatures. The light from each zone is directed to a single focus based on the divergence of the zone. All of the light energy from a particular zone is directed a specific focus. At the focal points, light rays do not bear any specific phase correlation. There is significant light loss and side effects from stray light at the zone transitions. These lenses are always pupil dependent, because exposure of a particular zone of the lens through an aperture leads to a light distribution that is extremely skewed in favor of a particular focus. Diffractive optics has managed to address the perils of refractive multifocals by utilizing interference. These lenses have a diffractive profile imposed on the curvature of a monofocal lens. From each zone, the light gets split into different orders of diffraction. Pupil independence is achieved as each zone can contribute light to at least two different foci. From each zone, the light energy that reaches a particular focus interferes constructively to achieve a higher contrast. However, there is significant unaccounted light loss, which results in waxy vision, poor contrast, and photic phenomena. This is because light energy falling on the portion of the lens surface forming the edges gets wasted. Various modifications of the diffractive profiles are focused on modifying these edges or reducing their heights and numbers in order to reduce the adverse visual effects. Edgeless phase matching technology features the LMAX profile, which utilizes 100% of the lens surface to shift and match the phase of light energy incident on the surface in order to achieve several foci and subfoci. The wasteful surface is completely eliminated. Each zone of the LMAX profile splits the light energy to distribute it to at least 3 foci and subfoci. Light waves incident at these foci interfere constructively to achieve enhanced contrast sensitivity. Desired light energy distribution or pupil independence is achieved while eliminating unaccounted wastage of light and resultant photic phenomena. Edgeless phase matching technology thus achieves the most physiological, natural quality vision, naturo.
Thank you, sir. It was an academic feast for us. Thank you for sharing this. And just a question, if you can throw some light on your experience on how the contrast gets improved after implanting these IOLs.
Yeah, this is something different negative. Then good A constant optimization. So I think once they are very much perfect, I think these are the lens to see only. But again, coming to all these premium values, the first simple test is that putting a dot light, knowing the pupil size. If the pupil is small, even if you put a range lenses also, refractive lens, patient will never have done that. So you need to know the pupil, scotopic and mesopic pupil size, knowing the patient's dominant light, even in cataract treatment, that is going to be the perfect.
Thank you, sir.
It is a really new thought.
Now we have Dr. Gopal Arora, who is going to share his thoughts on flex with natural oil.
Well, hello, am I audible? Hello, yeah. Respect to the chair and my seniors and my dear friends. I'm going to speak, I'm trying not to duplicate things what Dr. Kudlu had mentioned, but this is something that I really admire this lens, because what all you expect from a lens that you put in an eye is that there should be no night driving problems, it should be spectacle independent, and there should not be any loss of contrast, which a monofocal suffices. So basically, as told by Dr. Kudlu, 10% of most of the penetration of light is hampered in any lens that you have rings. Then there is compromise in the distance, the quality of vision. There is variability in refraction with respect to the pupillary size, the optical side effect about the glare and halos, and you need to have true competition to the monofocal lens. So this lens, which I already mentioned, it's an edgeless phase matching technology. It's one of the patented technology, and it gives you 100% light, which is used for achieving the working distance for all distance, intermediate and near. If you go to the defocus curve about this MTF, which is expected to be 0.45 and 0.30 for distance and intermediate, in this panfocal lens of Nature, it gives you 0.6 and 0.45. So it surprises what the USA FDA guidelines actually have meant for. Here is the comparison about all the monofocal, EDOF, trifocal, and the panfocal lens with respect to the visual acuity for distance, intermediate, and near, and the complications and the side effects which is expected from any ring lenses. So if you see, if the bilateral implantation, it gives you approximately 6x6 and an intermediate vision in 100% of the cases. If it is a 33 centimeter distance where you have the reading distance, then there may be an issue. I do accept and agree with that. I have tried this in one trifocal with this natural lens. I have tried in this monofocal aspheric other lens, the clear lens exchange in a young patient, one-eyed patient, and even a post-RK. I have done 9 eyes with a post-RK patients also, and the results are excellent. Looking at the defocus curves, it gives a good distance, intermediate and near, even in a dim illumination. This is a comparison of what I told you about the one-eyed patient and a traumatic where the pupil is actually more than what is expected, but still it works wonderfully. As already told by Dr. Kodli, the positive and the negative cuneiform, which is a conventional trifocal and the negative cuneiform, it combines these two effects and gives the best result which is expected from any lens for distance, intermediate and near. Basically, the light that is being used is a comparative picture, that entire light, as if it's the serrated edges, the utilized lights and the wasted lights are different, but in this case, 100% of the light is used, which gives the best results. I'm quoting one example. It's a hypermetro pi ACD of 1.67, K reading of 39, and this I had operated. This was an ophthalmologist. The anterior chamber depth was very less. And you can see I've done a femtocataract in this case. We are docking, and since there was a 0.67 astigmatism, so we attempted doing an arcuate incision just to reduce that astigmatism, pre-existing astigmatism. Here is the arcuate incision, lens fragmentation, capsulotomy, and the clear incision with the side ports being done. I'm just opening the incisions already done using a good viscoelastic because it was a shallow anterior chamber to protect the endothelial cells, which were not so much reduced, but still considering the anterior chamber depth, you can see comfortably we can remove the capsulotomy, which is already being done. Now the beauty of the femto, you can see, I'm just rotating the nucleus. I'm putting in a phaco probe, and as you can see, I can actually separate each pieces from the other one. I am not doing any phacoemulsification procedure. I'm not putting any energy here. I'm just separating with the tip and the dialer. So all these pieces are getting separated. And if they are not 100% separated, once we are trying to eat up each individual pieces, it automatically gets detached from the adjacent piece, which shows that the nuclear division by the femtocataract has been done precisely and adequately. So it's just a simple procedure of eating up each nuclear pieces which comes to the tip of the phaco probe one by one, it follows as if we are just need to take care of what the vacuum and the aspiration rate is, and it actually gets attracted to the tip of the phaco probe, and it gets eaten up comfortably because we have to take care, because the anterior depth is not much. We don't want to compromise on the endothelial cell loss. So once you're done with the managing the nucleus, you can just do the aspiration of the cortex. Bimanual is something I would prefer. I always use bimanual. And once the cortex is removed, the one that Dr. Kudlu showed was a preloaded one. Even if you do a non-preloaded one, if it's natural, it is just like implanting any other monofocal lens. So it's a very, very simple implantation of the lens, putting in the cartridge, putting in visco, and normally I do a hydro implantation, but since this was a shallow anterior chamber, I put viscoelastic, covered the endothelium, and implanted the lens in a very comfortable way. You just with one other tip, you just dip the optic and the IOL goes in the capsular bags. Just remove the viscoelastics and do the hydration of the main wound and the side port, and your surgery is done. And you can see the rings, which are actually doesn't cause any glare halos, but it wonderfully works for both distance, intermediate, and bilaterally done, it works for near as well. So basically, it's an edgeless face matching technology, works with full light transmission. 100% of the light is being used, both superior for distance, intermediate, I can say bilaterally for near as well, and it's a glistening free material. So it offers a good quality for all distances, and you don't need to bother while counseling the patient, gives excellent night driving, true spectacle freedom, and very forgiving even in amblyopic cases. So I give once again thank AGOS for the opportunity given, and I humbly request everyone here to give their kind support for the post of Joint Secretary AIOS. Thank you so much once again.
Dr. Gopal, for your excellent presentation.
Thank you, sir.
Now the next speaker is Dr. Ragini Parekh. She'll be speaking on interesting phaco cases. Please.
Sir, Mr. Chair, I would like to thank the Gujarat Ophthalmological Society, the president, EKA Arena, the whole team for inviting me here today. And my respective teachers, Dr. Lanik sir, Dr. Amar sir, and all the senior teachers, Dr. Rekha, Dr. Java, everybody present here today. So these are a few cases that I would like to present. As you can see over here, this is the intumescent cataract. You can see the brush of the cataract is intumescent and it is very little space to work. So it is essential to stain the capsule. Keeping the stain for at least 20 seconds makes it much easier to see the blue color. See the blue exits. As you can see, the fluidics have to be very good. The ultrasonic energy has to be perfect. And we have to chop. The energy that we use to chop and make it into pieces is very, very important because that protects the corneal endothelium. So here we have a straight chop, and now this is emulsifying the pieces to bring the pieces in such a way that the posterior edge of the piece does not face the posterior capsule, so that it will not make a PC tear. As you can see over here, the lens is very big. This is the second case. Like we said, when you stain it for longer, it really helps. And it is much easier to do a capsular exit. Forceps can be used or a needle can be used. In these cases, we use forceps by epsilon. This is forceps to be used then by epsilon. Of course, I have no financial interest, and they are very, very helpful. They can be used in the side port also. So sometimes you can get a fossil effect, which is something which is actually not very desirable because this is a very soft cataract, and you may not know when you will reach the posterior capsule. So in such cases, what you want to do is you want to lift this whole nucleus out and then emulsify it. So lifting one of the edges of the nucleus, which is called as the nucleus salute, will help. You can also go in, stop before the oscillation occurs, and do a hydro and lift the nucleus. So you have to check the anterior chamber depth to know. If you see this patient has a anterior capsular opacification. This could be because of trauma or it could be seen in so many patients. Now, while doing the exits, one has to be careful to see that you are outside of this fibrous edge, because otherwise the rexis is not going to be complete. So you have to go outside of this calcification. It may be a larger rexis. And if you're not comfortable, you can switch over to forceps. It is very, very important to get a good rexis. It may be oval or round, but a complete rexis. Because once you break the commitment to rexis, you break the commitment to phaco. The nucleus is lifted like this. There's no need to panic. You can use visco and you have to hold the nucleus properly. Now, what is holding? What causes holding is called as the volvoability. So the machine which holds the nucleus well, and you have to work in the center part only. You don't need to go into the periphery to fish the nucleus. Sometimes the finesse, as you may want, in multiple pieces may not be there. This happens because this cataract does not have an epinuclear buttress. It has no support, and that is why this piece is vertical and it floats like this. But as long as the phaco holds the nucleus, you are safe. So the probe holds the nucleus, and the second instrument helps you to chop. So in these cases, it's very important to know your machine, to know your parameters, and as you can see over here, the chamber stability is very, very good here. The construction of the tunnel is very important because it is also for safety. This looks like a white cataract, but as you can see, there is a nuclear cataract underneath it. So again, the rexis is very, very important. And we must be prepared when we examine the patient to know that this is not only a soft cataract, this is a hard brown cataract and the cortical milky material. So there is not going to be any nucleus. The nucleus is going to float, and we need a proper parameter. So as you can see over here, this is a brown cataract. You have to embed it properly, the nucleus tip, and this is the straight Nagahara stop. The center part of the nucleus will be the hardest, and if it separates, the periphery will separate. Separation of the posterior digitating leathery fibers is very, very important. As you can see, this nucleus rotates a lot because there is no support. So I will finish in a few seconds as soon as this video gets over. And you have to do more than 4 pieces because this is a hard, bulky nucleus. It's not necessary that you should do only 4 pieces, but whenever you make a piece, you should be careful that the posterior irregular sharp edges are not directed posteriorly. As soon as you emulsify and aspirate one piece, space is created so that you are able to emulsify the other pieces. And when the last piece is emulsified, one must be careful to see that you are in the anterior chamber for some time because otherwise collapse or surge will occur. And I think this is one patient. Can I show this video? So in this patient, what we are trying to do is try to aspirate the milky fluid, not knowing that this was probably a traumatic cataract. The needle has, because it was very soft, and this excessive aspiration has caused posterior capsular tear. As we can see, this was traumatic because once you start to do a rescue, it is difficult. So it is very difficult to do the rexis here. So you use the forceps. Cataract is very soft though. And as you can see, this was traumatic with fibrosis, but all well that ends well. So basically, hard cataracts or difficult cataracts can be done. A lot of patients and procedures is necessary.
Thank you, madam, for excellent presentation. I now request Dr. Rastogi to give his talk.
Good evening. Really thankful from the bottom of heart to the AGUS and talk on, as madam already done, hypermature cataracts. So basically, everyone knows that it is the advanced stage of the cataract, which is dense, rigid, and opaque, and difficult to deal with. So reasons are liquefied cortex, mobile cortex, and risk of the phacolytic glaucoma and zonular weakness. These are four things, that is Artinian flag sign, and there can be break in the capsule, there can be corneal decompensation, and ultimately dropped nucleus. So this is a brief video. In this we have done the mini CCC, and while just aspirating the cortex, yes, the break has happened. So that has extended, and that thing has to be dealt with in such cases. So ultimate goal is the safe nucleus management, saving the capsular support, and of course the optimal visual outcome. In these cases, with the patient, we have to discuss the outcome, and we should not overcome it. So another thing is the laser surgery, flax. In such cases, that is advisable, but that gives the precise capsulotomy, good lens fragmentation, and accurate corneal incision. But besides this technique, if at any stage we feel we are doubtful of the outcome, we want to avoid the complications, and we are scared from the bottom of heart, we don't want our heartbeat too fast, SICS is the last arrow in our cure. This is the case. It is a hypermature cataract, and staining done. CCC tried, but it was becoming difficult. So I took a decision to convert into SICS. So staining and visualization in these cases, madam has already told so many things. Trypan blue under air, that is the good, useful and safe. And basically, air prevents the direct endothelial contact, so that prevents the dilution of the dye. So this is another case of hypermature cataract. We have done the staining, and a CCC is done. By doing deep budding direct chop, we can conquer these lenses. So managing intralenticular pressure and capsular access in these cases, there are so many ways to do CCC and release intralenticular pressure, but ultimate outcome is that you have to achieve a good CCC and prevent the complications. So in that case, OVD, that is high viscosity viscous, is used. So in these cases, handling capsular fibrosis and zonular weakness, that dual microscope or micro seizures, or we can do radial relaxing cuts, or of course the capsular tension ring, so that the further zonular damage is avoided. Another case, good CCC done, mobile nucleus, and a good break achieved in the nucleus. So ultimate thing is that you have to achieve good CCC. Just releasing the intralenticular pressure, but the CCC was extending, so use the micro seizures so that the perfect cut is achieved here. So intraoperative nuts and bolts, that use phaco system with torsional or longitudinal sedative if available, active fluidics to maintain the chamber till the last, and balance aspiration flow and the vacuum. So thing is, again, flax, that is, though it is significantly expensive, not necessarily consistent with long-term visual outcome, they are equivalent, and depends on the patient's specific eye condition and surgeon's preference. And of course, the availability of the machine is the one thing. So summary is, You have to identify the general risk factors. There should be good visualization at the time of the surgery, good CCC, and of course the safe nucleus removal. IUL plan, depending on the CCC or depending on the technique used, we can plan the surgery. And of course, whenever we are in difficult situation or feel something that we are not able to do, we can always do SICS. And of course, depending on the complication or if there is anything, we have to monitor the patient. Thank you very much. Standing for request appeal for member AIC, North Zone. Thank you very much.
Thank you, Dr. Rustagi, sir. I think SICS has no contraindication, it means like that. Okay, thank you, sir.
Thank you, sir.
Now I request Dr. Rakesh sir to give his talk.
No financial interest in any of the products or any lenses or any other products what there is no need. So what are the problems faced on a day-to-day in ophthalmologist? The post-RK copies are usually the pre-lateral zone of cornea. Or most of the machines will give our diameters, the topography will be in the center coordinated paracentral zone. The results are not matching and then we always overestimate the post-operative hypertrophy. The surface irregularities lead to variable steepening and flattening. And then what is the intraoperative manipulation we do? Operating instability, which always gives us surprises in such cases. Considering all these challenges, most of them are usually slightly more myopic. So I use my reading from the Lenstar or the other biomarkers, put data into online calculator, take a final reading, and if there are variable cuts, basically a number of cuts followed by it, we average out our reading. So these are the different machines which we use to calculate. The Kankaria has a very particular finding in the central 3 mm zone. That's one machine which we have, which gives the reading, average reading in the central 3 mm zone. We do this online calculator, then get a final reading and then compare with different machine, and maybe sometimes you have to average out the reading. The post-classing, the process remains the same, but then you need to use the calculator. Post-Wikipedia, because most of these Wikipedia have different material, and very few companies you can actually then look after this, and you need to see and put this data about the gene thickness to get a final calculation. Most important of the counseling, because if you are not counseling this patient well, and if you get a post-operative very high hypertrophy, this patient are going to beat your head. So counseling is very important in all these patients. So what are the intraoperative difficulties and how do you face it? Most of the phaco incision are usually 2.2 mm. I keep the low infusion pressure. The wound basin is an actual occurrence in case if you are expecting multiple cuts, then always take a pre-existing sutures. Based on your surgical technique, you can use the phaco or a SICS incision. If you are in doubt, always take the fluorescein. Always try to place the incision between the two cuts to avoid any damage to this cut. Elastic substance. The main board again has to be written in your place very smartly, either on simple incision or the right is clear incision. Watch carefully, you have the wound lesions coming up here. Being a low infusion pressure, you can still manage your surgery. You can suture at the end of the surgery, or if required, with the pre-existing building, if you are expecting such outcome.
Another patient, you can still go for a good hydrophobic or tonic iron. This patient had a multiple scar. You use a tonic iron with a very good outcome. A very high iron patient with a tonic, and then the results are still very good. Patient goes for a near negativity with a 6th invasion unaided. Very low, very bad, like with a very hard knock. You may have a required exercise also, and such cases also does very well. They develop smart calculations for available care group. The results are very good. So post-operative, the primary is a hypopixel with a power changes and some surfaces which have counsel the patient well, then usually the patient does not have an issue. Thank you very much, and again I request everyone to have your blessing and support for AIs and everyone scientific community. Thank you very much.
Thank you, Dr. Rakesha. Very informative presentation. Now I request all faculty member of this session to come on stage for group photograph. With this, we conclude this session, and now, after a small tea break, we will start our inauguration function.
and gentlemen. Ladies and gentlemen, please stand up and attend.
「
Our chief guest and guest of honor has already arrived. Within a couple of minutes, we are going to start our inaugural ceremony. Please be with us. Thank you.
I would like to invite on stage our President, Dr. Vishnu Patel, sir, our Secretary, Jagdish Rana, sir, Treasurer, Dr. Bhavik Jala, our Scientific Chairman, Dr. Sandeep Arora, sir, Conference Chairman, Dr. Divyang Brahmbhatt, sir. Please come on the stage and join the dais, sir. Dr. Hitesh Ramanuj, sir. Organizing Secretary, Dr. Parth Rana, Bhaumik Rawal and Meir Patel. Conference Treasurer, Ashish Saxena, Rupesh Shah. Scientific Committee, Dr. Jitendra Jethani and Dr. Mohak Shah. Please join the stage. Dr. Jitendra Jethani, sir. Once again, a very warm welcome to all the dignitaries and chief guest and guest of honor, sir, to the inaugural ceremony of EGOS Summit that is going to happen in the world's first heritage city of India, Ahmedabad, at a very nice location, EKA Arena Club. As our tradition, I would like to invite and request all the invited dignitaries on the stage and chief guest to proceed for lamp lighting and prayer to inaugurate the function. Requesting all the dignitaries, our chief guest and guest of honor, sir, please join us for the lamp lighting.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणातीताय गुणाधीशाय गुणप्रवीणाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि
Thank you so much, all the dignitaries.
Dear colleagues and friends,
સ્ટેજ પર બેઠેલા આપણા મહાનુભાવો અને dignitaries, I welcome you all on behalf of all Gujarat Ophthalmological Society. I have already told you and messaged you, this is the AGO summit where we are having 450 plus and it has crossed the 500 figure today. We are having 500 plus delegates today in this AGO summit. In this summit, we have a unique program of a drone training also, which is the first time in any ophthalmology concerns where we have crossed the distance of 100 plus doctors, those who have taken experience of and training of this drone training. We have a 14 plus academic session during this session, where we have a 35 plus national faculties and 100 plus local faculties. We all know this is a beautiful venue located near Kankaria Lake, and the lakefront, which is world famous here. We can have a morning walk tomorrow at the lakefront, and we can enjoy the fresh, healthy air and the Kankaria environment tomorrow morning in the early, I think 7 to 8 or 7 to 9 a.m. So again, I welcome you all on behalf of Gujarat Ophthalmological Society. I hope you will enjoy the hospitality of our Gujarat Ophthalmological Society, especially to our national faculties. Thank you. Thank you so much.
Now I would like to invite Dr. Bhavik Jhala, Treasurer of All Gujarat Ophthalmological Society, to give introduction of our chief guest and guest of honors.
Hello. Good evening, everyone. Very warm welcome to the world first heritage city, Ahmedabad. I welcome all the faculties who have come from a long distance with full of enthusiasm and sharing their knowledge. For Gujarat people, they are knowing, but I will give a brief introduction of our chief guest, Sri Hasmukhbhai Patel sir. He is member of Parliament, East Constituency. He is honest and a well-known public figure. I would like to invite Dr. Vishnu Patel sir to felicitate Hasmukhbhai Patel sir. I would also like request to Dr. Jagdish Rana sir, Dr. Divyang sir, Dr. Hitesh sir to join Dr. Vishnu sir. Thank you so much, Hasmukh sir, for sparing a valuable time for us. Thank you so much, Hasmukh sir, for sparing a valuable time for us. For ophthalmologist, this name is not new, and there is no any introduction required for him. Professor Dr. Amar Agrawal is a renowned ophthalmologist and internationally acclaimed innovator. He is a chairman and MD of Agrawal Eye Hospital, handling more than 269 plus branches in worldwide more than 7 countries. I would like to invite Dr. Brahmbhat Divyang sir to felicitate Professor Dr. Amar Agrawal sir. I would request Dr. Jagdish Rana sir, Dr. Hitesh sir to join Dr. Divyang sir. Dr. Parth, Dr. Bhaumik, Dr. Mihir, kindly join. Dr. Saxena sir. He is the person from you always get motivations and spirits and strength to treat your patients fearlessly. Thank you so much, sir, for sparing your time. Padma Shri Dr. T.P. Lahane, sir. He is a deeply rooted yet impregnable Honorable Padma Shri awarded in 2008 by selection. He is well known to provide outreach services to unreached people in India. What I got personal experience for my last 3 years, he is very humble and very kind and very down-to-earth person. He is always ready to help anyone who is in trouble. I would like to request Dr. Sandeep Arora sir to come on the stage and felicitate Dr. T.P. Lahane sir. I would request Dr. Jagdish Rana sir, Dr. Divyang sir, Dr. Hitesh sir, Parth, Bhaumik, Mir bhai, Ashish Saxena sir, Rakesh bhai, please join Sandeep sir. I thank Mr. Neeraj Kumar Badgujar sir. He is IPS Joint Commissioner of Police Sector 1 in Ahmedabad city. He has spared his valuable time for us and he has accepted our invitation for the conference. I would like to invite Dr. Parth Rana to felicitate Sri Neeraj Kumar sir. I would request Dr. Jagdish sir, Dr. Divyang sir, Hitesh sir to join. Sri Devendra Bhai Bhatnagar, he is the state editor of Divya Bhaskar. He has shared his values in Divya Bhaskar and providing a valuable information to us, positive and no negative news. In Divya Bhaskar we are reading. I would like to request Dr. Jagdish Rana sir to felicitate Devendra Bhatnagar sir. I request Dr. Divyang sir and Dr. Hitesh sir, Dr. Parth to join Dr. Jagdish Rana sir. Thank you so much, sir, for sparing our valuable time. I would like to now request our own President, Dr. Vishnubhai Patel, sir, to have some few words about the conference and the event. Please, sir.
આજના સમારંભના મુખ્ય મહેમાન શ્રી હસમુખભાઈ, અતિથિ વિશેષ આસિસ્ટન્ટ કમિશનર બટગુજર સાહેબ, બિરાજેલા મહાનુભાવો, સરસ કોન્ફરન્સ રહી આપણી, વેલ ઓર્ગેનાઇઝડ. એક જ હોલની અંદર ઘણા બધા સમય પછી એક જ હોલમાં બધું કર્યું, મલ્ટિપલ હોલમાં દોડાદોડી નહીં, એક જ હોલ. અને ઓવરઓલ ઇટ વોઝ અ વેરી ગુડ એક્સપિરિયન્સ. એટલે થેન્ક્સ ટુ ઓલ ઓર્ગેનાઇઝિંગ ટીમ, દિવ્યાંગ, જગદીશ રાણા, સાયન્ટિફિક કમિટીના ચેરમેન અરોરા સાહેબ, બધાએ બહુ સારી મહેનત કરી છે અને એકદમ સુંદર 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 સરસ થયેલું છે. અને આ સ્ટેજ પરથી ઓલવેઝ સારું જ બોલવું જોઈએ અને બધા સારું જ બોલે છે, પણ મને થોડું ઘણું ખરાબ બોલવાની બી ઈચ્છા થાય છે, એટલે બોલી જ નાખું. બરોબર ને સંદીપભાઈ? હા, એટલે બધું વેલ ઓર્ગેનાઇઝ સરસ, પણ ટ્રેડમાંથી ખાલી એક જ કમ્પ્લેન છે બધાની કે સાહેબ આટલી બધી કોન્ફરન્સ કરો છો, પૈસા ક્યાંથી આપીશું અમે? સી આઈ થિંક દેટ ઇઝ અ જેન્યુઅન પ્રોબ્લેમ છે એમનો. અને બહુ બધી કોન્ફરન્સ હવે ઓલ ઇન્ડિયા થશે, ડોસ થશે, બધી ચાલુ એક મહિને દરેક જગ્યા પર. સપોઝ મહેસાણામાં વર્ષમાં 5 કરીએ, સુરતમાં કરીએ છીએ. એટલે આના માટે આપણી એક્ઝિક્યુટિવ કમિટીએ કંઈક ના કંઈક વિચાર કરવો પડશે રાણા સાહેબ, સમથિંગ. કારણ કે જ્યાં સુધી કેપેબલ માણસો આ પોસ્ટ પર છે ત્યાં સુધી તો તમે જોર કરીને બંદૂકની અણીએ પૈસા લઈએ છીએ આપણે. મારી વાત સમજો, આપણે બંદૂકની અણીએ એમની જોડેથી પૈસા લઈએ છીએ, ધમકીઓ આપીને લઈએ છીએ ટ્રેડવાળા જોડેથી. લેટ અસ ક્રિએટ સમથિંગ કે આપણે એમના જોડે બંદૂકની અણીએ નહીં પણ પ્રેમથી સામેથી આપે એવું કંઈક આયોજન કરો ને એવું કંઈક વિચારધારા ડેવલપ કરીએ આપણે, તો થોડુંક સમન્વયથી કામ થાય. ને સમન્વયથી કામ થાય તો પોઝિટિવિટી વધારે ડેવલપ થશે. અને જો એવું થાય તો કોન્ફરન્સમાં વધારે થોડાક તારા અને ચાંદ ઉમેરાશે. બાકી વેલ મેનેજ્ડ, વેલ ઓર્ગેનાઇઝડ, એક્સલન્ટ કોન્ફરન્સ. થેન્ક યુ.
Thank you, sir. Now we are going to felicitate our star national faculties from all over India. I request Dr. Upendra Kalaigar sir to come on stage, and I request Shri Hasmukh Patel sir to felicitate him. Dr. Upendra Kalaigar sir. He is very well known and very senior ophthalmologist from Surat. He has devoted whole life for our poor patient and all ophthalmic patient services. So I request Hasmukh Bhai to felicitate him. Okay. I request Dr. Upendra sir to give few words as an appreciation.
ખૂબ ખૂબ આભાર. ગુજરાત ઓપ્થેલ્મિક સોસાયટી, એના ટીમ લીડર્સ અને ઓર્ગેનાઇઝર. આ એવોર્ડ મારે 75 વર્ષ પૂરા થયા પછી મળ્યો છે. એને માટે મારા માતા પિતા, મારા ખૂબ લર્નેડ અને વિદ્વાન ટીચરો નાગપાલ સાહેબ, માથુર સાહેબ, વોથરાજાની સાહેબ, શ્રીવાસ્તવ સાહેબ, નારંગ સાહેબ, ભારતીબેન લવિંગિયા વગેરે ટીચરોએ મને આંખની મેડિકલ અને સર્જિકલ પ્રેક્ટિસ શીખવાડી અને એમને આપેલા એથિકલ પ્રેક્ટિસના સિદ્ધાંતો મેં મારા જીવનમાં ઉમેર્યા, અનુભવ્યા અને આચરણમાં મૂક્યા. માટે હું 75 વર્ષે બી સ્વસ્થ છું અને આ બધા ટીચરોને, મારા પેરેન્ટને, મારા મેટરનલ અંકલ, દાદા, નાની, આ બધાને ખરેખર ખૂબ આભાર માનું છું અને એમનો હું ઋણી છું. કે જેમને કારણે હું આ મને લાઈફ ટાઈમ એચયુએલ મળ્યો. એથિકલ પ્રેક્ટિસ કરો, પેશન્ટને સીધી રીતે સારી રીતે સમજાય તેવી એની ભાષામાં સમજણ આપો, કોઈ કમિશન લેવું નહીં, કોઈ કમિશન આપવું નહીં. એમઆર પાસેથી, ફાર્માસ્યુટિકલ કંપની પાસેથી, કોઈની પાસે, અને ગરીબ પેશન્ટો, અનાથ, સંત મહાત્મા, વિધવા, દિવ્યાંગો આ બધા પાસે થોડુંક દયાપૂર્ણ અને મોટો રાખી અને જો આપ પ્રેક્ટિસ કરશો તો જીવનમાં સફળતા મળશે જ. અને લાંચ રૂશ્વત અને કોઈ લોભ લાલચ રાખવી નહીં, બરાબર, કારણ કે સંતોષ જ મોટામાં મોટો ધન છે. બરાબર, મારા એક્સપેક્ટેશન કરતાં ભગવાને ઘણું બધું આપ્યું અને સુખી પરિવાર, સારા ડૉક્ટર મિત્રો, સારા ગુરુજનો માર્ગદર્શો, એના માટે હું આપ સર્વે વડીલનો સર્વેનો ખૂબ આભાર માનું છું. થેન્ક યુ સર. સર્વે ભવન્તુ સુખીનઃ, સર્વે સંતુ નિરામયા, સર્વે ભદ્રાણી પશ્યંતુ મા કશિત દુઃખ માપનું. અહીંયા બેઠેલા સર્વ વડીલો, મહાનુભાવો, આપ સર્વેને સુખ, સમૃદ્ધિ, નિરામય જીવન જીવો એવી હું હાર્દિક શુભેચ્છા આપું છું. થેન્ક યુ સર.
I will request all dignitaries on dais to come in front of the dais so that we can felicitate all the doctors. Please come in front of dais, please.
Hello. Now I would like to come on stage Dr. Ashok Thadani, sir. Dr. T.P. Lahane, sir, will felicitate Dr. Ashok Thadani, sir. I would like to come stage upon Dr. Kiran Shah, sir. Dr. Amar Agrawal, sir, will felicitate him. He's not there? Okay. Dr. Bharat Shah, sir. Dr. Amar Agrawal, sir, will felicitate him. I would like to call upon stage Dr. Vishnu Dhol, sir. Shri Devendra, sir, will felicitate him. Dr. Shri Devendra, sir. I would like to call on stage Dr. Natwar Prajapati, sir. Dr. Natwar Prajapati, sir. Dr. Hasmukh Bhai Patel, sir, will felicitate him. I would like to call upon stage Dr. Nitin Trivedi, sir. Dr. T.P. Lahane, sir, will felicitate Dr. Nitin, sir.
Round of applause should not stop. These are our own senior doctors who has served the community for so many years. And treated patient. We know Dr. Nitin Trivedi, sir. has treated patients also. And
Now
he has
I would like to
treated so
call
many
upon stage
ophthalmologists
Dr.
also.
Bhartiben Lavingya ma'am.
Clap for Trivedi sir, Bharti ma'am.
Dr. Amar Agrawal sir will felicitate her. Now I would like to call upon stage Dr. Rekhaben Bharwada ma'am. Shri Neeraj Kumar sir will felicitate her.
Thank you so much, ma'am. Now we are going to felicitate our star national faculties for their immense contribution for the scientific session and coming all the way to Ahmedabad. Dr. Vishnu Patel sir will felicitate Dr. T.P. Lahane sir. Please bring the trophy. Now, Dr. Vishnu Patel sir will felicitate Dr. Amar Agrawal sir. Big round of applause for all the national faculty for taking out time from their busy schedule. Dr. Ragini Parekh ma'am, Dr. Vishnu Patel sir will felicitate her. Dr. Krishna Prasad Kudlu sir will be felicitated by Dr. Vishnu Patel sir. Okay.
I would like to call upon stage Dr. Gopal Arora sir. Dr. Jagdish Rana sir will felicitate him. I would like to call upon stage Dr. J.S. Balla sir. Dr. Jagdish Rana sir will felicitate him.
Big round of applause for all the national faculties.
I would like to call upon stage Dr. Sharad Lakhotia sir. I think Dr. Sharad sir is not there. I would like to call upon Dr. Inder Moore Rastogi sir. I would like to call upon stage Dr. Harshul Tak, sir. I think he is not there.
Next, Dr. Arvind Moria, sir. Our chief guest, Sri Hasmukh Patel, will felicitate him. Dr. Subhas Dadia, sir. Dr. Amar Agrawal, sir, will felicitate him. Next, Dr. Rishi Swarup, sir. Dr. T.P. Lane, sir, will felicitate him. Dr. Ankur Singh, sir. Sri Neeraj, sir, will felicitate him. Dr. Navendu Rai, sir. Sri Bhatnagar, sir, will felicitate him. Dr. M. Vanathi, ma'am. Is she here? Okay.
Now I would like to call upon stage Dr. Mohita Sharma, ma'am. Shri Hasmukh Patel will felicitate her.
Thank you, ma'am.
I would like to call upon stage Dr. Kirti Singh, ma'am. Shri Neeraj Kumar sir will felicitate her. I would like to call upon stage Shri Dr. Sharad Lakhotia, sir. Dr. Divyang Brahmbhatt, sir, will felicitate him. I would like to call upon stage Dr. Vinita Ramnani, ma'am. Dr. Sandeep Arora, sir, will felicitate her. I would like to call upon stage Dr. Swati Tomar, ma'am. Okay, she is not there. Dr. Manisha Rathi, ma'am, please come on dais. Dr. Hitesh Ramanuj, sir, will felicitate her. would like to call upon stage Dr. Prafulla Kumar Maharana sir. Dr. Bhavik Jala sir will felicitate him.
Next, Dr. Rajan Gupta sir. Dr. Ashish Saxena sir will felicitate him. Thank you, sir. Dr. Rakesh Shah will be felicitated by Dr. Parth Rana. Dr. Rajesh Joshi sir will be felicitated by Dr. Amar Agrawal sir.
Now I request Dr. Vibhuti Kashyap to come on the dais, and I will request Dr. Bhaumik Rawal to felicitate him. Now I request Dr. Maya Hada to come on dais, and I will request Dr. Sri Hasmukh Bhai Patel sir to felicitate her.
I would like to invite Dr. Satyajit Sinha sir. He will be felicitated by Dr. Mihir Patel. Dr. Pooja Sinha ma'am will be felicitated by Dr. Rupesh Shah sir. Okay.
She is not
आप ले लो
there, I
sir,
guess.
please. Okay. Dr. Raman Mittal sir will be felicitated by Dr. Rupesh Shah sir.
I think Raman sir is not there. I would like to call upon stage Dr. Tinku Bali ma'am. Shri Neeraj Kumar sir will felicitate her. I would like to call upon stage Dr. Harshul Tak sir. Shri Devendra Bhatnagar sir will felicitate him.
ટ્રોફી સાચી છે જોઈ લો ને એક વખત પરીક્ષિત બોગટેની આવી ના ગઈ હોય. Last but not the least, Dr. Parikshit Gokte sir will be felicitated by Dr. Rupesh Shah sir. Yes. Done. Now I would like to invite our today's chief guest, Sri Hasmukh Patel sir, to share his feelings and give few words. Please, sir. Cordless mic. Sir. Please. Please come on the dais, sir. Please. Thank you so much, sir, for taking out your precious time. Please, sir. Fine.
બધાને નમસ્કાર. એગોસ સમિટ 2026માં આપણી વચ્ચે ઉપસ્થિત સનિષ્ઠ પોલીસ અધિકારી અને જોઈન્ટ કમિશનર ઓફ પોલીસ અમદાવાદ માન્ય નીરજકુમારજી, ગુજરાત ઓપ્થેલ્મોલોજીકલ સોસાયટીના અધ્યક્ષ ડૉક્ટર વિષ્ણુભાઈ, આપણે બધા જ જેમના માટે ગૌરવ લઈ શકીએ એવા પદ્મશ્રી એવોર્ડ વિજેતા ડૉક્ટર રાણે, કમિટીના એક્ઝિક્યુટિવ સેક્રેટરી ડૉક્ટર જગદીશભાઈ રાણા, સન્માન્ય મંચ, એવોર્ડ પ્રાપ્ય ડૉક્ટર્સ અને સૌ મારા વાલા ડૉક્ટર મિત્રો, મારું સદભાગ્ય છે કે આ બીજી વખત એગોસના સમિટમાં હાજર રહેવાનો મને અવસર મળ્યો છે. અંદાજિત 5 વર્ષ પહેલાં રાધે ઉપવનમાં આવી જ એક સમિટનું સુંદર આયોજન થયું હતું અને ડૉક્ટર જગદીશભાઈ રાણા, જેમની જોડે વર્ષોથી મારો નાતો છે અને હું એ વખત કદાચ નવો પહેલી વખત સંસદ સભ્ય બન્યો હતો અને આપની વચ્ચે ઉપસ્થિત થવાનો અવસર મળ્યો હતો. આ વખતે પાર્લામેન્ટ ચાલુ હતી, દિલ્હીમાં હતો. જગદીશભાઈનો ફોન આવ્યો કે આવો. મેં કોઈ એક વખત આવ્યો છું, ફરી નહીં આવું. અને મારા અધ્યક્ષ અને મારા ભાઈ વિષ્ણુભાઈનું નામ આપીને રીતસર ધમકી આપી કે આવવું જ પડશે. અને ડૉક્ટર વિષ્ણુભાઈ મારા, અમે બે કઝિન છીએ અને વિષ્ણુભાઈ પ્રમુખ હોય એટલે મારે આવવું પડે માનીને હું આપની વચ્ચે આવ્યો છું અને આવીને મને ખૂબ આનંદ થયો. સૌપ્રથમ તો બધા જ એવોર્ડી ડૉક્ટર્સને અભિનંદન આપું છું. તો ટેકનોલોજી અને નોલેજ એ એન્ડલેસ જોબ છે. હું પણ ટેક્સટાઇલ એન્જિનિયર છું અને આવા જ એક એસોસિએશનનો પ્રમુખ છું. અમે પણ દર વર્ષે આવી નેશનલ લેવલની, સ્ટેટ લેવલની કોન્ફરન્સ આયોજન કરીને ટેક્સટાઇલ ઇન્ડસ્ટ્રીના નવી જે ટેકનોલોજી, 4th જનરેશન ઓફ ધ ટેકનોલોજી વિશે અમારા ટેકનોક્રેટ્સને માહિતગાર કરતા હોઈએ છીએ. આવી કોન્ફરન્સના માધ્યમથી કોઈ પણ ક્ષેત્ર હોય, આંખનું હોય કે બીજા કોઈ પણ મેડિકલ ક્ષેત્ર હોય કે એન્જિનિયરિંગ ક્ષેત્ર હોય, નવા જ્ઞાનનો જે આવિષ્કાર થયો હોય એનાથી આપણા ડૉક્ટર મિત્રો માહિતગાર બને એ ખૂબ આવશ્યક હોય છે. હું અપેક્ષા રાખું છું કે આ સવારથી જે સિરીઝ ઓફ લેક્ચર્સ આપણે એટેન્ડ કરીએ છીએ, કારણ કે સિનિયર ડૉક્ટર્સને અનુભવ હોય પણ નવી ટેકનોલોજીનો જે આવિષ્કાર થયો હોય, નવી જે શોધો થઈ હોય, એની માહિતી તો આવા વાંચનથી મળે, આવા સેમિનાર એટેન્ડ કરવાથી જ મળે. એટલે આવા નંબર ઓફ લેક્ચર્સ આપણે એટેન્ડ કર્યા હોય એનાથી આપને ઘણી બધી ટેકનોલોજીથી અપડેટ થયા હશો. આવા સુંદર કાર્યક્રમનું આયોજન કરવા બદલ હું એગોસના સૌ કમિટી મેમ્બર્સને ખૂબ ખૂબ અભિનંદન આપું છું અને આપના માધ્યમથી
માનવ શરીરનું મહત્વનું અંગ, એટલે આંખને આપણે રતન કહીએ છીએ. આપના માધ્યમથી આ દેશના નાગરિકોનું રતનની જાળવણી થઈ રહી છે, ત્યારે આપ સૌને ખૂબ ખૂબ શુભકામનાઓ. ધન્યવાદ.
Thank you so much, sir. Now I would like to invite Dr. T.P. Lane, sir, to say a few words on behalf of
Good evening. Chief guest of today's function, Honorable MP Sri Hasmukh Patel, Dr. Amar Badguzar Sahab, Devendra ji, and the Jagdish ji, Vishnu Patel ji, and all the dignitaries on the dais, and dignitaries and all the ophthalmologists, faculty and delegates, and the association members of Gujarat Ophthalmic Association. Good evening to everybody. The conference which is organized is very well. Basically, it is in one hall. I must appreciate the organizers. Because of that, it is possible to attend each and everything. Secondly, the science what they have kept is very well, because, sir, now the ophthalmology is changing near about weekly. Weekly there are changes in the treatment of ophthalmology. And, sir, Gujarat is a forerunner. It means you will see all the things, that means from phaco or from retina, they have started first in Gujarat. And I think it is a really, I am very much proud that they are doing good work. Sir, MP sir, as you are there, I want to request one thing. As an ophthalmologist and working for the people, sir, we have got one problem, that there is one nursing home act that you have passed in the Lok Sabha. Sir, we don't need admission of the patient in our hospital. As you are I think you are a very honorable MP. Sir, we require a daycare. It means in the morning we are admitting it means patient and going home. Because there is a nursing home act, sir, the insurance people are troubling us that we will have to show the admission. And we don't want to do such wrong things, sir. So my request will be there, sir, you are the powerful person in the India now. So my request will be the ophthalmologists near about, sir, we are near about, sir, 31,000 ophthalmologists in India. And if you take this question in the Lok Sabha and talk to the Honorable Prime Minister, sir, our problem will get solved. Otherwise, what is happening, sir? We are being troubled by the insurance people and other people. They are deciding our rates. As we don't know anything, they are not giving money, they are reducing the amount. And because of that, sir, ophthalmologists are in the trouble. So if you will pass this daycare bill, sir, we will be very much, I think, thankful to you, sir. And I think you will do it in this. Thank you very much, sir. So basically, ophthalmologists, we all together. If you see Mumbai, there is not a single consumer case in Mumbai against ophthalmologists from 20 years now. So we should be together and we should not criticize our colleague, because whatever surgery he is doing, he is not doing any bad thing. There is the response of the body of that person. So you get some problems. And so we should not criticize our colleagues so that we will not required to go in the court of law. We should have, because we are the soft target now. So we should unite together. And I think the Jagdish is there at the helm of. We must help each other. Secondly, as a Maharashtra, for the EIOS association, that is a conference, we have helped, the Maharashtra has helped the Gujarat, so that the All India conference should be in Gujarat, and we have taken our claim back. so that the Gujarat will have this one. Same thing, as you can say, the Maharashtra and Gujarat, few doctors are contesting for the association election. And I request you people that definitely we can help the all India people who are there today, but also we can help the Gujarat and Maharashtra together, so that our association members can be the member of All India Ophthalmic Association. And I will promise you, Maharashtra will help Gujarat, all three candidates. And I will also send you the message. And also, you should also help the candidates from the, you can say, Maharashtra, and we will work together. Thank you very much. Thank you, Jagdish.
Thank you so much, sir, for your wonderful words. Now, I would like to invite Dr. Amar Agrawal, sir, to share his feelings.
Dignitaries on the dais, my very good friend Dr. Jagdish Rana, ladies and gentlemen, it's such a pleasure to come here and be the chief guest for such a great conference which is conducted by this great society. I've been part of the M&J Institute. I've learned everything from these people who came and got felicitated here. Right now I can see here Dr. Bharti Bain here, Nitin Bhai here, Rekha Bain, all these people, so many. I saw Parival Desai also here, who was my very close friend when I was doing my MS here for so many years. Ladies and gentlemen, the society you've got is such a fantastic society. And to be honest, I'm also part of the same Gujarat Ophthalmic Society. I wish you all the best, and I wish every candidate who's standing for elections also all the best. Congrats for such a stupendous conference, and to each of the persons who are standing, hats off to all of you, because I know the hard work you're each putting in for traveling so much, staying away from your families, and really canvassing. Really, God bless all of you. Thank you so much.
Thank you so much, sir, for your encouraging words. Now I would like to invite Shri Neeraj Kumar Sarji to give his insight and few words, feelings.
मंच पर विराजमान माननीय संसद सभ्य श्री हसमुख पटेल साहेब, पद्मश्री राणे साहेब, एसोसिएशन प्रमुख डॉक्टर श्री अने मंचस्थ हमारे सभी डॉक्टर साहब और जितने भी डॉक्टर साहब को आज फेलिसिटेट किया है और मेंबर्स, आज मुझे डॉक्टर राणा साहब ने इनवाइट किया था कि आप हमारे जो कॉन्फ्रेंस है उसमें आप आइए, भाग लीजिए। मैंने डॉक्टर साहब को बताया कि हमारे जो पुलिस ऑफिसर्स हैं उनको भी जो आई डॉक्टर्स हैं उनके एक केस स्टडी बताई थी। शंकर नेत्रालय है तमिलनाडु में, उसमें हमें उसकी केस स्टडी हमें इंडियन स्कूल ऑफ बिजनेस में हमारी मिड करियर ट्रेनिंग में उन्होंने बताया, और बताया कि कैसे एक आर्मी बैकग्राउंड से एक डॉक्टर साहब आए थे और उन्होंने किस तरीके से जो गरीब लोग हैं उनको, जो पेमेंट वाले लोग हैं उनके साथ में मिक्स करके किस तरीके से सोशल सर्विस किया और किस तरीके से उसको एक अच्छा मॉडल बनाया, और कैसे हम पब्लिक सर्विस में जो विक्टिम्स हैं या जो लोग हैं उनको हम अपनी पुलिसिंग में भी कैसे हेल्प कर सकते हैं, उसको हमें बताया। और आज डॉक्टर साहब ने हमें ये भी बताया था कि हम जो आज पार्टिसिपेंट्स हैं उनको साइबर क्राइम के बारे में भी उनको हम जागरूक कर पाए। हम अपने नॉर्मल डे टू डे पुलिसिंग में काफ़ी बार ये देखते हैं कि डॉक्टर्स जो हैं वो काफ़ी टारगेट होते हैं, उनको अलग अलग प्रकार के फिशिंग मैसेजेस हैं, स्कैम्स हैं, डिजिटल अरेस्ट हैं, और उनको व्हाट्सएप के ऊपर गलत डीपी से उनको कॉल करा जाता है, उनको स्कैम किया जाता है। अलग अलग प्रकार के जो साइबर क्राइम्स हैं उनसे उनको टारगेट किया जाता है। और कई बार अब ऐसे भी ग्रुप हैं कि उनके सीसीटीवीज जो हैं हॉस्पिटल्स के, उनको टारगेट करके सीसीटीवी फुटेज को लीक करके उनको बेचा जाता है। तो मुझे एज ए पुलिस ऑफिसर मैं आप सब लोगों को ये बताना चाहूँगा कि गुजरात पुलिस और अहमदाबाद सिटी पुलिस की जो साइबर क्राइम यूनिट है वो काफ़ी अवेयरनेस भी फैलाती है, और इसके साथ साथ कंट्री लेवल पे साइबर क्राइम रिपोर्टिंग पोर्टल पर काफ़ी जल्दी एक्शन लिया जाता है। आप लोग 1930 पर कोई भी अगर उसका विक्टिम बनता है तो उसको रिपोर्ट करेंगे तो उस पर इमीडिएटली एक्शन होगा। खुद से भी गुजरात पुलिस के द्वारा जो म्यूल अकाउंट्स हैं जिनसे आपके चीटिंग करके पैसा भेजा जा रहा है, उसको भी पकड़ने की और बंद करने का पूरा काम किया जा रहा है। आप जो मेडिकल प्रोफेशन से हैं, आप भी बहुत ज़्यादा केयर कीजिए कि आपके जो मोबाइल फ़ोन पे आप जिस तरीके से एक्टिविटीज़ करते हैं, अननोन एप्लीकेशन को डाउनलोड नहीं करना है। अननोन नंबर है तो उसको उसके साथ में बहुत ज़्यादा ऐसे बात नहीं करनी है कि आप कि कोई आपको ऐसे मोटिवेट करे कि आपको हम स्टॉक मार्केट में इन्वेस्ट करवाएंगे। आपके पास कोई लूज फंड है तो आप उसको हमारे यहाँ पर इन्वेस्ट करिए। वो APK फाइल डाउनलोड करवा के आपको दिखाएगा आपको बहुत ज़्यादा प्रॉफिट हो गया है, उसके अंदर आपके साथ चीटिंग हो जाएगी। फिर आपको बताया जाएगा कि आपको कोई CBI या किसी दूसरी CID ब्रांच से वारंट या समन्स आया है, या आपको स्काइप के थ्रू कोर्ट के सामने जाना पड़ेगा, उसमें वीडियो कॉल करके पुलिस ऑफिसर बन के आपको डराया धमकाया जाता है, तो उसमें आप तुरंत लोकल पुलिस को कांटेक्ट करिए। तो एज ए पुलिस ऑफिसर मैं यही अवेयरनेस के साथ आपके साथ ज्वाइन हुआ हूँ, और आपको ये 2 दिन की जो कॉन्फ्रेंस है उसके लिए बेस्ट विशेस। थैंक यू।
Thank you so much, sir, for giving us valuable information. Now, I would like to invite Shri Devendra Bhatnagar, sir, to share his feelings.
नमस्कार। घर में कागज के प्लेन बनाकर उड़ाने वाले को अगर अंतरिक्ष विज्ञान के बारे में बोलने को कहा जाए और उसकी जो स्थिति होगी वही स्थिति मेरी आप लोगों के सामने, इसलिए आप थोड़ा सा उसको उस तरीके से लेना। तो बेसिकली मैं सिर्फ कुछ एक्सपीरियंस आप लोगों से शेयर करना चाहता हूं, और एक मीडिया पर्सन होने के नाते हमारी क्या भूमिका हो सकती है उसके अंदर, वो बस आप लोगों से मुझे बात करना है। बेसिकली जब कहा जाता है कि कोई भी जब बीमारी होती है तो बीमारी का कोई इलाज नहीं होता, लेकिन आप जिस बीमारी के डॉक्टर्स हैं उस बीमारी का बहुत इलाज है, और वो इलाज है अवेयरनेस, और उस अवेयरनेस में मीडिया की भूमिका सबसे ज़्यादा है। उसी प्रकार जैसे अभी हमारे IPS साहब बोल रहे थे कि साइबर क्राइम जिस तरीके से बढ़ रहा है, जिस तरीके से फ्रॉड के केसेस बढ़ रहे हैं, तो फ्रॉड के केसेस और साइबर क्राइम को रोकने में अगर किसी की भूमिका है तो वो मीडिया की है। जितना ज़्यादा लोगों को हम अवेयर करेंगे उतनी सारी चीज़ें हमारी ठीक होंगी। इसी प्रकार जो जिस तरीके से आजकल हम देखते हैं, चूंकि मेरे भी बच्चे हैं, मैं अपने आसपास की चीज़ें देखता हूं, जब अखबारों में बहुत सारी चीज़ें आती हैं कि मोबाइल के कारण या टीवी के कारण या वो ब्लू स्क्रीन्स के कारण बच्चों की आंखें कमज़ोर हो रही हैं, किसी की आंखों में वो भेंगापन आ रहा है, किसी को उसका विजन डाउन हो रहा है। तो इसका इलाज क्या है? इसका इलाज ये नहीं है कि हम बच्चों से मोबाइल छीन लें, इसका इलाज है कि हम उन बच्चों को ये समझाएं या उनके पेरेंट्स को समझाएं हम कि मोबाइल का उपयोग कितना और किस तरीके से करना चाहिए, कितनी डिस्टेंस पे करना चाहिए, कितनी दूरी पर करना चाहिए। मैं कुछ पिछले 2 महीने पहले मैं गुलजार साहब से मिला था, चूंकि साहब ने बच्चों के ऊपर बहुत सारा लिखा है, उन्होंने बहुत काम किया है, तो मैंने उनसे कहा गुलजार साहब से कि साहब आप इस पे लिखिए कि बच्चों का मोबाइल कैसे छुड़ाया जाए। तो उन्होंने मुझे कहा कि यार अजीब आदमी हो आप, आपके ज़माने में मोबाइल नहीं था, बच्चों के ज़माने में तो है, और आने वाली जो दुनिया है वो सारी दुनिया मोबाइल के ऊपर चलने वाली। आप उनसे उनका मोबाइल मत छीनिए, आप बस ये देखिए कि वो उस मोबाइल का उपयोग किस तरीके से कर रहे हैं, किस चीज़ के लिए कर रहे हैं। तो ये सब चीजें चल रही हैं। हम डॉक्टर पार्थ राणा के साथ में जुड़े हुए हैं, बहुत सारी चीजें आती हैं, बहुत सारे केस स्टडीज वगैरह आती हैं और उसको हम अखबार में बड़ी प्रमुखता के साथ प्रकाशित भी करते हैं। उसका उद्देश्य हमारा ये होता है कि ज्यादा से ज्यादा पेरेंट्स उसको पढ़ें, उसकी गंभीरता को समझें और जो अवेयरनेस की चीजें उसमें निकल रही है उसको अपने बच्चों से बताएं, उनको समझाएं उनको कि इससे क्या क्या नुकसान हो रहा है। अभी टेक्नोलॉजी का जमाना आ रहा है, बहुत सारी चीजें बढ़ रही हैं और जब जब कोई टेक्नोलॉजी आई है, मेडिकल साइंस ने उस टेक्नोलॉजी को सबसे पहले एक्सेप्ट किया है, उसका सबसे ज्यादा फायदा उठाया है। अभी रिसेंटली एआई आ रहा है, एआई तेजी से जिस तरीके से बढ़ रहा है और मुझे पूरी उम्मीद है कि ये एआई की सबसे बड़ी अगर क्रांति कहीं होगी तो आप लोग उस क्रांति के पार्ट बनोगे। आई सर्जन जो होते हैं आंखों में, उसमें सबसे ज्यादा इसके उपयोगी होने वाला है। और दूसरी चीज ये है कि आज जब मैं बहुत सारे पेरेंट्स से मिलता हूं, चूंकि हमारा एक इनिशिएटिव है नो नेगेटिव मंडे, कि हम सप्ताह की जो पहली शुरुआत है वो पॉजिटिव खबरों से करें, तो उस सोच के साथ हम कई बार पेरेंट्स से मिलते हैं, उनसे बात करते हैं, उनके इश्यूज को समझते हैं। आप यकीन नहीं करेंगे, अगर मैं 25 पेरेंट्स से मिल रहा हूं तो 90% पेरेंट्स का एक ही कंप्लेन होती है कि बच्चे मोबाइल नहीं छोड़ते आजकल। तो उस मोबाइल के चक्कर में उनकी आंखें कमजोर हो जाती है। जब हम उनके टीचर से मिलते हैं, टीचर से बात करते हैं, तो वो भी बताते हैं कि अब सिर्फ आंखें कमजोर नहीं हो रही, इनका कंसंट्रेशन कमजोर हो रहा है, ये फोकस नहीं कर पा रहे, ये चिड़चिड़े हो रहे हैं। तो आप देखिए वो एक चीज आंखों से शुरू होकर उनके पूरे बिहेवियर को बदल रही है। और यही मुझे लगता है कि अब डॉक्टर्स की जिम्मेदारी भी अब यहाँ पर शुरू होती है कि जब वो पेरेंट्स से मिले या बच्चों से मिले तो सिर्फ बीमारी की बात न करें, उस बीमारी के पीछे जो वायरस एक्टिव होता जा रहा है उस वायरस की बात करें। क्योंकि हर पेरेंट्स के लिए पेरेंट्स अगर कोई है तो आप लोग हैं। चूंकि जब हमको कोई प्रॉब्लम होती है तो सबसे पहले हम आप लोगों की जब उम्मीद की नजर से देखते हैं कि आपके पास इसका क्या सॉल्यूशन होगा। जब मुझे ये कहा गया डॉक्टर राणा जी ने कि आपको इस कार्यक्रम में आना है तो मुझे थोड़ा संकोच भी था, चूंकि मैं इन सब चीज़ों को समझता नहीं हूँ, जानता नहीं हूँ। मैं एक पत्रकार आदमी हूँ, मुझे लिखने का बड़ा शौक है, बट मैं यहाँ पर सिर्फ इसी सोच के साथ में आया कि मेरे बच्चे भी इन्हीं सब चीज़ों से जूझ रहे हैं। तो मैं आपसे अपना अनुभव शेयर करूँगा और वो एक्सपीरियंस बताऊँगा जो एक पत्रकार होने के नाते मैं इन दिनों फेस कर रहा हूँ। किसी ने एक बहुत अच्छी लाइन बोली थी, तो मुझे लगा आप लोगों को वो लाइन सुनाना चाहिए कि आंखें सिर्फ देखने का औजार नहीं होती, आंखें सिर्फ देखने का औजार नहीं होती, ये वो खिड़कियां हैं जहां से जिंदगी हर सुबह अपने होने का सबूत मांगती है। और अंत में बस आप लोगों से इतना ही कहना चाहूंगा कि आप लोग अंधेरे को हराते नहीं हैं, बस आंखों में थोड़ी सी सुबह रख देते हैं और यकीन मानिए इतनी सी रोशनी जिंदगी के लिए काफी होती है। आप सबका बहुत बहुत धन्यवाद। थैंक यू।
Dr. T.P. Lane sir has already told that Gujarat and Maharashtra will act as a single unit as far as the AIOS is concerned. And so I will also request all Gujarat members or AIOS members to remember that Gujarat and Maharashtra, we are working as a unit. So we'll vote in favor of Maharashtra and Gujarat both together. And also those who are coming far away, all my friends from all over India. So we will vote in favor of these members, those who have traveled from such a far distance and to attend our conference. So we'll vote in favor for all national faculties as well as Maharashtra and Gujarat. Thank you. Thank you so much.
Thank you so much, sir. I would like to tell all the local organizing committee members to stay here. We will have a group photograph after the inaugural ceremony, along with all the felicitation renowned ophthalmologists of the Gujarat. Every year, we arrange all Gujarat Ophthalmological Cricket Tournament. This was the 5th All Gujarat Ophthalmological Cricket Tournament, and I would like to invite the runner-up team, Ahmedabad Ophthalmic Society, with the silver cup. like to invite Captain Dr. Bhavi Jala and Dr. Ashish Saxena sir. And if their team members are there in the crowd, they can join the stage. I'd like to invite dignitaries and judges, Jagdish Rana sir, to present the silver cup to the runner-up team. Now I'd like to invite the winner team with the golden cup, and this is not the first time. Consecutively, 3 times they have won the hat-trick for the win in the All Gujarat Ophthalmic Cricket Tournament. North Gujarat Cricket Captain Dr. Mugresh Chaudhary and his team, please join the stage for the golden cup. Run, 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 run. So as you run on the ground. They just look like doctors right now, but on the field, they are fabulous players. Big round of applause for the hat-trick win. Thank you, everyone. On behalf of Local Organizing Committee, AGS 2026, I would like to thank our chief guest and all the local organizing committee members to join the stage for the group photo. Please join the stage. All the organizing committee members, Dr. Divyang Brahmbhatt sir, Dr. Hitesh Ramanuj sir, Dr. Mehul Shah, Dr. Jigish Desai, Dr. Narendra Singh Verma, Dr. Arun Tyagi sir, Organizing Secretary Parth Bhaumik and Mehir Patel, Joint Organizing Secretary Mohak Shah, Dr. Gaurav Mehta, Akash Patel, Aditya Desai, Sahil Vasavda sir, Ashish Bojak, scientific committee members, all who are present in the audience, please join the stage. Dr. Jignesh Shah, Dr. Dhaval Rajpura sir, Dr. Chirag Goyal, Dr. Monica Jethani, Dr. Jignesh Goshai, Jitendra Jethani sir, Dr. Manvi Gajjar, Dr. Alpesh Rajput, Dr. Saloni Shah, Dr. Amit Sanghvi, Dr. Hiran Solanki, Dr. Harsh Shah, Dr. Murugesh Chaudhary, Dr. Sanjay Goyal, Dr. Jignesh Jethwa, Dr. Rakesh Patel, and Dr. Rishi Desai. Please join the stage for the group photo. They have worked very hard and tirelessly throughout the so many days, last few months we can say. So let's celebrate the moment and cheer for them. Thank you so much, everyone. I'm extending my gratitude and thanks to our chief guest, Dr. Amar Agrawal sir, Dr. T.P. Lane sir, Sri Hasmukh Patel, our guest of honor, Dr. Neeraj sir, Dr. Devendra sir, for sparing the time with us and give us a valuable insight. Thank you so much, sir, on behalf of whole organizing committee.
I would like to thank Honorable Secretary of AGUS, Dr. Jagdish Rana, sir. He's really kind of here. Actually, he wanted to be at home because it's his birthday today and he wanted to spend with my kids. But this is his responsibility and he took...
We have a group photo with all the dignitaries on the dais. One last photo, sir.
Hasmukh sir, just a minute. We'll cut a cake for him. Just 2 minutes. पहला मंगाई दीजिए.
Birthday song. All the faculties can come close to the stage. They can also join the celebration. Please, sir. Ma'am, please. This will be the most memorable birthday for Dr. Jagdish Rana, sir.
Happy birthday to you. Happy birthday to you. Happy birthday to Sumi. Happy birthday to you. बार बार दिन ये आए, बार बार दिल ये गाए, खोजिए हजारों साल ये मेरी है आरज़ू. Happy birthday to you. Happy birthday to you. Happy birthday to you. बेकरार हो के दामन थाम लो मैं किसका. बेकरार हो के दामन थाम लो मैं किसका. क्या मिसाल दो मैं तेरी नाम लो मैं किसका. नहीं नहीं ऐसा हंसी कोई नहीं है, नजर रुक जाए बेमिसाल जो कहलाए. खोजिए हजारों साल ये मेरी है आरज़ू. औरों की तरह कुछ मैं भी तो आज लाता. औरों की तरह कुछ मैं भी तो आज लाता. मैं तेरी हंसी में.
Thank you so much, everyone. I extend my gratitude on behalf of LOC to Dr. Vishnu Patel, sir, President, sir, along with all the national faculties and local faculties and renowned ophthalmologists of all the Gujarat to join us for the ceremony and taking out time from the busy schedule. All renowned and senior ophthalmologists for accepting our invitation for felicitation. I would like to thank all local organizing committee members for working tirelessly for months to make this event a grand success. The most important part of any conference, our beloved delegates and AGOS member for registering tremendously and to this number to make this event a successful one. I would like to thank our trade partners for supporting us and taking participation each and every time for the conference. Thank you so much, all the trade partners. I would like to thank EKA Arena Club management team, Mr. Hardik Bhai and his team, supported us for all the requirements. I would like to thank Jitendra Bhai from Connex Craft and his AV team for providing flawless scientific session without a single glitch. Big round of applause for the AV team. I would like to thank Mr. Sai and Dhanlaxmi and their team for providing flawless registration process for the summit. It was very smooth. I'd like to congratulate and give my thanks to Sun Pharma to arranging all the transportation service for all national faculties. Thank you so much.
I would like to thank our drone training partner Sanskar Dham for this, and I would like to thank our YouTube live partner Deepak Bhai, and today's photographer from my childhood. I am seeing him taking my photos. Bhargav uncle, thank you so much for coming here.
I'd like to thank Mr. Kirat Sukla and his team for arrangement for the gala night that we are going to witness very soon.
I will request all national faculties, please, I will request all national faculties to have a group photo together at the end. All national faculties, please sit, we'll have a group photo together. We'll have vote of thanks, then we will have a lucky draw for our AGOS member, then we will have a national anthem, and then we will have a group photo. So please be quiet. So after vote of thanks, there will be a lucky draw, and then national anthem. So all national faculties are requested to Dr. Parikshit Gopte sir, Dr. Satish Sinha sir, please be quiet and have a seat. Dr. Jabdi Kankaria sir, બેસો સાહેબ હજી ફંક્શન ચાલુ છે, પ્લીઝ બેસો. ડૉક્ટર મિહિર પટેલ, બધાને બેસાડો, આપણું ફંક્શન હજી ચાલુ છે. ડૉક્ટર રાજન ગુપ્તા સર, પ્લીઝ બેઠો. ડૉક્ટર અરવિંદ મોરિયા, आप बैठिए प्लीज़. डॉक्टर विनीता रामनानी, आप बैठो प्लीज़, बैठो. अभी फंक्शन चालू है, अभी ख़त्म नहीं हुआ है, बीच में बर्थडे के कहाँ से आ गया पता नहीं. तो वी विल हैव ए वोट ऑफ थैंक्स. आफ्टर दैट वी विल हैव ए लकी ड्रॉ सेशन, देन वी विल हैव ए national anthem, and after that we will have a group photo with all national faculties. Please bear with us. Thank you.
So the most awaited moment of the conference, a lucky draw. Finger crossed for everyone, and wish you all the good luck. All trade partners are here. Trade partners, Okay, we will call them later. Okay, so we are proceeding with the delegate lucky draw.
First lucky draw is for Philips True Wireless headphones. We are announcing the registration number, so kindly note your registration number for the reference.
This time we have changed the format.
296.
Find the number 296. If you are there, raise your finger. The number has been written on your badge. The last 3 digits or 2 digits are your lucky number. Remember that. Below the QR code.
Dr. Sajni Shah, it's 296. Kalpit Bhai, Sadni Ben.
Again?
नाम लिखना है को एक ना ना क्यों Next is for the Protonic power bank, 10,000 milliampere.
179.
Dr. Abamod. Big round of applause for Abba madam, please. She's winning Portronics 10,000 mAh power bank with inbuilt data cable. Last time she won the mobile and now power bank. For that mobile, she won the power bank. Yes. Everyone, please check your registration number. It's there on your badges. Yes. Next is for the same power bank. Fast charging. 26. Dr. Neha
Shah.
Yes. Everyone, please cheer. It's a good thing and bad thing. Now she's out from the line of mobile phone and laptop. Yes. Sorry. Now, next is car charger with inbuilt data cables. A fast car charger.
301.
डॉक्टर गौतम पटेल, ये लगाने से कार भी फास्ट चलती है. Now it's for SanDisk power bank, SanDisk pen drive, OTG pen drive, 32 GB.
415.
Dr. Hardik Kalaria, he's there. नेक्स्ट सीटी गाड़ी लो. Next one is for same pen drive.
Three two six.
लो.
326.
Shashank Shah. Dr. Shashank Shah.
Dr. Shashank Shah. He's there. No. Acha.
Captain of Surat, Shashank Shah.
Next is same 32 GB SanDisk pen drive with OTG.
336.
No. He's not there.
He- 253.
253.
Bharat Shah.
Dr. Bharat Shah. He was there. Yes, he was there. He was there. Yes. Now next one is fast car charger.
32.
Dr. Arjun. He's not there. Next one, sir.
$76.
Hitesh Vyas. Hitesh Vyas, sir.
Dr. Hitesh Vyas.
Copy this. Thank you. Congratulations. Photo.
299.
It's for same car charger. 299. Dr. Dhaval Modi. Yeah, he was there. Next one is for the same car charger. No.
One two one.
121. Dr. Jas Bhavisi. Yes, he was there.
Okay.
Now the most awaited mobile phone. It's a Galaxy M07 mobile phone. It's with 64 GB RAM.
I'll invite Dr. Satish Sinha
4 GB RAM and 64 GB storage.
For bumper lucky draw today. Mobile phone. Let us see who is lucky with your hands.
अंदर से बाहर से जहाँ से एक कोई भी
This is for the mobile phone.
Two
220. Dr. Shilvi N. Shah.
Dr. Shilbi Shah.
No, she is not there.
19.
19.
He's here.
Dr. Razak Mansuri. ना ये तो अच्छा एक तो खा लेगा मोबाइल फोन पर नहीं आता
चार के हमको
नाम रखिए कहीं से पहला फोन से
I would like to request all of you to stand at your place for our national anthem. And then we will have a group photo with all the national faculties. AV team, please.
मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल गंगा विंध्य हिमाचल यमुना गंगा उज्जल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
All the national faculty, please come on the stage for our group photo. Thank you so much, everyone. Now we'll proceed for gala dinner on the top floor. That is on the terrace 7th floor. There will be a very interesting and good event by Mr. Kirat Shukla and his team. Please join us for the gala dinner. Thank you so much, everyone. The 7th floor entry will be from the opposite wing. So everyone has to go to either basement or take the opposite side of lift to reach to the 7th floor.